Good morning, everyone. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy. And on behalf of Duke and the FDA, I'd like to welcome you all to our public meeting on leveraging clinical pharmacology to optimize drug development for non-alcoholic steatohepatitis, NASH, and cholestatic liver disease, which we are convening under a cooperative agreement with the FDA. You can read more about my background on my website, but today we'd like to focus on this significant unmet need related to the prevention and treatment of NASH and cholestatic liver diseases. Despite the increasing prevalence of NASH and the potential for NASH to cause severe liver-related morbidity and mortality, there are currently no drugs approved for its treatment. Recognizing that this set of conditions has a variety of etiologies and natural history and pathophysiologies, that is a major impediment to ongoing drug development, the FDA released 2 draft guidances to assist industry in the clinical development of drugs for the treatment of NASH with liver fibrosis and with compensated cirrhosis. And we are going to build on those documents and the related interests from researchers, industry, and other stakeholders in this important area of unmet need today. Throughout the day, we're going to have a series of presentations, reactant panels, and moderated discussion surrounding clinical pharmacology approaches to support drug development for NASH and cholestatic liver disease, which are these areas with significant unmet needs. Now, before we begin, I wanted to go over a few considerations for the meeting and some housekeeping notes. Then I'm going to turn things over to Dr. Patrizia Cavazzoni to offer some opening remarks and to introduce Dr. Shirley Say, who is going to provide an opening presentation. The goal for discussion today is to gather stakeholder input on the availability and utility of clinical pharmacology tools to support drug development for chronic progressive liver disease. This is a timely discussion as the pace of development for drugs to treat NASH, PSC, and PBC is quickening, and also as some experimental drug development programs, especially in the NASH space, are experiencing late-stage failures. We and our colleagues at FDA hope to provide a forum for open discussion and an opportunity for stakeholders to strategize about ways to overcome some of the challenges associated with clinical trial design and conduct for these indications. Before we begin, here are the housekeeping items. At several points during the day, we're going to invite groups of presenters and panelists to provide some remarks and engage in discussion about different aspects of drug development for NASH and cholestatic liver disease. We have a packed agenda today, and to make sure we get through all of that material and are able to wrap up on time, it's pretty important if all of our presenters could keep their remarks between the amount that we've scheduled, around 13, 14 minutes or so, and if our reactants could provide approximately 5 minutes of remarks before the open panel discussions. We have a couple of timekeepers, Sarah and Nick, right there in the front. They're in the front row. They're going to have signs that they'll hold up with time prompts during the day, so please do keep an eye out for those. And so that we can keep track of who wants to speak during the panel discussions, I want you to stand up the table tents if you've got a comment to make. And then at the end of each session, we're going to invite the participants in the room to join in a period of moderated discussion. If you'd like to make a comment during this part of the session, please approach one of the standing microphones that we have set up here in the room. And again, by keeping our comments concise, we're going to try to get to as many perspectives as possible. I'd like to note that in addition to those of you who are joining us here in the room, thank you all for being here today, we are broadcasting this meeting virtually on the web, and we have about 500 people who are registered to join us that way virtually. So welcome to those of you who are joining us online as well. And we're going to be making a recording of the meeting available on the Duke-Margolis event website and YouTube channel after the conclusion of today's event. Because we are broadcasting on the web live today, We do want folks in the room to make sure that you are using a microphone and it's activated when you're speaking, so that all of our web participants can hear you as well. If you're joining by webcast today and you'd like to ask a question during our discussion sessions, please do email your question to the number that we have on the screen up here, liver.disease@duke.edu, liver.disease@duke.edu, and we'll pass it along to the session moderator. We're also going to be tweeting about today's event using the hashtag NASH Innovation through our account at Duke-Margolis, so hashtag NASH Innovation, and we'd invite you all to follow us and contribute to that conversation as well. A couple of other logistical issues. We have several breaks scheduled throughout the day. We're going to break for lunch from about 12:15 to 1:15 p.m. Lunch is on your own today. There are a number of nearby options, including in the handouts and that are in your folders if you are here in person. And you should feel free to bring back anything left over for the afternoon session at 1:15. And finally, as I mentioned briefly at the outset, the Duke-Margolis Center for Health Policy is convening today's meeting in cooperation with the FDA. This is not a federal advisory committee meeting. While we are very much interested in input from a wide range of perspectives on this important topic, we won't be following advisory committee procedures like taking a vote at the end of the meeting and reaching formal consensus, etc. The meeting will be a success if there's a good exchange of a lot of ideas and open discussion about them. So we're very pleased that you're able to join us today, and we anticipate an interesting and productive discussion on this very timely set of topics. And so to kick that off, I'm very pleased to introduce Dr. Patrizia Cavazzoni, who's Deputy Director of Operations for the Center for Drug Evaluation Research at the FDA. Patrizia is going to provide opening remarks to set the context for today's discussion and tee up a more detailed presentation from Dr. Shirley Seo, who's the Director of the Division of Cardiometabolic and Endocrine Pharmacology in the Office of Clinical Pharmacology at FDA. So we'll be hearing from Patrizia first. Thank you very much, Patrizia.
Good morning, everyone. I'm very pleased to be here. I understand that we have approximately 600 attendees who are joining us virtually, so it's great to see that there is such a high level of interest in this area. The incidence of NASH is increasing, and it's quite clear that NASH is going to be a major public health issue. And as you heard from Mark, what is in stark contrast is the fact that there isn't any treatment for NASH, despite the fact that this issue is becoming more and more prominent in public health, and despite the fact that there has been considerable investment in R&D in this space. So why are we not there yet? Well, there are some very unique challenges when it comes to developing drugs for NASH. The first one pertains to the identification of patients, as well, and in particular, the absence of clear biomarkers or histological criteria that can identify patients with non-alcoholic fatty liver who are at risk of progression for NASH. And without being able to do so, and without developing these criteria, obviously, we're not going to be able to identify and enroll those patients who are still early in their disease progression. The second major challenge is the lack of success so far to develop non-invasive methods for the diagnosing and staging. And we are still at the point where liver biopsy is the way to diagnose this disease and stage it in late phase development. And we can well, envision that first and foremost, this is not a very practical way for patients to be enrolled in trials, and it is going to pose some barriers when it comes to adoption of these medicines when they are in the market. sorry about that. Let me just go back here. The inclusion of appropriate study population is also a challenge. We know that there's a spectrum of a presentation. There's this disease presents at very different stages. And so, as I mentioned in my earlier on, we need to find some ways to identify the right patients to be studied. And last but not least, which is going to be the focus for today, is there is the fact that there has been disappointment in the translation of early phase results to late phase success, and we have seen a number of failure in what seem to be very promising drugs in early phases. Just would like to tell you a little bit about some of the CEDAR initiatives that are really meant to spur the development of medicines through regulatory review, through our policy development, research, and strategic engagement. And the Office of Clinical Pharmacology is very much front and center in these initiatives, which are really aimed at accelerating the development of promising drugs, and in this case, drugs for NASH, while at the same time finding ways of de-risking these challenging and costly development programs. And some examples of initiatives that CEDAR is working on are the 21st Century Review Initiative, the Critical Path Initiative, where the Office of Clinical Pharmacology is very involved. As you have probably read from communications over the past couple of months, we have rolled out a major initiative to modernize our new drug regulatory program that touches all of the groups and offices that are involved in new drug review, including the Office of Clinical Pharmacology as well as the Office of New Drugs. We are obviously relying in a scientific public-private partnership and consortia to continue to advance this regulatory science, and this is a good example of such initiative. So the Office of Clinical Pharmacology, as I mentioned earlier, is really at the center of our efforts to identify innovative solutions to support innovation and advance CEDAR's mission and initiatives. Some of the examples of these modalities include model-informed drug development, which is a program that is increasingly more and more successful. And this program is really meant to find model-based approaches to accelerate drug development and be able to obviously making sure that we find ways to avoid unnecessary studies and clinical trials when model-based approaches could actually replace those. We are also very involved through the Office of Clinical Pharmacology in applying new technologies such as artificial intelligence, machine learning, and in particular applying this technology to the harnessing of real-world evidence and real-world data. And we're very involved in leveraging collective actions through, for instance, the CPAT initiative and so on, to exchange ideas and brainstorm and gather input from thought leaders on how we can advance innovation. Workshops such as this one are very critical to our ability to brainstorm and discuss these scientific topics. They provide an opportunity to engage thought leaders and create dialogue on the latest scientific methods, again, to try to find solutions to complex problems such as this one. So for today, we hope that you will have a very productive discussion throughout the day. The overarching goals of this workshop are to brainstorm on creative solutions to address the pressing challenges to develop drugs for NASH. We want to engage in two-way scientific dialogue to share, educate, and inform and we look forward to very robust discussions in the panel sessions. And ultimately, what we want to do is to drive and expedite and de-risk the development of drugs for this increasingly concerning public health issue. Thank you. I'm going to now turn over to Shirley So, who will provide an introductory presentation.
Good morning, everyone. It's my distinct pleasure today to be here and also to help represent the Office of Clinical Pharmacology at the FDA. So our committee has been working for many months in conjunction with the Duke-Margolis team in preparing today's workshop. I'm fully confident that it's going to be a fantastic discussion. We have many great speakers and presentations teed up for everyone. And so I wanted to give a little bit of an introduction about my experience at the FDA. Back in the early 2010s, I was involved in the antivirals area. When the treatment for hepatitis C was dismal at the time, we were seeing a sustained virologic response rate of around 40% until 2011, when the first phase of oral direct-acting antivirals were approved, and the sustained virologic response rate increased to around 70%. Shortly thereafter, I would say about 3 years later, we got to a point where we were nearly curing hepatitis C with close to 100% SVR. That was a really tremendous era for hepatitis C, and I'm hoping that we're on that cusp right now with NASH as well. Today we'll be covering many pressing issues as they relate to the development of treatments for NASH, and hopefully we'll advance thoughtful conversation around this topic. This is my disclaimer. So we've all seen the statistics. NAFLD, or non-alcoholic fatty liver disease, is the most common chronic liver condition in the U.S. currently. As most patients are asymptomatic in the initial stages, NAFLD can progress to NASH and other serious complications without identification and early treatment. I've seen many numbers about this, but up to 25% of all adults in the U.S. have NAFLD at some stage, and 20% of those adults have NASH. And then I recently read that NASH is now the leading cause of liver transplant in women and the second leading cause in men. Yet no approved treatment currently exists in the U.S. This is a simplistic diagram, but it really highlights why we're talking about clinical pharmacology and NASH today. There are many complexities to the liver, as we know, but it's here today we're talking about it as both the pharmacologic target as well as the clearing modality. We have drug metabolism and transport, liver blood flow and drug distribution, as well as synthetic function. And as those things all change in the liver, they will affect drug disposition. But ultimately, our goal is to reach efficacy or healed liver with increased function. This is a framework published by Vicini and Van de Graaff, which nicely depicts a holistic approach to building up the confidence and proof of concept, and how we can use the building blocks of clinical pharmacology to get there. I really like this diagram. It was published back in 2013, and it really is a two-pronged approach. So if you really break it down, we really need to know the full characterization of the drug compound. This includes its pharmacokinetics and pharmacodynamic action. So that will entail target exposure, target engagement, as well as the modulation of the target. On the other side, we have the pharmacologic target itself. We want to make sure this is fully characterized as well. So this will involve systems pharmacology, which entails pathway modulation, pathophysiological regulation, as well as modification of disease. So we want to keep this all in mind today as we talk about each of these components, and different speakers will be speaking to different aspects of this approach, but we really need to make sure that we're encompassing all of these items and concepts in order to really put us in the best position for success. Some general considerations for today. As we all know, NASH is a silent disease. We need better early diagnostic tools. It would be great to have some predictive biomarkers to better forecast the benefit of pharmacologic therapy as well. The targets Are we identifying the appropriate targets at the appropriate stage? Should combination therapy be the mainstay, maybe attacking more than one target at a time? Dose of the selected therapeutic agents. So really this is in our wheelhouse, right, for clinical pharmacology. Are we giving the right dose in all cases? Is it being given to the right patient population at the right time? How can we use clinical pharmacology to poise development for the best chance of success? I see our involvement in all stages of drug development. Starting even at the preclinical stage, we really need to think about species translatability. Is the appropriate characterization of target engagement really being performed? Next, with early phase studies, not just phase 1, but also phase 2, are they well designed and timely in order to inform phase 3? That's going to be a big topic of discussion later, and how we can really translate the success of phase 2 into phase 3 results. And then at the top, of course, we have the efficacy trials themselves, ensuring that the right population is getting the right dose and or the right drug combination are being studied. So I don't think I need to tell this audience that data on hepatic impairment is really critical for us. Since we're really interested in the function of the liver, and we know how complex it is, and I've pasted together all different processes in the liver, not really trying to be readable here, but just to illustrate how obviously complex the liver is. So it's really vital to study individuals with hepatic impairment, particularly for a disease that impacts the liver. This represents really a non-trivial subset of the NASH population. And hepatic dysfunction can affect either safety or efficacy or both. It depends on the underlying mechanism for the change in drug disposition. This may change our risk-benefit calculus in the end. So really getting this information as early as possible is ideal. So as I mentioned before, some of the areas of potential challenges and opportunity present themselves here, where we have no single preclinical model that really demonstrates full translatability to humans as of now. So really we need to find some relevance, translatability of different animal models, maybe more than one, to humans. Is the right pharmacological target being engaged at the right stage of disease? We have the PPAR agonists, the FXR agonists, and so on and so forth. We just need to make sure they're being engaged at the right time. And biomarkers at all stages. So I view this as the diagnostic aspects, the prognostic, as well as at the end, the surrogate endpoints that can be predictive of long-term effect. Biomarkers, when we speak about it in general, really encompasses all different stages, and I see them as being grouped into those 3 areas. So there's some good news and bad news, and these are some lessons learned from when I was involved with hepatitis C drug development. The good news is the liver is healing. So we have recovery of activity, enzyme activity, transporter function, protein synthesis, and increased blood flow. These are all good things. What's the semi-bad news about this? So this is a dynamic process, right, that occurs during treatment, and it's really dynamic. It goes back and forth. This, as the liver is recovering function, this could present challenges for predicting drug disposition and continued dosing. This is just something I want to present as a consideration, and how this could have implications on how we view the translatability of plasma concentrations to intrahepatic concentrations, and how might this affect drug interactions as we go forward. So this will be my final slide, but really kind of a checkbox for us as we compare and how we can think about leveraging experiences from another liver disease, hepatitis C. We have a lot of commonalities. So far, both hepatitis C and NASH have complex pathophysiology. I think we can all agree on that. Hepatotoxicity of a liver-targeted drug is a concern, so we know that is also true for both diseases. What about targeting multiple pharmacologic mechanisms? That led to success for hepatitis C. We saw SVR rates very, very close to 100% when this occurred. Could there be a need for targeting multiple mechanisms for NASH? The healing the liver for hepatitis C actually didn't impact dose really because of the short-term treatment. By the end, we were looking at 8 weeks of treatment for hepatitis C. But with NASH, if we are possibly looking at longer-term treatment, might this affect the dose that will it need to evolve over time with long-term treatment? And finally, the extent and the types of drug interactions were affected by the healing liver in the hepatitis C arena. Could this also occur with NASH treatment? These are all considerations I think we need to think about and talk about today, which I think we are in some of the later sessions. And finally, this workshop wouldn't have been possible without the hard work of the organizing committees at the FDA, as well as the Duke-Margolis team. And I didn't list all of their names because I was very afraid of missing somebody. So these are all the folks at the FDA who've helped organize it. And I'd also like to thank all the speakers and panelists today who've taken time to be here with us and contribute to the program. And also special thanks to Dr. Assam Zane, who is the office director at OCP, and also Dr. Patricia Cavazzoni, who is here today. She's very busy. She actually has to leave very soon. So thank you all for your attention.
All right, thanks. I'd like to thank Dr. Cavazzoni and Dr. So for a couple of things. One is laying out both the big picture and the set of issues that we are going to try to address today with all of your help. And the second is for doing it in a very concise time frame, so we're actually running slightly ahead of schedule. Now, with that in mind, I'd like to ask our panelists for our first session to come on up to the stage while I introduce them. This is our session 1 on liver disease pathophysiology and the impact of liver dysfunction on pharmacokinetics, pharmacodynamics, drug safety, and efficacy. And we're going to start with presentations from several speakers, so come on up. Dr. Manal Abdelmalik is a tenured professor of medicine in the Division of Gastroenterology and Hepatology and the director of the Non-Alcoholic Fatty Liver Disease Clinical Research Program at Duke University. Manal, thank you for joining us. Also, Kim Brower is the Associate Dean for Research and Graduate Education at UNC Eshelman School of Pharmacology and the Keenan Distinguished Professor in the School of Pharmacology and Curriculum in Toxicology at the University of North Carolina at Chapel Hill. Thank you for being with us. And Ansuk Kim is Clinical Pharmacology Team Leader in the Office of Clinical Pharmacology at FDA. Dr. Kim is responsible for gastroenterology and hepatology products there. Our three speakers, Drs. Abdelmalik, Brower, and Kim, will speak broadly about the pathophysiologies of NASH and cholestatic liver diseases, the impact of these diseases on drug disposition and pharmacokinetics, and key clinical pharmacology-related questions that may arise during drug development in these areas. After the presentations, we're going to open this up for comments and questions from all of you. So if you do have questions or comments, please go up to the microphones at that point, as I mentioned earlier. Again, this is to help us frame the issues for the day, the underlying science that we'll then turn to in the subsequent sessions. So to begin, Dr. Abdelmalik, I'll go to you first. Thank you.
Well, I'd like to thank the organizers, both at the FDA and Duke-Margolis Center of Health Policy, for the invitation to be here. I think this is just an absolutely fabulous forum. I have many disclosures. I'm broadly involved in the landscape of therapeutics and discovery in the field of NAFLD and NASH. So in the context of my presentation, I have one overarching goal to accomplish in the next 10 to 15 minutes, and it's to lend you an overview for the discussion of NAFLD and cholestatic liver disease, with an overview of the spectrum of this disease, maybe a little bit about the epidemiology, the cohorts at risk, the diagnostic approach that we take as clinicians, so that we can embark on a discussion leveraging the clinical pharmacology to optimize drug development. My talk will not encompass any discussion of biomarkers or any discussion of therapeutic targets and the treatment landscape, as we will discuss that more in depth in session 2. So as has already been pointed out, the spectrum of NAFLD and NASH is one that is very dynamic, where patients can go from a completely normal liver to the inclusion of triglycerides within hepatocytes, and then transition to the more ominous stage of NASH, which is the manifestation of necroinflammatory injury with balloon swollen hepatocytes that confers the risk of fibrosis progression. In the dynamic phase of the study, patients can actually flux in and out of different stages based on various interventions, even as much as diet and exercise. And we've come to learn that even fibrosis can regress, but certainly when patients develop very well-established cirrhosis with complications of end-stage liver disease, regression to normal is virtually impossible. And this disease is one that involves many, many factors that may even start as early as in utero, with changes in the epigenetics where obese or diabetic pregnant mothers can infer a signature that lends a newborn child the increased risk of developing NAFLD and NASH or any complications of metabolic syndrome over the lifetime, coupled with genetic predictors such as PNPLA3 as just one of many genes that may lend increased risk, and a milieu of environmental modifiers, smoking, exercise, diet, sedentary lifestyle, obstructive sleep apnea, in addition to infectious modifiers such as the gut microbiota that can infer then variations in the natural history of disease or the expression of disease phenotypes that ultimately lead to what we care about, which is negative clinical outcomes, how patients feel, function, and survive with complications of end-stage liver disease and portal hypertension. And has already been discussed, this is an endemic disease. This is not isolated just to the Western world. There have been reports of NAFLD having a prevalence of anywhere between 20 to as high as 30-35% globally, with the understanding that approximately 6 to 8% of patients with NAFLD may have a more ominous progressive form of NASH. So the progression of NAFLD and NASH is one that spans decades, and certainly one that will lead to cirrhosis, and as already been mentioned, is currently now the leading indication for liver transplantation, with the ominous rapid rise in hepatocellular carcinoma in this country being attributed to the obesity epidemic and NAFLD. There are certainly negative predictors: the development of diabetes or the presence of diabetes, obesity, genetic factors with unique gene polymorphisms, increased age, the consumption of social alcohol use, habitual alcohol use, and a sedentary lifestyle, while we've come to recognize favorable factors that may infer a protective response against NAFLD and NASH, including coffee consumption, routine physical activity, a Mediterranean-style diet, which is devoid of industrialized food products and high fructose corn syrup or hydrogenated fats, or even increase in dietary fiber. Of concern is this incremental increase in mortality that correlates with and pivots up exponentially once patients develop stage 2 or higher fibrosis, so that injury capitulates worse injury, particularly as it translates into necroinflammation and fibrosis. While several decades ago we conceived of NAFLD and NASH as a benign disease, there is certainly data that suggests, compared to the general population, that the presence of even a fatty liver incurs a slight decrease in survival compared to the general population. And likewise, not only the presence of NAFLD or NASH, but also the overall survival that incrementally decreases with higher stages of hepatic fibrosis. And again, we could see this capitulation of stage 2 or higher significantly increasing mortality when compared to stage 0 or 1 hepatic fibrosis. So risk stratification is a challenge for clinicians because our task amongst these 100 million patients walking around with fatty liver disease is going about risk stratification in the absence of well-validated, highly sensitive, highly specific biomarkers. However, as clinicians, we look for risk factors that include the obese state and the presence of elevated liver enzymes, 3 or more risk factors of metabolic syndrome, with a lot of attention being put on other manifestations of end organ disease, particularly diabetes, in patients with metabolic syndrome, and with the understanding that there are certain ethnic genetic variables, particularly that may infer higher risk in unique cohorts, such as those that are Hispanic or Asian, to develop NAFLD and NASH at lower BMI thresholds. The presence of dyslipidemia, polycystic ovarian syndrome, where women may develop NASH at a much younger age, even with hepatic fibrosis, endocrinopathies, obstructive sleep apnea, and the genetic inference of a first-degree family member having NAFLD, NASH, or hepatic fibrosis. But when put together as a clinician, an age over 50, the presence of diabetes in a first-degree family member with cryptogenic cirrhosis occurs the strongest clinical predictor of the presence of NASH and fibrosis. And as you can see here, diabetes, both its risk on NAFLD and NASH is almost twofold higher than the general population with elevated liver enzymes, the presence of fat by CT, ultrasound, or even MRI. And this also holds true to the presence of hepatic and the prevalence of hepatic fibrosis, where patients with diabetes are nearly twice as likely to be detected to have higher levels of fibrosis based on serological biomarkers or even radiographic elastography measurements. So diagnosing NAFLD and NASH non-invasively, in clinic, I look for 3 or more risk factors of metabolic syndrome. Patients may present with very nondescript symptoms, vague right upper quadrant abdominal pain, but as already been mentioned, this is a silent condition. Hepatomegaly on exam, and by definition, patients must have little to no alcohol consumption to be even given the diagnosis of NAFLD. A bright liver on ultrasound, and the serologic absence of any form of chronic liver disease. Seronegative chronic hepatitis and true normal liver enzyme is less than 19 to 20 for a woman and less than 30 for a man. So the concern of advanced hepatic fibrosis or even decreased liver function in this population can be detected clinically when we see platelet counts drop to less than 150,000, low levels of serum albumin, maybe an increased bilirubin, the presence of a calculated MEL score greater than 12, FibroScan transient elastography greater than 12 kilopascals will infer high risk for advanced hepatic fibrosis. FIB4 score, which we'll get into later today, NAFLD fibrosis score greater than 0.6, or an MR stiffness measure of greater than 3.6. So with those modalities, we still are left with the absence of therapeutic options, short of diet and exercise, and now therapies that are emerging but can't be broadly applied. And so the same challenge with NAFLD and NASH we see in cholestatic liver disease. This is a family of conditions. And so cholestatic liver disease includes hepatocellular cholestasis with drugs, antibiotics, certain genetic factors, maybe small bile duct injury that also can deal with drugs, infections, genetic conditions, and of course, large duct injury. So we stratify cholestasis both on intrahepatic and extrahepatic conditions. But as we've seen with NAFLD and NASH, there are both environmental sporadic cases, such as exposure to an antibiotic or a virus or even alcohol use in higher amounts, leading to alcoholic hepatitis, could lead to cholestasis, and pure genetic conditions such as mutations of the CFTR, Alagille syndrome, cystic fibrosis. But of interest is this middle range of PSC, and PBC, for which we see shared risk factors. Now, as you know, primary biliary cholangitis has been renamed as cholangitis as opposed to what we historically knew as cirrhosis. This affects, this is flipped. It should be women more than men in a prevalence of 9-to-1. Typically, it presents in age over 45 with an increased alkaline phosphatase and a GGT with or without elevation of AST, ALT. There are bacterial mimickers and xenobiotic chemicals that induce a PBC-like picture, if not PBC itself. And many of these patients are AMA positive, so the presence of an AMA confers the diagnosis without need for a biopsy. And the classic histologic picture is lymphocytic infiltration with the florid duct lesion and even granulomas that can be present. But the biliary tree is normal, and these patients do not typically have inflammatory bowel disease, but the symptoms of fatigue, pruritus, darkened skin, xanthelasmas, and even bone loss are prominent in these patients, potentially even with thyroid disease. The alkaline phosphatase is elevated alkaline phosphatase is the hallmark for biochemical abnormalities in PBC. Again, 90% plus will have a positive anti-mitochondrial antibody. But we only start to be worried about more advanced cirrhosis as platelet counts and measures of liver synthetic function decline. Now, what about PSC? While there are shared environmental risk factors, genetic, environmental, immune triggers, some interaction between the gut and the liver axis, as we see chronic ulcerative colitis as a prominent feature of this disease. So the gut microbiota likely plays a significant role, and the potential for stasis and toxic bile acids. So this condition tends to have a propensity for men more than women, also present at a younger cohort with onion skinning around the bile duct. Those with a dominant stricture may present as early as in their teenage years, again, alkaline phosphatase and GGT, but nondescript autoantibodies, potentially with only 20 to 50% having a p-ANCA positivity. Relapsing and remitting diseases that require biliary stenting and potentially even consideration of colectomy. We go through diagnostic algorithms looking at alkaline phosphatase and GGT, exclusion of drug-induced liver injury when patients present with cholestasis. If we find a suspected drug, we stop. We've established the diagnosis. If we find an AMA positivity, we could stop because we've established the diagnosis of PBC. And if that is negative, we can go on to MRCP or EUS. If we see biliary stricturing, we stop. However, very rarely we need a liver biopsy to ensure that there's no sarcoidosis or other immune overlap syndromes, and ultimately we are not using genetics in clinical practice. If all of these are negative, we observe, hoping that patient disease will regress. There are hurdles for the landscape of NASH and cholestatic liver disease: the lack of diagnostic and prognostic biomarkers, limited pharmacologic therapies, and the lack of tailored approaches with pharmacogenetics to identify which therapies should be applied to which cohorts of patients. However, if we can overcome these hurdles, I think there's a promising future ahead for both of these diseases. Thank you.
So I'd like to thank the organizers for the invitation to participate in this public meeting today and to lead off on the discussion about what we know regarding changes in hepatic transport proteins in patients with NASH and what implications that may have for alterations in drug disposition, as well as perhaps efficacy and safety. And these are the disclosures that I would like to provide. So my focus will primarily be on hepatic transport proteins. It's actually rather surprising with our sophisticated knowledge of drug transporters that we have a rather limited understanding of what happens to these proteins with respect to NASH and other diseases. We will be discussing a couple of different probes that we have used to study the function in patients with NASH of these transporters. And I also want to spend a few minutes talking about the increases in bile acid concentrations in patients with NASH and the impact these have on hepatic transport proteins. And I think that this raises one of the issues we have with the preclinical models where the bile acids are quite different. And then what implications these changes have in the drug development process. So just to make sure that we're all on the same page with respect to what we are talking about regarding these transport proteins, depicted in blue on this slide are uptake transporters that facilitate the movement of drugs, metabolites, as well as endogenous compounds such as bile acids into the hepatocyte. And transporters that we will be specifically focusing on for this morning's discussion are the organic anion transporting polypeptides, that is the OATPs. Once inside the hepatocyte, drugs and metabolites may be excreted into bile, depicted here in purple, these transport proteins. And of course, the bile salt export pump moves bile acids into bile. We will be primarily discussing the multi-drug resistance associated protein MRP2, which appears to be impaired in patients with NASH. Less well studied, but very important in NASH, are these basolateral efflux transporters, MRP3, MRP4, and importantly, OST alpha beta. These efflux transporters appear to be safety valves that are upregulated in cases where there's impairment in the biliary excretion transporters. And this, again, may impact systemic exposure of substrates for these transport proteins. When we started work in this field, what was known by Western blot analysis is, and this was based on liver tissue from patients with NASH published by Nate Charrington's lab, an increase in expression levels as depicted here for the OATP1B1, but a decrease in protein expression for OATP1B3. So it's a little bit difficult to predict what impact that might have in patients that would be substrates for these transport proteins. What was more clear is that there's an increase in protein expression levels for these efflux transporters, the MRPs, as well as P-glycoprotein and breast cancer resistance protein. However, when we look more closely at the protein expression level data, we note, especially for MRP2, that there's a significant component of the increased protein that is in the unglycosylated state. Now, glycosylation of transporters in the case of MRP2 serves like a zip code that tells that protein in the hepatocyte where to go, to be localized properly on the canalicular membrane. And as you can see here, relative to the normal state, where staining of MRP2 is distinctly on the apical canalicular domain, in the fatty infiltration, most severe NASH form, we see mislocalization of the protein. So it appears to be not properly on the membrane and therefore would likely be less functional. So given the data with the OATPs and MRP2, we were interested in determining in patients with NASH the function of the uptake transporters and the efflux transporters. And to do that, ideally, we needed an imaging agent so that we could measure not only systemic exposure, but also hepatic exposure. And we chose technetium-labeled mebufotenin. It's used clinically as a hepatobiliary imaging agent with extensive liver uptake, about 98%, extensive excretion into bile with negligible metabolism and less than 2% of the dose excreted in the urine. It was also important that this imaging agent is taken up into the hepatocyte by the OATPs, 1B1 as well as 1B3, the two isoforms, and biliary excretion occurs via MRP2. There's a modest but small component of basolateral excretion by MRP3. We had done prior work in healthy patients, and based on PBPK modeling simulations, predicted that when in fact we had an impairment in MRP2 function, we would expect to see an increase in hepatic exposure of technetium-labeled mebufotenin, but not much of an effect in systemic exposure. And this slide, I think, nicely depicts the challenge, one of the challenges that we have in clinical pharmacology, that what we are measuring in the systemic circulation may not reflect the actual hepatocyte concentrations that we would be achieving. And that, of course, depends on whether or not the compound of interest is a substrate for the uptake and the efflux transporters. So the clinical study design is described here. It's a very small study. We enrolled 7 biopsy-confirmed NASH patients. These patients had a fibrosis score on average of 2, ranging from 1 to 3, but they were not cirrhotic patients, and 14 healthy subjects. And after attenuation correction, we positioned the subjects under the gamma camera, gave a 2.5 millicurie IV dose of technetium-labeled mebufotenin, and then collected blood samples over 300 minutes with continuous gamma scintigraphy imaging over the abdominal region. This work was published by one of my former graduate students, Isna Ali, and as you can see here, the liver activity data, the concentration in the liver versus time expressed as activity, is significantly increased in the NASH subjects, about a 2-fold increase in exposure, longer half-life than in healthy subjects. And surprisingly, also in the systemic circulation, we saw about a 2-fold increase in the initial maximal concentration of mebufotenin, and overall about a 2-fold increase in systemic exposure. So using this rich data set, we developed a 3-compartment model that best described the blood and liver concentration time data with a peripheral and liver compartment with biliary excretion as the sole route of elimination. And using a population PK modeling approach, you can see the model predictions for all of the individual subjects' blood and liver concentration time profiles. NASH was a significant covariate with this data set, and the estimated parameters stratified by disease here are shown. A significant, about a 2-fold decrease in the biliary clearance, consistent with this decrease in MRP2 function, which is what we would have anticipated based on the mislocalization of MRP2. And interestingly, we see also a 2-fold decrease in the volume of the central compartment for mebufotenin, consistent with this decrease in the uptake clearance of the mebufotenin, suggesting an impairment in OATP-mediated uptake. Now, we know that OATP1B1 is polymorphic, and that it might have been possible that some of our NASH subjects were low functioning in OATP. So we completed the genotyping study. As you can see, among our healthy subjects, we had 4 low or intermediate functioning OATP 1B1 genotypes. So there was a slight decrease in hepatic uptake of the mebufotenin because of that genotype. But look at the NASH subjects here. All of those subjects had normal functioning OATP1B1 genotypes, and yet their uptake clearance of the mebufotenin was significantly lower than the healthy subjects, and also of those low functioning genotype subjects. So very interesting data, I think very convincing that there's an impairment in uptake of the OATPs. Well, based on this data, where we had seen impaired MRP2 excretion and impaired uptake, we were curious about MRP3. We expected that to be increased, and to test this hypothesis, we examined the hepatic disposition of morphine. We know morphine is taken up by passive diffusion and also predominantly by OCT1-mediated uptake. It is metabolized by UGT2B7, which is known not to be increased in NASH. And then the glucuronide conjugates, the 3 and 6 glucuronide, are excreted back across the basolateral membrane into the systemic circulation for urinary excretion. All of the subjects we enrolled had normal renal function. In this study, we were also interested in looking at bile acid concentrations, and so the patients came in fasting. We took baseline samples, and we fed them a standardized diet. We measured serum concentrations of bile acids over a 2-hour period before giving the morphine IV and then measuring blood concentrations and urine collection through time. And these subjects also were fibrosis stage 1 and were biopsy-confirmed NASH patients. So we did not see any difference in the morphine concentration time profile, which was what we expected, but we saw, as depicted in red, a significant increase in the morphine 3 and the morphine 6 glucuronide conjugates in the systemic circulation. You can see the data shown here, and this is consistent with induction of MRP3, the increase in protein expression of this basolateral efflux transporter, which is responsible for moving many glucuronide conjugates from the hepatocyte where they are formed back into the systemic circulation. Questions have come up about the extent of enterohepatic recycling and the impact of NASH on enterohepatic recycling. And so we examined this using SimSip and taking the data from our healthy morphine subjects and then simulating the concentration time profile of morphine in the presence of enterohepatic recycling in the solid profile here, and with no enterohepatic recycling, the dashed profile. And you can see that this isn't a great example because the morphine glucuronide is predominantly excreted by MRP3 back into the blood, with relatively little going via biliary excretion back into the intestine for reabsorption of morphine. So we don't see a significant impact on this, the parent compound due to recycling. But you can see that when we incorporated the NASH-related transporter changes, that is a 50% decrease in MRP2 excretion and about a 2.5-fold increase in MRP3, we essentially see very little effect of enterohepatic recycling due to NASH, which is what we would expect. And in fact, we see that same difference, which is less in the NASH obese subjects with the glucuronide conjugate. I think it's well established that NASH patients have increased bile acid concentrations. You can see that total bile acids, as well as the glycolic acid and tarcholic acid bile acids, are increased in the systemic circulation. And there is a strong statistical correlation between the bile acid concentrations and NASH severity, as determined by the NAFLD activity score plus fibrosis, as shown here, statistically significant increases. And the more hepatotoxic bile acids are elevated in the serum of NASH patients, the chenodeoxycholic acid and the deoxycholic acid specifically. And note here that you see these NASH-related differences in the serum, but not in the urine, which would suggest that if we're trying to use the bile acids as a biomarker, we really need to be looking at these in the serum. Now, bile acids are master regulators, and we know that they are responsible in part for many of the changes that we're seeing in these hepatic transport proteins. And specifically, bile acids through FXR upregulate OST, organic solute transporter alpha beta. This protein resides on the basolateral membrane and is responsible for pumping bile acids out of the hepatocyte into the systemic circulation. It had been previously shown in primary biliary cirrhosis that OST alpha beta is upregulated, and you can see by the immunohistochemistry that OST alpha and OST beta, nicely overlaid there, are significantly increased not only in PBC but also in NASH. And we believe that the OST alpha beta is really an overlooked safety valve for hepatocellular efflux of bile acids. So to recap here, what we see in patients with NASH is a decrease in the function of OATPs, 1B1 and 1B3 specifically, a significant, about 2-fold decrease in MRP2 function, and a marked upregulation in MRP3 and OST alpha beta. Now, these compensatory pathways are for bile acid efflux, specifically on the basolateral membrane, are increased when we administer a compound, a drug that inhibits the bile salt export pump. And as bile acids increase in the hepatocyte via FXR regulation, these pathways are induced, and OATPs tend to move off the membrane. So one might think about the potential for NASH patients being really predisposed or more susceptible to drug-induced liver injury because these compensatory pathways have already been activated by the disease state where there are already higher levels of bile acids in the hepatocyte. And if you happen to be co-administering a drug that may be inhibiting these efflux transporters, then you are further trapping those bile acids within the hepatocyte. So something more to think about. So to summarize, we know that there are changes in hepatic transporters in patients with NASH. This may impact either the systemic and or the hepatic exposure to substrates. So it's very important to understand the disposition and the sensitivity of your compounds of interest to these transporters, whether they are substrates or inhibitors, and the impact on endogenous compounds such as bile acids. I think the data nicely show that systemic concentrations may not accurately reflect hepatic exposure, and that patients with NASH, in fact, may be predisposed to bile acid-mediated drug-induced liver injury. So the knowledge gaps that we have in the field, from my perspective, of course, we've already discussed the challenges of staging, and we know very little about the impact of disease progression on hepatic transporter function. I've basically showed you one extreme of biopsy-confirmed NASH patients. I think we lack a thorough understanding of the pathophysiologic changes that we need as input parameters to do the physiologic-based pharmacokinetic modeling, simple things like liver blood flow you need accurate estimate of for PBPK modeling. How the NASH disease itself alters transport function in other organs, such as the intestine and the kidney, have not been explored. And then, of course, the relationship between systemic concentrations and tissue exposure. Finally, I'd like to acknowledge the graduate students and postdoctoral fellows, particularly Isna Ali, Melina Malinin, Nora Sojdat, and also Brian Firstly for the data that I presented, the collaborators and the nuclear medicine radiology staff involved in the study, and funding sources. And I look forward to further discussion on this topic with you. Thank you.
Good morning. My name is Kim. This is my great pleasure to be here and participate in this workshop in a timely manner, and welcome all. Okay, so this is my disclaimer. And then today I'm going to talk about current trends of clinical trials or regulatory submissions for liver disease therapeutics, and also briefly touch on draft NASH guidances and major clinical pharmacology questions at the IND stage. And before I summarize. So as we heard this morning, there's a great unmet need, that there's a limited number of approved drug products for non-viral, non-oncology liver disease. There are 3 products I can think of, orthodeoxycholic acid for primary biliary cholangitis. It used to be cirrhosis, approved in 2 decades ago. And then about 10 years ago, rifaximin for reduction in risk of overt hepatic encephalopathy recurrence. And about only recently, there was obeticholic acid approved for primary biliary cholangitis based on subpart H pathway, based on alkaline phosphatase reduction. Obeticholic acid is still undergoing the confirmatory clinical trial in phase 4. And unfortunately, despite all this public health issue, and we heard it this morning, there's no approved product for NASH or primary sclerosing cholangitis. So good news is there's a great interest in this field. So we do see a peak of really IND submissions, which keep my life very busy these days. And then since 2012, we see a tremendous increase in IND submissions, including some are pre-submission stages. And then the submission trend development, there are a lot of development programs. Number of commercial INDs is 132 for NASH and NAFLD, including that are in pre-submission stages. Out of that, 73 active clinical programs for drug development. Now, NASH field especially more dominant commercial program than research program. For PBC, PSC, there are 32 commercial INDs open in our database. Out of that, 14 active clinical programs for drug product development. And then for PBC and PSC field, there are still more research INDs than commercial INDs. So we do see more numbers of research INDs currently. And most of these programs are currently in phase 1 or phase 2 stages, very early in development program. Only a few completed phase 3. And in many phase 2 protocols, sponsors are coming with phase 2 protocols to open an IND. That can really give us very time-crunching review time. And those treatments are many NMEs with a lot of the new molecular target. NASH alone, we have more than 35 molecular targets under investigation. And then mainstay of the products are small molecules, and then some are biologics, and we do have also antisense oligonucleotide under studied. And then great interest in repurposing a previously studied or approved product, especially for type 2 diabetes and hyperlipidemia or weight loss, because of the connection to the lipid metabolism, metabolic syndrome with the NASH. And there's increasing interest in combination therapy, so we do see dual combination, also a triple combination. And another aspect is the same drug are sometimes being studied for both NASH and cholestatic liver disease. And unfortunately, recently we see some late phase attrition, that really hurt us too. So, we are sharing the pain in the field. It's not your problem, it's our problem as well. So just switching the gear to draft guidances for NASH. Last year, about a year ago, FDA released draft guidance for non-cirrhotic NASH with liver fibrosis. And in that guidance, FDA laid out the accelerated approval pathway based on liver histology. When improvement in fibrosis stage greater 1 with no worsening of steatohepatitis, or resolution of steatohepatitis with no worsening of liver fibrosis, or both will be the best scenario. And also this year, mid this year, NASH with compensated cirrhosis guidance is also published. In this case, efficacy study is recommended for the time to clinical outcome event instead of accelerated approval pathway at this point. And then compensated cirrhosis is defined by histology, and then like F4 fibrosis stage. And in this case, we recommend exclusion of MELD score greater than 12, from a clinical trial. So in this, especially for non-cirrhotic NASH guidance, there are two features I'd like to point out. A lot of discussion on biomarkers. I realized the drug development for NASH disease is really based on biomarker up until now, because even the phase 3 programs are based on biomarker, which is surrogate endpoint, until we really have to prove the clinical outcome, benefit in phase 4 stage. So the FDA really encourage people to really invest on this biomarker area. And then just because, although histology is still biomarker because of the invasive nature, it's not really preferred or desired for the early phase clinical trials. So we do recommend, in order to accept, or it's up to you, either the non-invasive biomarkers be used for early phase clinical trials for drug effect. And also, however, after proof of concept studies being done, most likely in phase 2A, still histologic endpoint is being recommended to be explored for phase 2B, so to be more relevant to your phase 3 program at this point. And then we do recommend and then encourage biomarker strategy for patient selection and diagnostic, also prognostic biomarkers. So the biomarker is important, as you all can agree, because for clinical pharmacology programs, which is phase 1, phase 2, we do need good biomarkers which can be related to the final outcome we are really aiming for. In this case, liver histology is our goal to achieve at this point, and then best scenario will be if the biomarker is much more correlated with the clinical outcome, predictive of clinical outcome. That will be the best scenario. But I think there's still the way to go. So especially I'd like to emphasize the proof of mechanism, good biomarker identification for target engagement is very important early on. Also proof of concept study in patient population. Biomarkers, non-invasive biomarkers, still it has to be somewhat closely related to the histology, reflective of histology or clinical outcome. And histology, again, is good to go. However, because of the logistic issue, it's not really being studied early phase clinical trials. Though with the great interest in combination product, the proof of concept study for each component is desired. Even if the mechanisms are different, especially if the mechanisms are different, proof of concept study for each component will be very important to really justify why we need these two combinations. And then relationship among this molecular mechanism of action and disease-specific biomarkers, imaging biomarkers, and histology should be evaluated and established throughout the program. So we know what we are doing, what will be the final outcome of the development program. And the major clinical pharmacology questions at the IND stages are not that different from NDA stage. These are our bread and butter for our NDA review, but it's because it's very important for drug development as well. So dose selection is our mainstay, which will be extensively discussed in the later section. Also drug-drug interactions. As I said, there are a lot of phase 2 programs to open an IND, and then my first question will be, do we know what's the DDI potential for this patient population? Are you going to exclude those concomitant medications, considering patients with liver diseases often have comorbidity that require medications like a type 2 diabetes drug or dyslipidemia, and you really, really think about what will be our strategy to make the product can be safely administered in this patient population. And the inclusion-exclusion criteria based on renal and hepatic function is also very important consideration, clinical pharmacology consideration. It can be based on known drug ADME, absorption, distribution, and metabolic and excretion. So depending on what's the primary elimination pathway, maybe impact of the hepatic or renal impairment on the PK will be different. So we need to really think about it ahead of time. Also, another consideration is patients with liver disease can have concurrent hepatic impairment and renal impairment because of the nature of the disease. So that should be considered ahead of time. So another aspect of this NASH guidance is because of that, early evaluation of the hepatic impairment on the PK is really impairment, and to support dosing across the spectrum of NASH liver disease. The importance of right dosage for patients with hepatic impairment cannot be overstated. In our recent experience, for the obeticholic acid, after approval, because a PBC patient with type 2B or C hepatic impairment, moderate to severe hepatic impairment, had an event of hepatic decompensation or failure, those patients were dosed with more frequent than recommended. So we recommended lower dose. However, in clinic, people are using the higher dose, and then there are events, and then that had to be really re-emphasized in the labeling. And the hepatic impairment study is currently a single or multiple dose PK study to test the PK, impact of PK and initial tolerability in patients with hepatic impairment. And this is done in cirrhosis patient, and degree of hepatic impairment is based on Child-Pugh scoring system. Other classification may be used, however, we still want to collect the Child-Pugh scores in the patient population, in that subject. And then this is very important because to support the dosing for patients with cirrhosis in clinical trials, if you're studying the cirrhosis patient, Also, even if you are not studying the cirrhosis patient, but NASH with fibrosis patient may progress to cirrhosis during the long-term clinical trial. So we need to have some safety buffer before we go ahead to the very long-term study. And PK in patients with non-cirrhotic NASH or cholestatic liver disease still need to be collected in the clinical trials. And then I have one case, because many people are using trying to repurpose the approved product, knowing we know a lot about the drug, which may be true in certain case. So this particular case, the drug is approved for a non-liver disease and proposed for a non-cirrhotic NASH with fibrosis. And the patient with cirrhosis will be excluded for the efficacy trials. And it's the same dose as the approved dose for non-liver disease is being considered. However, in the legacy HI study, there was a 5-fold increase in AUC in subject with decompensated cirrhosis compared to the patient subject with normal liver function. So in that case, we have to really think, what can we do? We thought we know a lot about the drug. The patient population has changed. What's the additional risk factor we have to consider? So basically, there should be some risk mitigation strategy be implemented, especially because patient may progress, and then sometimes it will be asymptomatic. So people have to think about it. And the biomarkers, which can really detect progression to cirrhosis or very well correlated with the PK change, will be very useful in this particular case. So in summary, there are unmet medical needs. I'm very, very happy to see all this interest and excitement around this. We can make things happen. So to make the program progress safely and steadily, I'd like to have the early characterization of the ADME of the drug and impact of hepatic impairment and PK. Really, really important to support dosing in patients with liver disease and to mitigate safety concern if there's any, especially if the liver disease progresses during the trials. Also, there are opportunities, as Dr. Brower also mentioned, there could be some disconnect between plasma and liver concentration. I don't know what degree and under what condition, because certainly there are some correlation, but maybe under certain condition it may not be. So better understanding of the relationship between drug concentrations in plasma and liver will be important aspect we want to consider. Also, as Dr. Brower mentioned, knowing the PK/PD, the potential of PK modeling is somewhat impaired because of the less well-defined systems parameters. So this is our opportunity to collect that information because we are studying liver disease. So better characterization of the physiologic parameters that reflect the pathophysiological changes due to liver dysfunction, and also that may impact PK. Also, to support the biomarker development, simultaneous assessment of PK biomarkers in target patient population to understand and establish the relationship between PK, PD, and disease biomarkers will be very important to moving forward. Last but not least, I'd like to thank my colleagues at FDA, especially my clinical pharmacology review team members for liver and GI product. As you can see, a lot of INDs, very busy life. And also, I'd like to acknowledge my DGIP colleagues, clinical review team, PharmTox review team, with who we are working pretty much daily basis together. And also OCP senior leadership to support for this great workshop. Thank you.
Thank you all very much for those presentations and for keeping on schedule with the all that we're trying to cover today. I would like to open up the discussion now to those of you who are here in the room, and again, for those of you who are joining us online, you can email us with a question or comment. So please make your way to the microphones. While we're getting started on that, Dr. Kim, I thought that was a really nice slide at the end with opportunities for connecting the growing interest in drug development in this space with some further work that builds on what Manal and Kim described. And maybe Manal, Kim, if you have any brief comments about what you see as the best opportunities for addressing these unmet needs, maybe picking up on some of Dr. Kim's comments. And
No, I
yes,
think
please.
all excellent comments and presentations. Where we're struggling with in the arena of clinical trial design is what you touched on, Inzuk, is this risk mitigation. We're dealing with a disease that naturally fluxes, for which the natural history is not one size fits all, and for which the drivers of disease may not be the same in any given cohort. And I suspect what we'll find years down the road is there are different phenotypes of NAFLD and NASH and different target engagements. When we're talking about risk mitigation in the context of drug development, what is the FDA considering that means when risk in any unique cohort may be not the same, or disease and in fact may not be uniformly progressive? It may regress. We see placebo response rates in these trials anywhere between 10 to 30%. So maybe being on placebo in and of itself is a risk mitigator. I struggle with that.
Yes, thank you for the question. So for that particular question, example, risk mitigation is really that we also struggled what to do with this. Should we put the clinical trial on hold because we have some unknown? What should be done? From a developer's perspective, you have to really think about what are you doing, basically what we are doing. Do we have enough safety margin from our non-clinical study or clinical prior clinical experience? We do see a lot of program, starting at the top dose they studied in healthy subject after in multiple ascending dose healthy subject that will go into liver patient. Depending on the liver disease status at that point, it may be appropriate and then we may have a really good safety margin and a good reason. But so depending on the disease status at the point, maybe we don't have enough rationale to go into the liver disease patient with the top dose. In that case, we have to reduce the dose. And then also some kind of identification of the metabolite, early in, and then study properly the toxicological profile of the metabolite will be also important. So when I say risk mitigation is how to really do the study and then collect the data ahead of time so we know what we are doing, although there are always risks we have to take.
Dr. Brown?
Well, I think the quantitative system pharmacology models are really very powerful tools to make these accurate predictions and to help with risk mitigation. But we have to have the key input parameters in the disease, and as the disease progresses or regresses, we have to know what to input there. So I think some basic research in that area, and also as the clinical trials are being conducted, any information that we can glean to then use as input parameters for the models is absolutely critical.
Yeah, thank you. Please, and let us know who you are when you ask your question. Thanks.
Sure. Claudia Filosof, Covens. First of all, congratulations for those 3 very clear and concise presentations. I have one question to Kim, and please, Manal and Inzuk, provide input as well. I'm wondering if you have any data, indirect data, comparing these abnormalities in the transport proteins with other chronic liver diseases and the potential impact of the need of including NASH patients and hepatic impairment studies.
So you mean changes in the transport proteins in non-NASH but other liver diseases?
Yes, because in general, in hepatic impairment studies, we are not specifically enrolling patients with NASH.
Exactly.
So I could like the 3 of you to comment on that.
Well, I think our understanding is relatively rudimentary with the specifics of the transporter proteins and using probe substrates like the mebufotenin, for example, to really look at how disposition changes. So I think we don't have a lot of information.
We don't have a lot of information either. So gradually we're thinking of whether the hepatic impairment study should be done in target patient population. So basically, we don't really consider the etiology for hepatic impairment study at this point, but maybe, for the sake of patients, who will be in this PK study, maybe we should study NASH cirrhosis patient in the hepatic impairment study. to be more relevant to the target patient population. That's really the current thought process.
Yeah, this is a good point, particularly as we design these trials and are moving phase 2 compounds into phase 3. We're designing these long-term trials, and it's been discussed that patients certainly can progress, particularly if we're moving away from histology as an endpoint silently. And if we're doing a highly well-compensated cirrhotic trial, the data would suggest about 25 to 30% at 3 years may have a potential decompensating event. But yet if we're studying patients who are stage 2, 3, for example, in a 5-year trial, a third may go on to stage 4 and be silent. Maybe part of the answer to Claudia's question is the industry is reserved doing the hepatic decompensation phase 1 kind of hepatic impairment studies early, understanding that hopefully their label may not be inclusive of that cohort of patients. But from a clinical practice standpoint, clinicians will be at risk for a patient becoming hepatically impaired in the context of time, and maybe we need to consider doing some of the hepatic impairment trials at an earlier time point in drug development pipeline, such that as we transition compounds from phase 2 to phase 3, that there are small pilot hepatic impairment studies done as conceptual safety metrics.
Yes, please.
Hi, my name is Sam Ribello, Excella Health, Boston. Thank you for the nice background and overview. I have 2 questions. First relates to the conduct of renal impairment study. And as we know, we use the MDRD formula, and that is based on the assessment of serum creatinine levels. So I was just wondering, during the disease progression from normal NAFL-NASH to cirrhosis, the serum creatinine levels decrease, and therefore the use of serum creatinine has the tendency to overestimate renal function. Now, when you're trying to insert renal impairment study for a program that is aimed at cirrhosis, how do you use the MDRD guidance in the renal impairment guidance?
Well, that's a challenging question. The reason it's a challenging question for me clinically is as liver disease progresses, we lose muscle mass. Patients lose muscle mass. And the serum creatinine, which is historically used in the assessment of renal function, may actually underestimate the severity of renal impairment in patients with cirrhosis, particularly in women who don't have the same amount of muscle mass as men. So we tend to, as patients get into cirrhosis and hepatic decompensation even, while we put emphasis on creatinine in the MELD score, there are risks in cirrhotic physiology of potentially over or even underestimating what true renal impairment is based on calculations that use serum creatinine. But in keeping with the hepatic impairment concept, there have to be renal impairment studies that are done in the context of cirrhotic and decompensated trials.
Okay. And my second question was, again, trying to design hepatic impairment study in the support of a cirrhotic program. Now, for a cirrhosis, the MELD score is used as inclusion exclusion. And let's say if we go at a higher MELD score, it almost includes all childs A, B, and C if you see the correlation that is published. So if that's the case, and that is the target population, what is the value of a clinical pharmacology, a dedicated clinical pharmacology study in hepatic impairment childs A, B, and C, when a phase 2 program has already included those patient population? I struggle with that.
Right. So I think it's the best scenario you do establish the safety and efficacy in the target patient population. So again, we are going forward, not looking backwards. What do we know about the drug? Before we are exposing patients to the unknown drug with unknown efficacy yet. So this is like a de-risk strategy, and more like, to me, hepatic impairment study is more like a worst case scenario to really have some safety margin ceiling. This is the potential, the exposure change we may see in this target patient population, even if you don't really do the cirrhosis patient enrollment. Then at that point, that information will link all this available safety-related data to make sure we have right justification for safety of the drug, the dose at the point, more like linking non-clinical toxicology data and also prior clinical pharmacology study, safety from the previous clinical pharmacology study. So I feel it's kind of due diligence for the patient, when we moving forward, because there's so much unknown. However, ultimately the safety and efficacy should be established in the target patient population, and the phase 2 program will be very important to gauge that real effect, not only in the PK but also PD, for moving forward. That's my take. Any other comments?
I would say that we're going to come back to some of these clinical trial design issues and clinical pharmacology later in the day too. So please.
There's time, great. Naga Chavasani, Indianapolis. Comment about phase 1 and phase 2 enzymes and NAFLD, and I see a big gap in our knowledge. We know NAFLD has, or NASH, for example, has, increases 2E1, decreases 3A4, 1A2, Greg Everson's, but nobody's really investigating. Who should be doing it? Academic labs don't get funded to do that type. Dr. Brower can vouch to that. It takes revisions, rejections, that type of stuff. Industry is not going to study a disease with probe drugs, but it's really critical, though, for us to do the quantitative systems pharmacology. Otherwise, you're just making up stuff for input. And so this is really, especially drug-drug interactions, NAFLD patients are a number of medications. For example, if your 3A is down, and then, you're going to end up with rhabdo. And, we've seen already that in some of the clinical trials. And that's one comment. Second is, and I think Dr. Brower, you pointed out, that NAFLD patients may be generically at a higher risk for drug hepatotoxicity. I think beyond the anecdotes we are seeing from clinical trials, epidemiologically, I think there is evidence now that there are a generalized increase in daily risk. Therefore, what I'm pointing out is more investment. I don't know where it'll come from, but systematically characterizing, phase 1, phase 2, various transporters, just not all, you have done brilliant work, but just the early NAFLD, NASH, even compensated cirrhosis I'll touch on, is just not all the same. There is early cirrhosis, there is late, where drug metabolism could be quite different. So.
Thanks for the comments. I saw some nodding. We've got time for one more, but please, if you've got a quick response.
Well, my quick response is I'd like to chime in. I think that we need funding. I would like to think that NIH would be supporting this work, but my NIGMS program officer wasn't, made it really clear that the focus is fine on understanding regulation of transporters, but to move on to the clinical studies was really not what NIGMS was interested in. So I think this is an issue we need to address.
Yeah, really important for early stage development, yeah.
Yeah, Greg Everson, formerly University of Colorado, now HepQuant. One of the things that, number one, yeah, we need more funding and input into this whole area for sure. One thing that happens in these trials, of course, is that the patients are oftentimes losing weight. And I'm wondering if you could comment on what you would anticipate the effects of pure weight loss alone without a drug effect would be on some of the processes that you were defining. Because I think the weight loss effect here is also very relevant, both therapeutically for the patient, but also in the interpretation of the results of the trials.
So to my understanding, so weight loss control should be done, for the clinical trial. So, when we include patient population, normally they should be on the stable the way, for a certain amount of time. And as you pointed out, the weight loss itself is kind of treatment. I saw the bariatric surgery can really reverse, steatohepatitis a lot, but even some fibrosis. So that's something we have to think about when we design the clinical trial. What will be our baseline placebo effect? What's the net effect we are targeting to? So to justify the use of the pharmacotherapeutics in this patient population.
I mean, this is an important issue that the Liver Forum is trying to address in two position papers. One for what we mean by, a standard of care to lifestyle in the context of clinical trials, such that intensive weight loss, it doesn't prove to be confounder. However, there is an understanding that certain targets will induce weight loss, but also even metabolically stable, metabolic stability, because significant fluxes in lipids or even glycemic control over the context of trials can influence and confound treatment outcomes. So ultimately, the larger the trial gets, hopefully the less confounding we will have by standard of care weight loss interventions, and it'll be less confounding the longer the trial's in, because patients can't sustain weight loss effectively over the long term. But it is an issue for the short-term phase 2 trials, and hopefully one that can be standardized, understanding that weight loss can occur just from enrollment into the studies or from a given therapeutic target.
I think the signaling in the liver can be very quick with weight loss, and Dr. Brower, I was kind of curious if, what the weight loss effects might be in your models on the transport systems, and because weight loss effects can be much more dynamic than we think, because we have some patients who will lose 10% of their body weight in that first few weeks, and they plateau, some gain, some continue to lose. So I was curious about the effects that you would, I'm sure you haven't studied it, but what would you anticipate?
So what we know from the changes in the transporter systems that we have investigated is that it's primarily driven by FXR and by bile acid mediated alterations. When we talk about obesity specifically with respect to metabolic and transport systems, I think we have a less understanding of the impact of the obese state itself. But I think I'm a little bit more focused on the bile acid mediated changes than on the obesity itself.
I want to thank our panelists for a great kickoff discussion for today. I know there's some more comments and questions. I think some of these are going to come up again in our later sessions, including in our next session on issues in early discovery and clinical development. So please hold on to those thoughts. And for right now, we're going to take a short break. We'll be starting up our second panel at 10:50. Thank you very much. Keep us on schedule. As you all know, we have a lot of ground to cover in this very important and dynamic area. So I'm going to go ahead and get our next session started. So I'd like to ask everyone to come back to their seats. And again, welcome back all of you who are joining us online. This session is on early discovery and development, treatment mechanisms, molecular targets, and biomarkers in the early development of therapies for NASH and cholestatic liver diseases. To kick this off, I'd like to ask our two presenters and our case study presenter to come on up. I'll introduce the rest of our reactants a little bit later on in this session, but right now we're going to start with two opening presentations and then discussion focused on molecular targets and biomarkers in early phase development. We touched on this a little bit in the last session too. So first we get to hear from Naga Cholestatic, who's the David Crabb Professor of Medicine and the Director of the Division of Gastroenterology and Hepatology and Associate Dean for Clinical Research at Indiana University School of Medicine. Naga, thank you for being here. And also Jeffrey Edwards, who's Executive Director of Clinical and Preclinical Pharmacology at Intercept Pharmaceuticals. Following their presentations on this topic, we're going to have a case presentation from Saurabh Gupta, who's Director of Translational Research and Early Clinical Studies at Takeda Pharmaceuticals. So Naga, to you first.
Thank you. Happy to be here, and I appreciate the invitation to speak here. These are my disclosures. So to set the stage, to set the framework for discussion about molecular targets and treatment landscape, I just want to touch on major NAFLD subphenotypes. And as Manal touched on, there are 4 subphenotypes. One is NAFL, then there is NASH with early or no fibrosis, and then you have NASH with stage 2 and stage 3 fibrosis. And then you have NASH cirrhosis. And then I want to point out, though, is the major causes of morbidity and mortality in each of these subphenotypes. What you will see is in NAFL, liver disease does not make it to top 4. Actually, in NAFL, if you look at long-term outcomes, liver as a cause for death is quite rare. Whereas in NASH with early fibrosis or no fibrosis, NASH is liver disease can cause death, but it is behind cardiovascular and non-hepatic malignancies like colon cancer, breast cancer, etc. However, that's not the case once you advance to stage 2, stage 3 fibrosis and NASH cirrhosis. Here, liver disease becomes the dominant cause for morbidity and mortality, followed by cardiovascular disease. Also, you have hepatic and non-hepatic malignancies. Hepatic malignancies feature here. So this slide outlines which subphenotypes benefit from liver-directed pharmacotherapy. So if somebody has NAFL, they need to be taken care, but not necessarily liver-directed. And the same thing with NASH with stage 1 or no fibrosis, probably not. I think you better take care of their cardiovascular as well as diabetes, so on and so forth. However, when you get to stage 3, stage 2, stage 3, and stage 4, which is cirrhosis, you certainly need liver-directed pharmacotherapy. And most of clinical trials now, phase 2B and phase 3 are focused in bottom through 2 columns. Rows, sorry. Oh, this is also... Why are the slides cut off in the bottom? That's major causes. I think I'm going to skip this too. This is an important slide, though. I think we are collapsing. The compensated cirrhosis is very broad. I think this is for hepatic impairment studies as well as understanding PK/PD. The compensated cirrhosis, I think, behaves differently early versus late. We know, though, even if you look at Charles A, score of 6 and 5 behave very differently in terms of outcomes and natural history. So here, what I propose here is you have early versus late stage. This is all within compensated. Early cirrhosis this is just a patient just entered the stage of cirrhosis. The nodules are large, septa are thin. Of course, synthetic function is preserved. And here I think you often see active steatohepatitis. And here the patient population, types of patients, age, the interventions, outcome, duration of therapy is very different in this subgroup. Whereas late stage, still compensated, you have thick septa, you have portal hypertension, your hepatic venous pressure gradient is over 10 or 12 millimeters of mercury. MELD, because it's compensated, as was pointed out, on 12 or less. And here the active steatohepatitis may be burning out. You may just not see enough fat. So I think even the hepatic impairment studies, we sort of lump A, B, and C, and I think A should be sort of split either into A5, A6, or into early or late stage. I know no drug is approved to treat NASH by the FDA or by EMA. There are a few things that are available to us clinicians in the clinic, and some of them actually have made it to practice guidance and practice guideline documents. So there are two groups of compounds. One is the insulin sensitizers, metformin, to most part did not prove to be useful, whereas pioglitazone and liraglutide can be effective. Especially pioglitazone, there are about many studies, including PIVENS trial, showing it improves liver histology. ASLD practice guideline document recommends that it can be used in patients with biopsy-proven NASH. Liraglutide, lean trial published in Lancet also has shown histological improvement. Pretty convincing. It needs to be reproduced. The practice guideline thought it was premature to use in clinical practice. Having said that, there are NAFLD clinics, for example, at University of Chicago, where they have an endocrinologist embedded, and they aggressively use GLP-1 agonists such as liraglutide in their patients, especially if they have diabetes. And ox-stress, vitamin E, there are two trials, PIVENS and TONIC. There's a large trial in China that we're expecting results anytime. There is histological improvement. As a matter of fact, it made it to practice guidelines as a possible treatment. So we certainly been using pioglitazone as we have done the PIVENS trial, as well as the vitamin E, at least for 8-9 years or so now. This is a slide I borrowed from Dr. Mike Charlton showing global pipeline, which is very robust. As was pointed out, there may be 35 different molecular targets that are being aimed at to develop therapies. There is big stream of phase 1 and phase 2, fewer phase 3. There is only one compound aiming to get subpar H, maybe early 2020. So in terms of groups of assets, NASH development assets, I sort of group them into 6 categories here. One is the targeting metabolic. These are the insulin sensitizers, GLP-1 agonists, FGF19-21 pathway, SGLT1 inhibitors. And that's sort of one group. The other is oxidative stress reduction. This is vitamin E as well as mTOT inhibitors. Anti-steatotics, you have ACC and you have SCD1 inhibitors and so forth. Nuclear hormone receptor agonists, this is where a lot of action is with PPAR agonists. I'll touch on these. FXR agonist, LXR, and then you have thyroid hormone receptor beta agonist, which is now in a phase 3 program. And then you also have mitopyruvate carrier modulator. This is a serious compound. Some interest in intestinal permeability and anti-inflammatory and anti-fibrotic. And the CCR2, CCR5, this is the allergen compound, which is in phase 3. And ASK1 inhibitors, selonsertib by Gilead was a failure. Now it is being tested in combination. There are a number of things. The point out though is when we have done look at the RNA-seq data in nicely characterized NAFLD patients, early, late, what really speaks at you is the inflammatory pathways. Arun Sanyal's group has seen the same thing in his scientific reports paper. So I think I expect much more action in this bucket, although there have been early failures with ASK1 inhibitors, caspase inhibitors, and so forth. A lot of action. Once again, these are advanced phase monotherapy for pre-cirrhotic. This is NASH with stage 2 and stage 3 fibrosis. A number of phase 3 that are ongoing. I have a slide to show. There are a number of interesting phase 2 initiated, completed, and you can look at this slide leisurely at a later point. This is a summary of phase 3 clinical programs. This is once again pre-cirrhotic. Almost all of them are aiming to get subpar H to show histological improvement, and they all have a phase 4 built in. So where they can show improvement in hard outcomes to get a full final approval. Obeticholic acid is an FXR agonist. They have a fairly large trial. The results are available. I think it just got published in Lancet within last week or so. Met the primary endpoint, improvement in fibrosis, 23% versus 13% or so in placebo, and then NDA has been submitted, and we will see what will happen to that. Elafibranor, this is a PPAR alpha delta. Enrollment is complete. Hopefully in 2020 late, we'll start seeing the results of elafibranor. The thyroid hormone receptor beta agonist, this is resmetirom. It is recruiting, so is cenicriviroc. Both of these compounds had positive phase 2 data, more so with resmetirom than cenicriviroc. Had some fibrosis, but the 2-year data were soft. Aramcol is SCD1 inhibitor at a positive phase 2 results. Now it is started a phase 3 and started to recruit. The Sirius compound, this is the mTOT inhibitor, modulator, had phase 2 results presented at the liver meeting by Dr. Harrison. They were planning to start a phase 3 in light of phase 2 results. They're in the process of redesigning the trial, is my understanding. Selonsertib, these are Stellar 3 and Stellar 4 were failed. Therefore, that compound is not being developed as a single agent. NASH and cirrhosis, though, is also there's been a number of phase 2 and phase 3, but to large part, they have not been very successful. So selonsertib, this was Stellar 4 trial, was a negative study. Obeticholic acid actually is a reverse trial. It is ongoing. They recently increased the sample size to 900. I think we won't be seeing results until 2021 from this cirrhosis trial. Simtuzumab, Gilead trial failed many years ago. Belapectin, galectin, this was a trial I was heavily involved in. A primary endpoint was not met. A lot of lessons learned, though. This is where I realized the compensated cirrhotics are a mixed bag. You need to be very careful in terms of who comes in and what kinds of endpoints you need to be aiming at. Emricazan, this is Conatus, was their trials have failed and they discontinued their program. BMS has PEG FGF21. I think the recruitment is complete, and Novartis is also a cirrhotic trial just has begun. Just high level, I'm going to touch on biomarkers, and Dr. Abdul Malik sort of briefly mentioned this. So we need diagnostic, prognostic biomarkers as well as treatment response. There are a lot of activity here, though, at least going back to 15 years or so. Soluble biomarkers, ALT is useful some, but not necessarily for clinical trials. CK18 fragments, a lot of interest in 4 or 5 years ago. It's not commercially available, but most clinical trials use K18. It relates quite nicely cross-sectionally to liver NASH, presence of NASH, and also it is dynamic enough. If there is NASH resolution, you see a decrease in K18. More work needs to be done. ELF and ProC3 are exciting, and hopefully we see more of them. Our NASH test also is exciting. This is based on lipidomic and metabolomic. But rigorous peer-reviewed studies are not yet available. Imaging, FibroScan really changed how we practice hepatology in our clinics. But FibroScan for clinical trials, it can be useful for enriching patient population, but not for as a surrogate for endpoints. MRI, PDFF, MR elastography, and multiparametric MRI, that is the corrected T1, all are exciting. They are making into clinical trials. They're still trying to find their precise role in monitoring endpoints. 2 function studies that are used fair bit in clinical trials, HepaQuant, Dr. Everson will touch on it, and then C13 methacetin breath test. Neither are available clinically, although one of them is approved. I think maybe both are approved by the FDA. Hopefully we will see more of this, and also I think we need to see rigorous peer-reviewed publications from them. Two international consortia focusing on biomarkers. This is Litmus from Europe, almost a $50 million initiative to advance biomarkers. A lot of important work is ongoing. I think there is optimism that next few years we will have something concrete here. On the US side, NIMBLE program, Dr. Kaya is here. He can elaborate on it. This is more qualifying some of promising soluble and imaging biomarkers. Molecular targets for, and the ongoing studies for PBC, really the FXR agonists and PPAR agonists, FGF19, are what's been pursued today for PBC, and there are IBAT inhibitor and kappa opioid receptor agonist for itching. Both are trials ongoing at the moment. I have a table here showing various PPAR agonists that are being tested at the moment. We are heavily involved in saroglitazar program, which is PPAR alpha, and then bezafibrate, not being tested in this country, but it has a New England Journal paper showing efficacy in a fairly large cohort of patients. And seladelpar had toxicity in their NASH program, and I think their PBC program may be on hold. Last slide. Molecular targets and ongoing studies in PSC. There is no approved therapy, although clinicians use ursodeoxycholic acid and endoscopic therapy. Nor UDCA and acylfexar, that is Gilead compound, are being tested in phase 3. I think NAR UDCA is not in the US, it is in Europe. There are a number of phase 2 ongoing trials. PPAR agonist, fenofibrate, FGF19, IBAT inhibitor, high tide compound, 1801, FMT, fecal microbial transplant, and vancomycin. There's just a lot of interest and a great unmet need. This is a progressive disease, an important cause for liver transplantation. So, and there isn't clear guidance in terms of what endpoints. We sort of use alkaline phosphatase. Unlike in PBC, where alkaline phosphatase is a good marker for outcome, an improvement in alk phos improves outcomes. In case of PSC, alkaline phosphatase has no prognostic significance. Therefore, endpoints are not clear. There is not a clear guidance, so that's an area that's pretty confusing. That's my last slide, and I thank you for your attention.
Good morning. Today I'm going to talk about the clinical pharmacology of obeticholic acid. And I'm going to focus very specifically on the clinical development program for both PBC and NASH, as that's most relevant for what the discussion is for today. Obeticholic acid is a selective and potent FXR agonist. It is a modified bile acid. It's structurally very similar to chenodeoxycholic acid, which is the natural ligand for FXR, except for it has an ethyl group, which allots it to 100-fold more potency on FXR. OCA has received market authorization for the treatment of PBC in the United States, in Europe, and other countries. And very recently, a new drug application has been submitted to the FDA for the treatment of fibrosis due to NASH. Now, prior to talking about biomarkers related to both PBC and or NASH, I do need to talk a little bit about the PK. And you saw this morning how transporters and all these things can be affected in NASH and actually with PBC as well, that can influence the PK of a drug. And particularly because we look at plasma, we sometimes can be a bit fooled because we know that the liver, the site of action in this particular case being the liver, is the most relevant. Obeticholic acid is rapidly absorbed from the gut, and it is extensively taken up by the liver and conjugated to the amino acids glycine and taurine. These conjugates are approximately equally potent on FXR and then are released into the intestine via the bile gallbladder and are actively taken up in the terminal ileum. And the net effect of this is that OCA primarily resides within the liver-gut axis. And this is important because that is primarily where FXR is expressed. The other part that makes OCA a little bit unique is that it has a 4-day half-life. And so it's kind of rare to talk about a drug being highly extracted by the liver and still having a 4-day half-life, and that is because it is just continuously cycling between the intestine and the liver. Now, as we discussed this morning, there are what we call the relatively typical clinical pharmacology studies that you run with hepatic impairment, and we did run this during the PBC development program, not really knowing all the things that we know today. Results from this study, and I should just say that a single dose was either given to healthy subjects or subjects with mild, moderate, or severe hepatic impairment based on the Child-Pugh class system, we saw that the plasma exposure in the subjects with mild hepatic impairment wasn't particularly different than those with healthy subjects. Now, again, there is some arguments about this, whether this was a cherry-picking patients who were very well compensated, or the fact that this was patients who had cirrhosis primarily from hepatitis C and not PBC. There could be some confusion with that. However, very clearly, there was an increase in the plasma exposure of OCA with those with moderate and severe hepatic impairment, approximately about 4 to 17-fold. In addition to looking at the plasma exposure of the drug, we also looked at the levels of the endogenous bile acids. So do recall, OCA structurally looks like a bile acid and behaves like a bile acid. And not very surprisingly, we actually saw pretty similar results with the bile acids, where in the patients with mild hepatic impairment, there really wasn't too much of an increase in the exposure levels. But in the moderate and the severe, we saw approximately a 6 to 13-fold increase with it. Now, this should not be unexpected because it has been long established in literature that bile acids levels are increased in the systemic circulation with cirrhosis. In this particular case, I'm showing the results from Fisher et al. From 1996, where they looked at the level of endogenous bile acids, both in plasma and liver, in patients with end-stage liver disease. In this particular case, I'm showing from non-cholestatic patients, relative to healthy control matched. And what they had found was that the systemic exposure of bile acids went up about 20-fold in this patient population relative to the healthy. But importantly, liver exposure only increased approximately 2-fold. And the real take-home message here is you can be fooled when you look at plasma exposure of a drug that's in the liver when you're talking about hepatic impairment. Now, this doesn't mean that you have to just avoid saying plasma exposure is important. It's very important. But what you need to take into account is, in this particular case, looking at patients with end-stage liver disease at their endogenous bile acid levels from a cholestatic disease, there's higher levels of the bile acids, and thus you can see differences in the liver disposition of a drug, whether you're talking about a cholestatic liver disease versus a non-cholestatic liver disease. And the reason that is important is OCA is being developed both in PBC, cholestatic, relative to NASH, non-cholestatic. So you can have different doses and different effects, and it was alluded to this morning in our talks. For the PBC development program, we relied extensively on 2 biomarkers, alkaline phosphatase and total bilirubin. And this was fortunate because they had been established that there's a correlation with outcomes of reductions in ALP and total bilirubin with ursodeoxycholic acid, which is the first-line treatment for PBC. Here I'm showing the results from our phase 3 studies, and we see a very robust reduction in alkaline phosphatase starting at the 5 milligram dose, with maximal responses seen at the 10 milligram dose, which are the doses that are approved for PBC. We also saw a reduction in total bilirubin, again, a pretty similar one where we see a robust response at 5 milligram, but maximal response is at 10. And I do need to point out that the total bilirubin levels were typically in the normal range, and so this reduction was even seen in patients early on in the disease. Now, actually this morning we talked about the fact that there is an alternative dosing regimen of OCA in PBC patients with moderate and severe hepatic impairment. And honestly, what's not being told about that, there was a very strong collaboration between the FDA and Intercept to propose this dosing regimen. Now, I'm not going to belabor the point about this, but just quickly, the dosing regimen starts off with 5 milligrams of OCA once weekly. The purpose of this is that the plasma exposure in the patients with moderate and hepatic impairment with this particular dosing regimen will have similar plasma exposure in the non-cirrhotic patients receiving 5 milligrams or 10 milligrams once daily. Patients then can move upwards to 5 milligrams twice weekly or 10 milligrams twice weekly, with the concept here being that liver exposure in this patient population would be similar to to the non-cirrhotic patients receiving the daily doses at 5 and 10 milligrams. So with the PBC program, we had the advantage of the fact that ursodeoxycholic acid is approved for the treatment of it, and that ALP and total bilirubin are very good biomarkers and are likely to predict outcomes. However, when it comes to NASH, Intercept has certainly been in the forefront of this, and unfortunately, we just aren't at a stage where the biomarkers are really set that we can rely on them completely. And so histology is what we use in our phase 3 studies, and we do use them in our phase 2 studies as well. Now, prior to going into these biomarkers related to NASH, I actually need to talk a bit more about the PK of the drug in this particular patient population. So obeticholic acid is highly extracted by the liver, even in healthy subjects. As you progress forward with NASH, especially F1, F2, you start to see increases in the plasma exposures. And actually, Dr. Brower this morning highlighted that quite nicely. And by the time you get to F3 and F4, and so F4 being the cirrhotic, there are significantly higher plasma concentrations of bile acids, and you're going to see the same thing with obeticholic acid. The thing here that you have to be careful of, again, is the most relevant concentration is the liver, not the plasma. And we would have predicted that actually liver concentrations wouldn't change very much based on what is known about the transporters and the effects of NASH on them. During the development program of OCA in NASH, we looked both at the plasma levels of obeticholic acid, and we were able to actually take biopsy samples and looked at the liver concentrations of OCA. Here on the left-hand side, you see an increase in the plasma concentrations as you progress forward from F1, F2, F3, and F4. In this particular case, I do want to point out this is Child-Pugh A, so these are compensated cirrhotic patients. But if you look on the right-hand side at the liver concentrations, they aren't changing very much, especially in the patients from F1 to F3, and there is a slight increase in the F4, although there's variability where they're overlapping one another. And so when we're talking about dosing, which is very true to clinical pharmacology, this is what we need to focus on because it's the most relevant. In terms of biomarkers, the first thing that we did is we actually looked at markers of FXR activation, and the two that I'm going to talk about today are C4 and FGF19. C4 is a marker of bile acid synthesis, and as alluded to this morning, FXR is a regulator of bile acid. It actually suppresses it. In this particular case, I'm showing the results of a dose response from 5, 10, and 25 milligrams in healthy subjects, which are shown on the far left, those with NASH fibrosis, so that's F1 through F3, as well as NASH cirrhosis, which is F4. And what is very interesting about this, if you can look at it, the 5 milligram dose, you see an effect on FXR activation, but the greatest effect is actually seen with the 10 and the 25 milligram. The other thing to take home from this is the fact that the dose response looks very similar between the healthy subjects and the NASH subjects, whether it be with fibrosis or cirrhosis, even though plasma concentrations are changing quite dramatically. And the reason I'm not showing an exposure response, there isn't a good exposure response because the plasma exposure is not predicting the liver concentrations. If you look on the right-hand side at FGF19, it's a little bit of a mixed result. In the healthy subjects, we see a dose response with the 10 and 25, with the 25 being the greatest. In the fibrotic subjects, it was a little iffy. But in the cirrhotic subjects, we see that the 25 milligram dose was highest with that one. And that is actually a marker of intestinal FXR activation. In terms of the dose response for markers of liver injury, in this case, we're going to focus a lot more on ALT, as well as liver function. We actually see a pretty similar dose response to that which was observed with C4. In this particular case, if you look on the bottom left-hand side, the 5 milligram dose suppresses or reduces the ALT levels, which are usually higher in NASH patients. But the maximal effects were seen with the 10 and the 25 mg dose. As a matter of fact, looking at the 10 and 25, you wouldn't think there would be a difference. I do want to highlight one thing that's really key here. I'm only showing the results from the phase 1 and phase 2 studies. So this is from clinical pharmacology. Obviously, when you get to phase 3 studies, when you're talking about hundreds of patients per dosing arm, you might be able to delineate the response a little bit better. But a part of what clinical pharmacologists have to do is take limited data and make our best judgments of how to move forward. A similar response was seen with AST and GGT here. I'm not going to belabor the point because of time. And if looking at total bilirubin, we couldn't really see a dose response. These studies went out to 4 months, and so perhaps with longer time frame, you would have seen it, but it certainly wouldn't have helped with dose selection. Now, the really fun part here would be able to say that we ran our pivotal phase 3 study, Regenerate, and we saw that the 10 and the 25 mg dose had a very similar response. But as many of you know, that was not the case. In the bottom right-hand corner here, I'm showing the results from Regenerate from the F2, F3 population, looking at an improvement in one stage of fibrosis with no worsening of NASH. And here we see a very clear dose response where OCA 25 milligram was both statistically and numerically greater than placebo, where the 10 milligram dose was lower than the 25 but higher than the placebo. And in fact, if you were to actually correct for the placebo response rate, the OCA 25 milligrams was double that of the 10 milligram dose, not predicted by the phase 1 and phase 2 studies. But the one thing that I hadn't shown previously is that we did use non-invasive technologies in our clinical pharmacology program, and the one that I want to talk about in particular is HepQuant. Now, I don't have time to go over the details of the HepQuant methodology, but I will point out that it is based upon liver function, and that changes in liver extraction that I talked about earlier with bile acids, that's what it takes advantage of. Based on the disease severity index, we saw a dose response where the 25 milligram dose saw a 73% improvement in liver function, where the 10 mg dose showed a 36% reduction or improvement in it. And there you can see you're seeing that doubling of the effect that's more consistent with what we saw in the phase 3 study, and none of the placebo subjects showing any response. And just to point out, this is with very low numbers. There was only 5 in placebo, 11 in the 10, and 11 in the 25 milligram dose groups. The last thing I want to talk about, and this may seem obvious to you, but I'm seeing it in the field quite a bit, and that is the potential pitfalls of using liver biomarkers. I'm going to use one that's very specific to OCA. The 25 milligram dose has been associated with an increase in ALP, not so much the 10, but the 25 for sure. And this has actually been noted in other programs for non-steroidal FXR agonist. And although we don't fully know what the mechanism is, we know a couple of things. One, at therapeutically relevant concentrations, OCA does not affect ALP directly in terms of transcription. So what I'm showing here on the bottom are human hepatocytes looking at subtherapeutic to almost toxic doses of OCA, and you're not seeing an increase in the ALP at the ones that would be relevant to the clinic. However, if you look at other markers related to ALP homeostasis, in this case phospholipase D, we see that there actually is an increase in phospholipase D at the therapeutically relevant concentrations. And so what we're proposing, at least in part, is that this increase in ALP, which is occurring primarily again at the 25 mg dose, is due to the increase in phospholipase D, which is responsible for the cleavage of the membrane-bound ALP, and it increases the amount of the soluble ALP. The reason I say, though, this is probably only part of the story, we need to understand things like phospholipase C and the others. But again, this effect that we're seeing isn't related to the disease, and it's really important that when you're looking at these biomarkers, that they're related to disease modification and not to a direct effect of the drug on it. So in conclusion, I just want to point out that in liver disease, whether it be cholestatic or non-cholestatic, you need to be careful when looking at the PK and the site of action. We know that these biomarkers can be very useful in the clinical development programs, but they can also sometimes mislead you in this particular case with the dose response. And the use of non-invasive technologies may be very useful. And finally, it's very important to make sure that when you're looking at biomarkers, it's related to disease modification and not due to a direct effect of the drug.
Good morning, everyone. I'd like to thank the organizer for the opportunity to participate in this exciting workshop. So I'll be switching gears. Rather than clinical pharmacology, I'll be talking about the circulating biomarkers in NASH clinical development. And specifically in terms, I would cover the background and why the non-invasive biomarkers are needed. It has been alluded in earlier presentations, and I'll go a little bit deep in the same. There are tons of exciting biomarkers which being leveraged in various consortia, etc. But I'll concentrate specifically on PRO-C3 and other extracellular biomarkers in NASH clinical development, and emphasize upon the data which has been evolving and being produced regarding how they are useful in diagnosis, identifying responder, non-responders, their prognostic value, and finally their translatability, but rather reverse translatability in terms of animal models. So this is an obvious, and I'm guilty of teaching to the choir here. So what we know in the liver NASH area is that liver biopsy is still the reference standard, which is definitely not a gold standard for staging fibrosis and steatohepatitis. What we know is the fibrosis scoring system is relatively complicated, ranging from stage 0 to stage 4, and NASH scoring system comprising of steatosis, lobular inflammation, and hepatocyte ballooning. So it's obvious, but I still like to emphasize the biopsy is invasive, painful, can lead to, in rare cases, complications and even to death. Costly, and as we see in earlier presentation, there is a huge burden of patients which are risk at NASH. So there is lack of specialists available to cater to this huge patient numbers. And finally, it's not suitable for frequent and longitudinal assessment. And the other part, if we go into the fibrosis per se, fibrosis is not a homogeneous disease, and maybe when we are taking biopsy, it's definitely not representing whole liver per se. And again, there is a high interobservable variability, histological scoring, even among most trained pathologists. The concurrence rate doesn't go beyond 80%. So what I'm trying to make case is, for my bread and butter is the biomarkers, that you require one, and non-invasive, cost-effective, readily available, accurate. This is mouthful, but still, these are aspirational goals, and we may have some potential candidates. That's what I'll try to make case for. Dr. Kim already pointed out to the latest guidelines which have been regarding the non-alcoholic steatohepatitis in non-cirrhotic patients, that what kind of biomarkers can be included and what role they do play in the early studies. So I combined those guidelines with what is the real world experience. And if you see that in terms of the early phase 2, in proof of concept studies, a lot of biomarkers catering to steatosis, steatohepatitis, or fibrosis are being used, like MRI-PDFF, CK18, ELF, and PRO-C3. Histological opportunities can be utilized provided the trial is running for sufficient duration, and that again provides an opportunity to incorporate biomarker and concurrently read with the histological readout. And in late phase, where you require an histological readout, and the histological readout is regarding reduction, for example, in inflammation or improvement in fibrosis, the scope of biomarker becomes more important here, and which can be used either to increase the likelihood of confirmation biopsy, thus reducing the screen failure rates, biomarkers that can provide the evidence of disease progression, and also the prognostic biomarkers which may be robustly predict the liver-related complication. So phase 3 has been covered earlier, and again the additional endpoints would be dependent on the long-term outcome, all-cause mortalities, cirrhosis, or liver-related outcomes. So just a little bit background on PRO-C3 and its counterparts. If we look into the NASH patients with hepatic inflammation and hepatocellular injury, there is increased risk of fibrosis. And so far within the studies which have been read out, hepatic fibrosis is only the independent predictor of clinical disease progression. And out of that, if we look what exactly fibrosis is, it's abnormal deposition of connective tissue leading to the damage of the structures and functions of the organ and tissues involved. And if we look into the core protein involved in fibrosis, it's not simply collagen, but also structured proteins like laminin and elastin. So the formation and degradation process of collagen do offer us an opportunity to monitor and look into the fibrogenesis and fibrolysis part through these formation and degradation processes. What you look in the cartoon is, if you look into the fibrogenesis part, you have example like P3NP or ProC3, which is simply the pro-collagen fragment which comes out from its N-terminal domain during the maturing of the collagen fibers which are being laid out. And similarly, during the fibrolysis part, enzymes like MMP degrade these fragments, and these soluble fragments can be tracked in the blood vessels, and these degradation markers like C3M, C4M do cater to different kinds of collagen. So this is an opportunity and which has been leveraged well in the biomarker arena in NASH. As Dr. CEO kindly pointed out or recapitulated what is our experience from hepatitis C and the drug development in hepatitis C, I think in NASH we have been fortunate to leverage upon our learnings from hepatitis C. And this is a publication coming from 2015 in an Australian cohort where 400 chronic hepatitis C patients with the biopsy confirmed were looked from the perspective of the fibrogenesis and fibrolysis marker. So what you see is the metavir fibrosis scoring on the x-axis, and what you see with the ProC3 and P4NP7S, which is also called now ProC4, there is a clear distinction between early fibrosis, which is F0 to F2, vis-a-vis F3 and F4s. The similar thing was seen with C3M, C4M, and C6M. So and this changes also were measured along with the AST in these patients, AST and ALT. And then a multi-ordered regression was done where it was seen that the best model was combining the structural abnormalities like ProC3 and C4M along with the functional aspect like AST and ALT. So what you see a significant changes vis-a-vis F0, F1 and F2, not much resolution between F3 and F4s. And even if you do a model with the risk factors like BMI along with the epidemiology like gender, it is able to distinguish between the early phase vis-a-vis the late phase. So if we look into the ProC3, which is the N-terminal fragment during the collagen formation, one thing I'll like to give a health warning, it's not a liver-specific marker, but its association has come from multiple clinical studies and also what we've got through our in-house data experience. So what you see here is a nice staircase response if you look into the normal healthy volunteers, simple steatosis and NASH, that the ProC3 levels are really high in case of the NASH patients, and they correlate well with the NASH scoring, specifically if you look into the 5, 6, 7 versus 1, 2, 3 of the NASH scoring. And in terms of the Kleiner fibrosis scoring, fibrosis stage 3 and 4, significantly the ProC3 levels are high, which has been also confirmed from the various clinical studies. This one is coming from BMS, where you see again the high levels in the F3 and F4. Although I say the resolution for ProC3 distinguishing between F3 and F4 is not much. And again, the NASH, the similar studies have been reported that ProC3 trends well along the NASH score. So I won't belabor on this point except saying that it's not only ProC3, what we have also ProC6, which is also a signaling peptide, which was recently shown in the ASLD, where it was presented that ProC6 was as pro-fibrogenic as TGF-beta, and ProC6 was used in a scar in a jar model, which it increased the ProC3 levels. Similarly, you have markers like ProC4, which gives the information about the basement membrane fibrosis. And here again, you see a nice staircase responses within different pathologies. And if you look into the fibrolysis marker, C3M and C4M is also increased. It seems a little bit counterintuitive that, if the lysis marker are increased and the genesis marker are increased, so it underlines the fact that fibrosis is a high turnover disease. And I think to get a comprehensive picture, it's good to quantify the genesis lysis marker together. And what we saw that, we calculated the Pro-C3 versus C3M ratio, and it was significantly high in NAFLD patients as compared to the normal healthy volunteers, both for the Pro-C3 and the similar exercise we did for collagen 4 between Pro-C4 and C4M2. And here again, the levels were high in case of the NASH patients. I'd like to point out also, when we are looking into these biomarkers, we are looking to set up certain threshold, for example, for diagnosis. So in this particular study, what we looked was the Pro-C3 levels between the normal healthy volunteers between Japanese ethnicities and UK, and there was a higher level in case of Japanese subjects for Pro-C3, whereas it was opposite for collagen 4. So in brief, what I like to emphasize from this particular slide is when we are designing the global trial, it's important to take the ethnicities in account, which will help in us in identifying the thresholds. So one thing regarding how the pharmacological interventions have impacted the Pro-C3 levels. So this study is from BMS, where they showed FGF21 responses, FGF21 pegylated analog could reduce the different markers, including the steatosis through MRI, PDFF, the Pro-C3 level and MRE level. Interestingly, when the patients were segregated based on their Pro-C3 level, the patients with a higher amount of Pro-C3 responded much better, both with the MRE, but also in the decrease of the Pro-C3 level as compared to the patients who had lower amount of Pro-C3 levels. Similar story was seen in the responders of the NGM282 FGF19 analog, where the patients who responded, and response being defined improvement in NASH score or improvement in fibrosis score, there was a almost 56% decrease in the Pro-C3 levels. And the timing wise, it's what was earlier thought to be a relatively slow process, it's being indicated that actually the Pro-C3 levels can be changed between as soon as 28 days. So in terms of identifying responders and non-responder towards Pro-C3, there were two studies which were negative, specifically Farglitazar, where it's a PPR agonist for 52-week treatment in chronic hepatitis C patients. If the patients were segregated based on Pro-C3 levels higher than 20.2 or lower than 20.2, what you see is the patients with the higher Pro-C3 level, there was a significant decrease in their Pro-C3 levels. And also what you see is in case of patients with a higher Pro-C3 level, there was also an improvement in the fibrosis score, again indicating that Pro-C3 is associated with the histology part. In case of a phase 3 study, with the baloglitazone study, it was again divided between 13.3 and less than 13.3. What was observed where the patients had higher levels of Pro-C3, there was a parallel improvement in the serum ALT. If we look into the time course of Pro-C3 changes, the NGM studies have moved and really given us enough thoughts to ponder. The increase is relatively fast. This is coming from a PSC study where you see even within 1 week there is a significant decrease in the Pro-C3 level, and which is maintained throughout the treatment duration. And after the end of treatment at 12 weeks, you see a recovery, and there seems to be a dose-dependent response between 1 milligram and 3 milligram. And this changes correlated well with the Pro-C3 levels and the conjugated bile acids. And as I showed in earlier slide, 1 milligram and 3 milligram both also showed a significant changes in Pro-C3 level for NASH. And here I like to emphasize upon the potential of Pro-C3 to predict clinical responses. In a liver transplant study, it was shown that if the patients are classified fast, intermediate, and non-progressors with a recurrent fibrosis based on a biopsy readout, and if the response is divided between, patients are divided between high ProC3, that is 20 that is less 20.2, and patients with a high ProC3 level, the yellow one with the higher ProC3 has a worse prognosis than the patient with the low ProC3. And similar trend was also seen in the CHT patients. And just to sum it up and indicating that if there is a challenge in NASH clinical development, if we can improve our translatability, more so the reverse translatability, that also helps in the drug development. And in these MCR4 knockout, those are the melanocortin receptor knockout mice, in these mice we saw a clear increase in the fibrogenesis marker, that is ProC3, and there is the rodent version with the C4M2 and also with the C6M. And what you see are the positive correlations with the cirrhosis staining, again providing a construct validity to this particular model. So in the end, I would say the early phase clinical studies need to incorporate as much as biomarkers as possible. I know it's against the grain when we work in industry to have a very nimble studies, but again, in a targeted way, if our studies are positive, these biomarkers can be banked and can be triggered in a stepwise fashion, and these non-invasive biomarkers would expedite our clinical development. Thank you.
I'd like to thank all three of you for your presentations and ask our reactants to come on up to the stage now while I introduce them. We are going to hear perspectives from a number of people on these same topics, starting with Roberto Cavalli, who's an executive director in the clinical research group at Pfizer and the co-chair of the NIMBLE Biomarkers Consortium. Gregory Everson, emeritus professor of medicine at the University of Colorado Denver School of Medicine and CEO and CMO at HepQuant. Anand Balakrishnan, who's senior staff fellow in clinical pharmacology at the US FDA. Abbas Bandukwala, who's biomedical engineer for US FDA, and Robert Schuck, who's clinical pharmacologist in the Division of Translational and Precision Medicine at the US Food and Drug Administration. And we are running a little tight on time, and we do want to get all these perspectives in. So I'd ask that if you all could make your presentations from the table. I think some of you may have slides, which we're happy to support as well. So starting with Roberto.
Thank you very much. So if we can go to the first slide next. Thank you. What you see here is basically an illustration of the definition of NASH. I am not going to school you on what is the definition of NASH. The only point that I wanted to make with this slide is to remind us of the important contributions of histology in the understanding of the disease, because as we try to look for non-invasive biomarkers, we must not forget the contribution of this particular tool. If it were not for the contribution of histology, we would not be where we are at the present time, with the FDA actually offering us a path forward for an early registration. So it cannot be understated. However, at the same time, as Saurabh was pointing out earlier, there are a number of limitations with this tool. So our intent is to improve on this and to complement this. The issues with the biopsy are not just the issues with the invasiveness and the fact that it can be painful or the complications, but the way I see it, the two most important issues are the variability, because of the sampling and because of the intra and inter-observer variability, and the fact that it's just simply not scalable in order to be able to screen the large population at risk. So it's not about not recognizing the importance of the biopsy, it's about what can we do to complement the biopsy. And the issue that we have as we move forward in trying to look for non-invasive markers is that this variability is not an issue just for the clinical implementation, selection of patients, but also introduces a variable in our ability to validate biomarkers against this reference standard. So that's the hurdle that we have at present, and that we are likely not going to be able to overcome until we have solid data on outcomes that can be then related back to these biomarkers. Yet, biopsy is our bridge. This is where we need to start in order to walk this all the way to non-invasive markers. One important point that I wanted to make is that working together is important to achieve this goal. So the FDA itself has made this point in its guidance for qualification for drug development tools, and they encourage us to work in consortia and in groups in order to collaborate and bring forward the data necessary to validate these markers. There are a number of areas across the drug development timeline where biomarkers are critically important. I wanted just to point a couple. One is the dose ranging. Dr. Kim was talking about the dose selection. And before we get to dose selection, which at present requires histology, we need to try to winnow down those doses that we're going to test. Otherwise, those studies are just too big. So early dose ranging is important. Right now, we have a very good tool for anti-steatotics with MRI-PDFF, but for anti-fibrotics, anti-inflammatories, we still have nothing that really we can use in very early studies. The other point is the very high screen failure rate that we have. So whatever we can do to try to reduce that screen failure rate when we get to the biopsy will be of great benefit to advanced drug development. And it cuts both ways, right? This variability is not just the fact that we may not be selecting, without those biomarkers, we may not be selecting the right patients to take to biopsy, but because of the variability of the biopsy, our prior criteria might have selected the right patient, but the biopsy failed to identify it just because of this variability. So that's an issue that is critical to address in order to expedite therapeutic development. We're not in any dearth of candidates. The issue really is about the qualification robustly. And this is where we need to concentrate, is being able to qualify robustly these myriad of biomarkers that we have as candidates. And this is what has been tackled here by two big consortia, like Litmus across the Atlantic in Europe, that builds on EPOS and other registries to try to understand better the natural history of the disease, and NIMBLE to try to characterize the biomarkers against biopsy in both retrospective studies and prospective studies.
Great. Thanks, Dr. Collier. Next is Dr. Everson.
I think I'm down to 3 minutes.
We'll give you 4.
The first slide. You want to move the slides along?
See, you've got the controller right there.
Oh, okay.
To it.
Yeah, so I'm going to talk a little bit about functional tests and HepQuant just briefly. The functional tests are very interesting because they can assess the hepatocyte function, and then they can also tag the circulations, both the systemic inflow, portal inflow, and even quantify portal systemic spillover. So they can actually become fairly comprehensive. In a study we did at HALT-C, we thought that the dual cholate test outperformed metabolic tests in terms of being able to link to clinical outcomes. And so we've pursued the dual cholate test. In the dual cholate test, you label the systemic circulation and the portal circulation to the right, and this way you can quantify inputs through those circulations to the liver as well as quantify the shunt. And the test relies on cholate uptake only. The compound is a molecular probe, free unconjugated cholate. that is analyzed in its entirety as a spillover, if you will, into the systemic compartment. Another reason we kind of avoided the metabolic approach is that if you look at patients with liver disease, a lot of them take a lot of medications. 2/3 of them were on multiple medications in the HALT-C trial, and I'm sure it's the same in NASH studies, if not more. And smoking is very common in the population, so this can affect the metabolic testing. Now what's shown here on the top is a function map from the dual cholate test with clearance from the oral administered dose on the horizontal axis and clearance from the intravenous dose on the vertical axis. The top map is a functional display, which is a total global clearance value, if you will. And the bottom map is the shunt, the portal systemic shunt. You can see the patterns are quite different, giving you the opportunity to de-link, if you will, functional impairment from portal systemic shunt. So for a given patient or a group of patient, we can actually map out these key physiologic and functional variables. Now the color coding goes from green is a normal population, yellow is mildly impaired, light orange moderately impaired, dark orange transition to early portal hypertension, magenta is more in terms of clinically significant portal hypertension and the emergence of clinical outcomes, and then red is clinical outcome patients, and crimson is you better get to the liver transplant center soon. So if this is all true and what I'm showing you is translatable to NASH and all the other diseases that we've been talking about, it really raises the issue, should function be the new gold standard? Treatment that's approved by the FDA should improve how a person or patient feels, functions, or survives. And a person with a disease that damages the liver feels, functions, or survives based on how the liver functions, not based on how much scar tissue there is in the liver. Yes, scar tissue is a surrogate, but clearly scar is not the answer. Function's the answer. If treatment improves the liver, one thing, if we use these tests, we must be able to detect that improvement and we must quantify it. Trouble with fibrosis stage, we've heard it 100 times. Here's some real data. 174 paired liver biopsies, baseline and 2 years later. This is a cohort of patients with active ongoing Hep C, 1/3 of whom went on to hard clinical outcomes. 2-year biopsy interval could not detect change in this group of patients that's obviously progressing. The dual cholate test picked up highly significant change over the same period of time. Now, I'm not showing you any data, but the patients who progressed to clinical outcome had higher baseline values, and at 2 years, higher 2-year values, and the change was highly significant for the group as a whole and for every single stage of fibrosis at baseline. So can function tests become a clinical reality? Obviously, function testing has some logistic issues. We are working to overcome all of them. But I think function testing can clarify liver health by providing cutoffs for significant clinical risks and can define global liver health that can be useful in tracking patients, either over time, not on treatment, or with treatment. And I think it can be quite useful in the drug development area for ongoing and future pharma trials. Thank you very much.
Thank you. And I'd like to go now to 3 perspectives from FDA, starting with Anand Balakrishnan.
So from an agency perspective.
Oh, a microphone, yeah.
Okay, so from an agency perspective, actually echo what a lot of it has already been talked about earlier by Shirley and Insuk earlier. We highly encourage the use of the biomarker, particularly in the early stages of your clinical development. Again, I mean, I personally view the biomarker as a complement to the histological endpoints. I mean, you can only collect so many histology samples. So, and particularly with respect to the early stage, your early POC study, where you're kind of picking your dose for the dose ranging study, that's also an area where you can actually utilize your biomarker. In a way, I mean, biomarker is like early childhood education, in a way. You kind of put in a lot more effort early in your discovery development program. It'll actually yield you a lot more benefit later. Unfortunately, I mean, there is a bit of a trade-off there. I mean, I was in the industry before, so there's always the push for lean, nimble, early trial. But I mean, I do think if you actually invest in early, particularly for NASH, you'll actually have the benefit of it later. The challenge is from a regulatory standpoint that we have faced is we have not seen consistent data to kind of go one way or the other. So that's why we kind of always recommend go both. I mean, it will help you kind of make more sense of your data as you move along in your development program. So that's all I have.
Great. Thank you for your comments. And next is Abbas Bandakwala.
Hey, thank you so much. I very much enjoyed everyone's presentations. As in the biomarker qualification program, we were always interested and very happy to see this development of these biomarkers. What I'd like to emphasize is when in the biomarker qualification program, when we're looking at to qualify biomarkers, and we're thinking about qualifying biomarkers so that can be used in all drug development trials. And so it'd be, it's very important to think of the evidence that's needed to qualify these biomarkers so that it can be used in these trials, and that includes both the analytical evidence to be able to use these biomarkers and then the clinical evidence. And as everyone's mentioned, there's a lot of these biomarkers, and there's uncertainty with these biomarkers right now. So when you're thinking of the evidence, it's sometimes better to think of using these biomarkers in diagnostic enrichment cases before trying to go for biomarkers to be used for PK or for pharmacodynamic response and surrogate endpoints. That's what I'd like to emphasize. Thank you.
Great. Thanks very much, Abbas. And next is Robert Schuck.
So I'm Robert Schuck. I work in the Division of Translational and Precision Medicine at FDA. And one thing that we're very fortunate working in our group is that we actually work across all the different therapeutic areas at FDA. And what I can honestly say is that I think that there's probably more excitement and more activity going on in the biomarker development space in NASH than there is probably in any other therapeutic area at the moment. And I think that's great and it's very exciting. I think the biggest challenge that's facing us now is moving from looking at these biomarkers for exploratory purposes and trying to generate the data that's necessary to make them more decisional. So Dr. Gupta in his presentation had a nice slide that showed kind of in the early phase 1 studies all the different biomarkers that you can look at and that are being used during that exploratory phase. But as it kind of goes down into the phase 2 and phase 3 studies, there's less specific biomarkers that are being used for those decisional purposes, like your final dose finding studies, as well as your phase 3 studies where you're trying to get registration. So I think developing that data that's necessary in order to use these biomarkers for more late phase decisional purposes is going to be a very big challenge, and I think that it's very exciting to see the studies like NIMBLE and LITMUS that are currently being conducted that will hopefully facilitate some of that. The other thing that I wanted to comment on is I think that it's been mentioned a couple of times today that there's a lot of different areas where biomarkers are needed here. So there's tends to be a big focus in drug development on developing biomarkers for surrogates, and that's great. I mean, surrogates are obviously extremely helpful if we can develop the data necessary to get a biomarker considered as a reasonably likely surrogate or validated surrogate endpoint. But generating that amount of data is very difficult. Now, I think that we should also emphasize developing biomarkers for other purposes. So for prognostic purposes, prognostic enrichment clinical trials can help you have much shorter, smaller clinical trials. That's a huge victory for drug development. It can help test compounds faster, get them to patients faster, and then also ultimately when they're being used in the clinic, you know who really needs the drug and who doesn't. So things like prognostic enrichment, biomarkers can be used, genetic biomarkers for molecular target validation. So there's data out there showing that if you have GWAS findings and things of that sort where there's a genetic polymorphism in your drug target that's related to the disease, those drugs are about twice as likely to make it from phase 1 to approval as drugs that don't have that. So using biomarkers for target validation is another very important way that they can be used. Dose finding, again, I know that we're currently encouraging looking at histology for dose finding purposes so that you know what, have some data on what your final endpoint's going to be. But there's, I think there's some wiggle room in there where you could have enough data on a biomarker that maybe it's not quite a validated surrogate yet, but you might feel comfortable using it for dose finding purposes. And again, that can make those phase 2 trials shorter and more efficient and move us on into phase 3 and getting those registration trials underway. So just a couple of observations based on the presentation so far today.
Great, Robert. Thanks for those comments too. I'd like to thank all of our reactants for their comments and also for doing it very efficiently. So we do have a little bit of time for questions and follow-up comments. So if any of you in the room have comments, please go to the microphones. I'd like to start with one from one of our online participants. And remember, if you're watching us online, you have a comment or question, just email it to liver.disease@duke.edu. And this is, I think, just a clarifying question, Jeff, for you from the presentation at Intercept, and it appears that on the clinical endpoints, 25 milligrams did better than 10 milligrams. However, only 5 to 10 milligrams are approved. Please comment on your impressions about the clinical utility of the 25 milligram dose.
So I think partially we're getting a little bit confused between PBC and NASH.
Yeah.
So in PBC, we see a dose response for the 5 milligram where we see the ALP reduction in maximal at the 10 milligram dose. The 25 milligram dose that I talked about today was very specific for the NASH program. This may come down to that difference in liver exposure.
That makes sense. All right, let me go to the microphones, and please identify yourself when you ask your question or make your comment.
Thank you. Thanks for the presentations. Great. I'm Will Treem from Takeda. And Naga and Greg and others on the panel, we've heard a lot from our previous speakers about hepatic metabolism and transporters. But Naga, you were talking about Child-Pugh A, and maybe there should be a more specific gradation. There, our hepatic impairment guidance is still based on Childs-Turcotte-Pugh A, B, and C. And I think, as you were implying, that we may be really, missing a more specific classification that might inform our clinical trials better if we had that. So again, I'm coming back to HVPG and portal hypertension. I've heard some other of your academic colleagues comment that this is a difficult measurement to make. It's not always replicated. We can't really use it necessarily. But what I'm hearing in terms of functional aspects of liver function and how they influence pharmacokinetics and pharmacodynamics, that maybe HVPG in the NASH population, maybe within that Childs-Pugh class A, is important. So I'd like to hear some comments on that.
Good point. HVPG, I think, can be helpful, but I think it's going to be difficult once again to scale it. It's expensive, and patients really don't like it. I've done several trials with it. So I think there are ways other than HVPG where you can categorize your child's A's into either A5 and A6. I think it's an advance, or into early versus late based on septa thickness and so on and so forth. What do you think, Greg?
Yeah, those are certainly ways to deal with that. And HVPG does have a problem in reproducibility outside of the 2 or 3 centers that can do it really well. But in terms of our testing, we see a huge functional display in the Child's A group, from almost near normal function all the way to a decompensated disease. And within that group, there's a nice cutoff for the group that is at risk for clinical outcome versus those that are not. So we do think, and that's mainly from hepatitis C, but we are seeing an emerging amount of NASH data with some of the trials we're doing, where it seems like we're getting very similar kinds of data there. But we have only outcome data, clinical outcome data in Hep C. We do have some interesting outcome data in PSC, where again the testing does seem to perform well compared to the standard in PSC, which is a terrible standard, ELK-phos. But so it's good that it's such a terrible standard because you can outperform ELK-phos pretty easily. But still, the function testing we do does in fact identify the progressor group, and the change in function even further identifies that group. I think the thing I was trying to emphasize is, if we're going to treat one patient, we have to be able to measure improvement in the one patient. And honestly, I've been a hepatologist 40 years, and the one thing I set out to do with our testing was, can it work in one patient? And we think actually some of the data we have does lend itself to that. So I think that needs to be proven, obviously, with larger experience and larger numbers of patients. But I think that should be the goal, really, is finding something that the change represents a clinically significant change and that the baseline reflects the baseline severity of disease.
Thank you. Please go ahead.
Hi, Giri Turjurai, Clinical Pharmacology, Bristol Myers Squibb. My question is directed to Jeffrey. A great presentation. So you showed us quite a dynamic range of data in terms of the hepatic impairment study, anywhere ranging between 1.1-fold to about 13-fold. And pretty much following up on the prior questioner's comment about A5 and A6 within mild hepatic impairment, do you actually have a good distribution in your mild hepatic impairment cohort? Because I'm looking at the value of 1.1, and that could just be a mean value, and you could have somewhere between 2-fold for a certain individual and less for another. So comments on that?
Yeah, that's a great question, because coming into the program at the time, I just thought you ran these ClinPharm studies and you'd have everything. We did see some variability in the phase 1 study, the first one. But when you pull in that data relative to that in the NASH patient population and even some in the PBC, the distribution is just endless. And it's a little bit of what Dr. Everson was just talking about, which is you find these subjects who have cirrhosis, but their hepatic function seems to be normal based on the PK. And then you have these people who are compensated, but they're so high that you almost wonder if they're almost at that edge of becoming decompensated. And that's something you have in clinical development programs, specifically in cirrhosis, you have to pay very, very close attention to.
But in terms of interpreting your hepatic impairment data and dose adjustment, you currently are not recommending any dose adjustment for milds, correct?
Currently, we're not.
And so that does include A5s and A6. So I just wanted to see if there's a distinction that's being made currently between A5s and A6 within mild hepatic impairment.
Not at the moment.
Thank you.
We have only a couple of minutes left. I'd like to go back to our panelists, so Naga, Jeffrey, Saurabh. Any additional comments you'd like to make based on what you've heard from the reactants, maybe about best opportunities for advancing biomarker use, and would appreciate any further thoughts about Dr. Everson's points regarding functional testing for tracking progression of patients. How feasible is that to fit in more systematically?
I'm not sure if the hepatic impairment studies are disease-specific. And if not, they should be, at least for Charles A. I think what disease you're studying, I think especially if you have active steatohepatitis. So rather than just taking all cirrhotics, and I think that's one thing the attention should be paid to.
So I think on the question of the endpoint, and I'm just going to say this in a very generic way because Dr. Everson pointed it out, but I've been dealing with this for a very long time, and that is it's going to be very hard to correlate these biomarkers to histology. Because although we're here with histology and we're here for a reason, there are limitations to it. And I think the expectation is getting very hard because how as an individual are you going to correlate these things? It's just not realistic. Maybe over time, once the outcomes portion of these studies start to complete, we're going to see a better correlations with them. But until then, we're really looking for that biomarker on an individual level.
Saurabh, any quick comments?
Just to add, as you know, individual biomarkers and maybe the gold standard which we are running against it, maybe it has to evolve, and maybe soluble biomarkers along with the imaging biomarkers together may provide that horsepower to take us to the finish line, depending on what's our context of use.
Okay, great. Thank you. And I'll try to get to 2 more questions before we wrap up, if we can go quickly.
Yeah. Veena Somayaji, statistician from Pfizer. Great presentation, good coverage of all different biomarkers covering functional, physiological, and genetic maybe. None of it is actually predicting, or we don't right now no clear prediction from those biomarkers to the histology part. So my question is, have there been any consideration, any studies done in terms of the composite biomarkers that can maybe more accurately predict as opposed to any of these individual biomarkers? Thank you.
I guess yes, not in a way that's rigorous enough. For example, ELF has 3 matrix proteins, and there are a number of bedside markers, NAFLD, fibrosis score, FIB4. They're using multiple variables into a composite. That's right? You want to comment?
Yeah, so the point is very well taken. I mean, there are currently a number of scores that are used clinically that are based on combining a number of clinical measures. What we are hoping to accomplish is to, if we cannot find a single marker that can describe the histology and therefore correlate to the outcome eventually, can a combination that doesn't necessarily need to be all soluble markers. It could be a soluble marker and an imaging marker or a functional marker in combination. So both of these consortia are planning to do these types of analyses as well, analyze each biomarker individually, and then go across these and see how can we best combine them to give us the best answer.
Thank you. Last question.
Thank you. Nathalie Depreville from Servier Laboratory. I have a question regarding imaging biomarkers in proof of concept studies. MRI, PDFF are widely used in these studies, but regarding antifibrotic drugs, it's more complicated. What is the future of MRE, and how long should be the proof of concept studies if we use this type of biomarkers for antifibrotic drugs?
I mean, an antifibrotic in 16 to 24 weeks, MRE has not picked up. So I can't really, I think we have to look something beyond MRE as we do it now. You know, I know Galectin trial did a 16-week, and there was just virtually no change in fibrosis. But once again, though, it would be hard to actually do correlative studies because we're not doing early biopsies. So you would have to depend on something like ELF or ProC3 to see what's happening to matrix protein. So that's, yeah, antifibrotic early proof of concept studies are tough just because there isn't a surrogate like PDFF or steatosis.
Well, I'd like to thank our panel and reactants and all of you for the excellent comments for a great session before we head off for lunch. Thank you very much. All right, we are now going to take that hour-long lunch break. We'll be reconvening at 1:15. Again, there's some information on options for food in the area, and please feel free to bring something back if you need to. See you in an hour. Welcome back to this afternoon's session of today's meeting on leveraging clinical pharmacology to optimize drug development for non-alcoholic steatohepatitis and cholestatic liver disease. I know we have a few of our in-person participants who are still trickling back in from lunch. We have a whole lot to cover this afternoon as well, so I'd like to get started with our afternoon session. And for our initial presenters, if you're here and could come on up, that would be great, and I'll introduce you right now. This is a session on clinical pharmacology approaches to support dose finding for clinical trials for NASH and cholestatic liver disease. And the discussion is going to focus on the use of these pharmacology tools and methods to support dose finding. We'll discuss modeling and simulation approaches and the utility of adaptive trial design and the relationship between efficiency biomarkers and dose tolerability. So we're going to begin, as we did in the last session, with 3 presentations, and then we'll hear from a number of respondents and have some time for broader discussion with this whole group. Very pleased to have our presenters with us today. Stephen Lee is Clinical Pharmacology Reviewer in the Division of Inflammation and Immune Pharmacology at the US FDA. Ruby Mehta is Medical Reviewer in the Division of Gastroenterology and Inborn Errors Products at the US FDA. And Art Bergman is Senior Director for Clinical Pharmacology and Early Clinical Development at Pfizer.
So we'll hear presentations from each of them, and then we're going to go to discussion with our reactants, and I'll introduce them in a little while. But right now, Stephen, please go ahead.
Thank you for the introduction. Good afternoon, everyone. My name is Stephen Lee. I'm a reviewer in the Office of Clinical Pharmacology. It's my pleasure to have this opportunity to discuss clinical pharmacology considerations in dose selection for NASH and cholestatic liver diseases. So this is my disclaimer. A brief outline of my presentation today. At the beginning, I will briefly present the current trend in drug development and the challenges in dose selection for NASH and cholestatic liver diseases. For illustration purposes, my presentation today will mainly focus on dose selection for non-cirrhotic NASH with liver fibrosis, but the general clinical pharmacology principles may apply to cholestatic liver disease as well, such as PBC or PSC. Following that, I will talk about the dose selection approaches for early phase 2A proof of concept trials, then for late phase 2 dose ranging and phase 3 trials, along with some case examples. There will be a summary slide at the end. Here is a brief summary of the potential therapeutic targets for NASH. As we can see here, a wide range of therapeutic targets are currently being evaluated for NASH, including metabolic modulating agents, drugs with anti-inflammatory effects, drugs can regulate oxidative stress or apoptosis, and also anti-fibrotic agents. In some cases, combination therapy with 2 or more drugs targeting multiple pathways are being evaluated. It should be noted that a drug alone may have 2 or more potential effects, such as a PPAR agonist or FXR agonist. Literature data suggests they may also have anti-inflammatory and anti-fibrotic effects in addition to metabolic regulation. Dose selection remains one of the major questions during IND stage for both early phase 2 and late phase studies, due to distinct challenges that usually encountered with NASH and other liver diseases. Because of the slow progression of NASH, currently liver histological endpoints are accepted to support an accelerated approval pathway. However, this would require an invasive liver biopsy procedure, which carries some risk and challenges in clinical trials. So there is a need to evaluate and hopefully identify and validate non-invasive surrogate biomarkers for assessing clinical efficacy or disease progression for NASH. Currently, there are still uncertainties about the relationship between biomarkers and the histological endpoint. In addition, drug exposure in the liver is generally not available, and this poses a unique challenge in drug development intended for the treatment of liver diseases. Pharmacokinetic information and the biomarker response that's related to target effect from healthy subjects or other patients in the population can be used to inform dose selection to initiate early phase 2A proof of concept trial. At the early phase 2 stage, non-invasive disease-specific biomarkers, liver injury markers, imaging or liver stiffness assessment, or hepatic fat content are acceptable as study endpoint. For late phase 2 trial, a placebo-controlled dose-finding study with multiple dose levels is generally recommended with dose selection based on data from early phase 2A study. In phase 2B trial, histologic endpoint should be used as a primary endpoint, same as in phase 3 trial. Meanwhile, biomarker information is also recommended to be evaluated that may provide supporting evidence with regard to safety and efficacy. Early phase 2 proof of concept trials are desirable to demonstrate intended pharmacological effect and also identify appropriate dose before engaging on intensive clinical programs. I will first discuss dose selection for early phase 2 trials based on PK and biomarker response. PK characterization is useful to inform dose limit, dosing frequency, and also dose escalation approach in phase 2 trial. For a new molecular entity, phase 1 PK studies are generally conducted in healthy subjects, but for NASH, there are also drugs initially developed for other indications, such as for the treatment of hyperlipidemia, type 2 diabetes, or sometimes PBC, may already have some relevant prior PK and PD information. Selection of biomarkers as the primary endpoint in phase 2 proof of concept trials will need to be justified based on the intended mechanism of action. There are generally 3 major categories of biomarkers based on the intended therapeutic effect for NASH: metabolic biomarkers, inflammatory biomarkers, and also fibrosis assessment. Dose response and exposure response relationship analysis using biomarker data are also useful to optimize dose selection. The current FDA guidance outlines the general principles in terms of trial design, endpoint, and also biomarker evaluation. FDA encourages sponsors to consider biomarker development since identification and validation of non-invasive biomarkers could significantly accelerate drug development for NASH. As we can see here, currently many biomarkers, including soluble biomarkers and imaging assessment, are currently being evaluated in the NASH trials. Some examples include lipid profiles, systemic inflammatory biomarkers, liver biochemistry and function markers, fibrotic markers, and also imaging assessment to assess liver fat content or liver stiffness. Please note this slide is not intended to be an exhaustive list. Rather, it provides a brief summary of non-invasive biomarkers that many clinical trials for NASH are currently evaluating to better understand the relationship between biomarkers and the disease progression for NASH. Now I will switch gear to present some case studies. This slide shows an example of dose selection for initial phase 2A proof of concept trial based on PK and biomarker data from phase 1. MGL3196 is a thyroid hormone receptor beta agonist. In phase 1, 5 mg to 200 mg dose was studied in healthy subjects with mildly elevated LDL cholesterol. Not showing here is that plasma exposure of the drug appears to be dose dependent, as we can see here in the change in lipid levels with dose plot. In healthy subjects with mildly elevated cholesterol, near maximal lipid reduction effect was observed at 80 mg once daily dosing for both LDL cholesterol and triglyceride, with no apparent further increase in PD effect when dose further increased from 80 to 200 mg dose. As such, an initial dose of 80 mg once daily dosing was chosen by the sponsor to be further evaluated in phase 2 trial. Of note, 80 mg once daily dosing was also one of the 2 doses chosen by the sponsor to proceed to phase 3. Another example is for dose selection for phase 2B trial based on data collected from phase 2A study. Aramocol is a SCD1 inhibitor. In a placebo-controlled phase 2A study, 100 mg and 300 mg dose once daily dosing was studied in patients with NAFL disease or NASH. Liver fat content was used as primary endpoint in this phase 2A study. As we can see here in the plot on the right-hand side, the reduction in liver fat content appeared to occur in a dose-dependent manner, where 300 mg dose showed a greater PD effect as compared to 100 mg dose. However, it was unclear whether a maximal PD effect was reached at this dose level. So subsequently, in phase 2B trial, the sponsor selected 2 higher doses as 400 and 600 mg dose, considering both biomarker response as well as safety information. Later on, 600 milligram total daily dose was chosen by the sponsor to proceed to phase 3. Generally, a randomized placebo-controlled phase 2b trial with adequate dose response information is recommended to support future phase 3 program dose selection. Given that histological endpoint changes take time, the duration for phase 2b trial should be at least 12 months per the current FDA guidance. Meanwhile, exposure-response relationship for biomarker response are important for study design, dose selection, as well as may provide supporting evidence with regard to safety and efficacy. Here are some examples of the doses evaluated in phase 2 NASH trials and also the phase 3 dose selected for each drug. Looking at the third column on the table for phase 2 doses, it's important to note that for most of these drugs, 2 or more dose levels were studied in phase 2 trials before proceeding to phase 3. Generally, a wide dose range with sufficient treatment duration is recommended in phase 2 trial, since this would provide maximal information to guide phase 3 dose selection. To summarize, there is a lack of validated non-invasive surrogate biomarkers that is predictive of clinical benefit for NASH at this time. However, better understanding of PK and PD markers with regard to the mechanism of action is useful to guide initial dose selection for early phase 2 proof of concept trials. For late phase 2 trials, multiple dose levels are recommended with histological endpoint as the primary efficacy endpoint. In addition, biomarker evaluation may provide supporting evidence with regard to efficacy and safety. Dose response and exposure response analysis utilizing biomarker data can also provide critical information to optimize dose selection. Finally, I would like to thank my colleagues and also the FDA Workshop Planning Committee for their review and comments provided for my slide. So this concludes my presentation today. Thank you for your attention.
Thank you. My name is Ruby Mehta. I'm a medical reviewer in the Division of Gastroenterology and Inborn Error Products. And I'll be switching gears and talking a little bit about biomarkers and surrogates in drug development for both the NASH and cholestatic liver diseases. This is my disclaimer. So a biomarker is a defined characteristic that is measured as a normal indicator of normal biologic processes or pathogenic processes or response to an exposure or intervention, including therapeutic intervention. And a biomarker could be anything, right? Not anything, but molecular, histologic, radiographic, or it could be a physiologic characteristic. It's important to note that a biomarker is not an assessment of how an individual feels, functions, or survive. Because different people were using their terminology different ways, and they were not clear on what was being said. Therefore, FDA and NIH Biomarker Working Group put together the glossary of terminology for the uses of biomarkers and endpoints in basic research and clinical research. And the best resource is available at the NIH website. So best definitions, there are many definitions that they have provided. However, I would bring your attention to the pharmacodynamic response biomarker, which indicates a biochemical response that has occurred in a patient who has received therapeutic intervention. Now, that may end up becoming a clinical trial endpoint for a very small subset of patients or for the whole clinical trial as a surrogate endpoint, but it's not necessary. A pharmacodynamic biomarker could be a biomarker, standalone biomarker, and the surrogate endpoint may be different in a clinical trial. So the question is, what are the regulatory considerations for a biomarker use? Although biomarkers are used in clinical practice, they're used in basic science, they're used in research. However, for a regulatory acceptance, the questions that one has to ask is is the biomarker clinically valid? And the term valid is so different for different people. The only advice that we would have, or I would have at this point, is that as soon as you figure out this is a biomarker you would want to use, engage with the FDA early on so that we could guide what needs to be done. Then reproducibility of the data. So there's a high rate of discordance between the conclusion of the biomarkers in the published literature. So that needs to be resolved during the drug development or before the drug development. Is the adequacy of the analytic device or assay to assess the biomarker accurately and reliably. Now, this is extremely important, especially if the assay is guiding the drug development or the device is used in the clinical trial to either enroll the patients or during the trial itself. And then, is the biomarker feasible? Switching gears, approval pathways. So, as you all well know, there are two pathways. One is your traditional or full approval. And the evidentiary framework requires substantial evidence of effectiveness through adequate and well-controlled clinical trials, typically 2 or more. And the efficacy endpoints is a direct measurement of how a patient feels, functions, or survive, or validated surrogates. So, for example, survival is clearly survival is a direct endpoint, then patient-reported outcome is how a patient feels, and the disease-free survival is morbidity, and hypertension and hemoglobin A1C are validated surrogates. To ensure that the therapies for serious conditions are approved and available to the patients, and as soon as it can be concluded the therapies benefit justify their risks. To meet that, we have two pathways. One is we have one pathway, accelerated approval, but we have for both drugs and biologics. And then again, the evidentiary framework requires similar substantial evidence of efficacy through adequate and well-controlled studies. So the standard for effectiveness and well-controlled investigation stands true for both the pathways. May be granted based on surrogate endpoints that are reasonably likely to predict clinical benefit. Generally, drugs approved under accelerated approval pathway requires a confirmatory post-marketing trial or trials to verify the clinical benefit, which should be typically underway at the time of drug approval. Switching gears again to endpoint considerations. So a correlate is not a surrogate make. So what are the features or the criteria for surrogate selection? It should be measurable, it should be interpretable, it should be sensitive, and on path to the clinically meaningful endpoint. So FDA accepted histology as a surrogate endpoint, and the paper from Angulo et al., and there was also a paper from Eksted et al. From Sweden, both the studies demonstrated that the patients who had cirrhosis had poor outcomes, clinical outcomes, compared to patients who had no fibrosis. And all the patients in between ranged, and there was a linear increase in the mortality based on the degree of fibrosis. So we, in the studies so far conducted, have shown that fibrosis stage, but no other histologic feature of steatohepatitis has been associated independently with increased mortality, liver transplantation, and liver-related events. Currently, there are no data to support that one-stage reduction in fibrosis is clinically meaningful. This is a theoretical assumption. However, most of the trials would be required to do a confirmatory trial to prove that it does lend support to this theory. So the limitations of surrogate endpoint. If a surrogate is on the causal pathway, which is modulated by the intervention or the drug, then the picture seems pretty clear as seen on right-hand side. However, if the surrogate is not in the causal pathway, or if there are multiple pathways leading to the outcome, biomarker may or may not reflect the key pathway. However, if the surrogate is not on the path entirely, and if the adverse events occur on the desired clinical outcome path, or if there are toxicities that that the drug leads to the drug or intervention leads to the toxicity, then biomarker may not reflect the benefit and the risk. So there's a gamut of NASH biomarkers available currently, and as you can see on this slide, however, it is important to note that one biomarker that could be used in one stage of the disease may be more specific to that particular stage, and for the next stage of the disease, we may have to move on with the assessment with a different biomarker, and one biomarker may not be a surrogate for the whole total spectrum of the disease. In addition, as the disease progresses from non-cirrhotic to compensated cirrhosis to decompensation, again, the biomarkers may vary by the disease stage. So generally at the FDA currently, this is what we are accepting for early phase. We accept surrogates based on mechanism of action of the drug. We do accept the liver biochemical endpoints, knowing that they are not predictive of histologic changes. Imaging biomarkers for measuring fibrosis, such as elastography or MRE, or measuring fat with MRI, PDFF, or MRS. For phase 2b trials, it's highly recommended that biopsy be used. Could consider doing NAS versus other scoring system. For phase 3, again, a biopsy is currently being the gold standard is what the FDA is recommending, and the endpoints proposed in our guidance include improvement of fibrosis by at least one or greater than one stage with no worsening of NASH, or resolution of NASH with no worsening of fibrosis, or both, improvement in fibrosis by one or greater than one stage and resolution of NASH. For phase 4 trial, all the clinical benefit endpoints are included, plus there is progression to cirrhosis on histopathology that is accepted at this point of time for a full approval. Moving on, changing gears, I do want to discuss that we have limited biomarkers for we have limited biomarkers for drug development in both compensated and non-compensated, as well as non-cirrhotic liver diseases. And other challenge that we have is we have limited biomarkers for detecting drug-induced liver injury. So new molecular entities pose a risk of unknown off-target effects. An assessment of drug-induced liver injury can be challenging even when the drugs are being developed in patients with normal liver undergoing treatment of chronic diseases. And in subjects with pre-existing liver diseases, assessment of drug-induced liver injury is even more challenging because you have not only the confounding effect of the disease progression, also these patients are on multiple medications. So that makes it very difficult. So the challenges that we have encountered so far, there are many challenges, but these are the key challenges that we have seen in the past few months. One is to differentiate liver adaptation from liver injury in the early stages of drug development, which can be which we can overcome by the phase 2 and phase 3 trials. However, there are limited biomarkers. We only have liver biochemistries, and we only have liver biopsy. And what do you do when there's a lack of concordance between the biochemical biomarker and the presence of liver injury? And then timely recognition of cholestatic type DILI. Sometimes we don't get to do biopsies until later, and at that time, the disease is way far gone out. And doing a liver biopsy on a repeated basis during the clinical trial is not even feasible. So lack of biomarkers for detecting DILI is another challenge. I thank the liver team and Dr. Omokarov, as well as the whole DGIEP. Thank you.
Hi, I'm Art Bergman. I'm from Pfizer. Thanks for the invitation to speak at this event today. What I'd like to review today is dose selection strategies using clinical pharmacology toolbox. I'll give some examples about what we have used so far, but also we'll talk about combination therapies, which I know we talked about a little bit about previously, and how we may go about dose selection in that realm. So when I think about clinical development and the use of clinical pharmacology in NASH, in many ways I would say it's not terribly different in concept from other areas. And by that I mean that the clinical pharmacology toolbox can be used, ranging from preclinical up to phase 2B and 3. So it starts with animal PK data where we can use translational modeling to predict what's going to happen in humans. Then in phase 1, which is being early clinical development, we spend a lot of time on this of trying to find not only the PK safety tolerability, but it's always good to have some kind of target engagement to know how well you are modulating your target. Without that, it's very difficult to interpret the data from phase 1. Based on that, we would typically model that to end up in phase 2A, which we think of as proof of concept, proof of pharmacology, using exposure response, and then move on to phase 2B and 3, which are typically registration endpoints. So for NASH, that would be your biopsy endpoints. And along the way, there's dose selection in each of these transitions, I would say. So as an example, I'd like to talk a little bit about something in our development pipeline, this ACC inhibitor, PF1304. So this compound works essentially by inhibiting ACC. And to make a long story short, I know I don't have a tremendous amount of time, but what would happen here is you would decrease de novo lipogenesis in the liver, which would hopefully decrease liver fat, but would also have other effects that are somewhat perhaps anti-inflammatory in the liver. The issue with this mechanism, however, is increase in lipogenic gene expression, SREBP. So you have a potential specifically for increased triglycerides. So at the time when this program went into phase 2, we were aware of other data with another ACC inhibitor where we saw that the compound decreased liver fat quite substantially, but it did increase plasma triglycerides. Now this was at a DNL inhibition that was very high. Our hypothesis was that we'd be able to find an amount of ACC inhibition that would be therapeutic without running into these challenges. So what kind of DNL inhibition did we think we needed? Now that we go back to literature on this, there's some information that DNL is high in those with NASH and NAFLD versus the regular population. And based on those data, we came up with the hypothesis that we need to decrease de novo lipogenesis by 70%. And we thought that could be therapeutic in terms of lowering liver fat. When we designed our phase 1 program, I won't go through all the details in general, but in our phase 2 multiple ascending dose study in healthy subjects, we did incorporate the ability to measure de novo lipogenesis in that population. And this was done by essentially giving deuterated water, and you can follow the incorporation of that into triglyceride palmitate, which can then be measured, and you can determine the amount of de novo lipogenesis that occurs. Now this happens, as many of you may be aware, de novo lipogenesis is variable during the day, so what we do is give constant fructose stimulation that kind of evens it out, and you can get a good measurement of DNL and percent inhibition of DNL. So that's what we did in our phase 1 study, so we could look at target engagement. Now, going back to our hypothesis, is we were hoping to find a level of DNL inhibition where we wouldn't see these increase in triglycerides. So on the plot on the left there, you can see DNL inhibition. It's on the left axis. And you can see there that we get down to about 70%, 80% inhibition, where we have really no effect on fasting serum triglycerides. And we found in this population, it was almost an all or none phenomena where you have at the lower doses, no effect on triglycerides. At the higher doses, you saw about a 40 to 50% increase in triglycerides. Quite remarkable, but based on this data, it looked like that there was a window where we could inhibit DNL quite substantially and not increase triglycerides. Just very briefly, there was another issue with the ACC mechanism, is that if you have too much ACC inhibition in the periphery, it can inhibit platelet production. We saw that with the previous compound we had in development, PF157, where in phase 1 we saw decreases in platelets, all within the normal range. But we didn't really, but we did notice that we saw these decreases. Going back and looking at the biology behind it, we did find that ACC inhibition does inhibit megakaryocyte transition into platelets. So the later stages of the megakaryocyte maturation process, ACC inhibition tends to not allow that, hence the decrease in platelets. So a lot of preclinical data on that and show it in the monkeys as well. And I'll show you here what we saw in our study. We went back this 1304 compound, which was liver selective, and we hoped to have a better therapeutic index between the platelet effect and the DNL effect. And we did indeed see that, where we saw very little platelet effects. If you look at the plot on the left versus de novo lipogenesis, platelet effects were only seen very small changes at very high concentrations. What we did is we used a semi-mechanistic model to model this, because one issue with this was only a 2-week study. With the maturation of platelets, it could get worse over time. So we wanted to have a semi-mechanistic model where we kind of extrapolate out to later times, so we knew we'd be safe in phase 2. So putting all this together, we did a lot of different kinds of modeling: exposure, dose response for triglycerides. We had the semi-mechanistic model for platelets, and also another model for de novo lipogenesis versus dose. And we came up with the figure on the left here to show what each of them were doing. And we can look at doses all together to determine, what dose is appropriate for phase 2. Now, for phase 2A, we were looking to find doses where we would have liver fat lowering without too much triglyceride increase. And as you can tell from the purple lines there, we chose doses from placebo up to 50 milligrams QD in our phase 2 study. And this we thought would give us an understanding of our therapeutic index versus the triglyceride increase. Now, just briefly for our phase 2 design, we then used this data to go into a 16-week study in NAFLD patients. There was 2 kinds of population in this study. We weren't going into a biopsy study, so we weren't really having biopsy as an entry criteria. But we also wanted to study some patients that would be representative of those that would be in the eventual biopsy study. So therefore, we split our population into NAFLD patients, essentially those with the high liver fat, and then there was a presumed NASH cohort where a constellation of their laboratory values, FibroScan, etc., would suggest that they were probably more NASH than NAFLD. So we wanted to make sure that we had enough of those subjects to understand what was happening in a population that was closer to our eventual target therapy population. Here is the results that we observed in that study for MRI-PDFF liver fat. Another thing is we didn't really know how long we had to go to find out the maximum effect on liver fat. We ended up going to 16 weeks and looking at a time course. So as you can see across the time course, we saw improvements up to 12 weeks where it plateaued from 12 to 16 weeks. That kind of gives us an idea of how long we have to measure liver fat, at least for this mechanism. We saw a nice dose response there with pretty substantial decreases in liver fat at the highest doses tested. Another way of looking at it is the number of patients that you reduce 30%. That's been thrown out there as a target for something that may be effective as an anti-steatotic. And of course, we saw dose-dependent reductions there as well. Going over liver function tests. Now, things aren't always that easy. So what we saw was a decrease in ALT and AST, an increase in alkaline phosphatase and GGT. And really that tells you that there's things moving in different directions. And really, how do you interpret that? All these biomarkers together, it's difficult to say. I know I'm a little bit shorter on time, but also you have a lipid effect as well. So we saw an increase in triglycerides pretty much at all doses. So we didn't really see a separation from liver fat and triglycerides as we had hoped. It's possibly due to being a different population, but we did see changes in LDL cholesterol, decreases in LDL and HDL cholesterol, and also some changes in total cholesterol. Again, with this kind of data set, it's difficult to say exactly the long-term implications because, of course, lowering LDL is good. Triglyceride increases could cause problems. So it's really not as easy as looking at one biomarker a lot of times and determining the way to proceed. I would also just also point out that we did have, in addition to what we already talked about, some changes, some encouraging results in some of the other biomarkers. CK18 and M65 suggest potential for improvement in biopsy endpoints. So again, we have a lot of different biomarkers that we have to find a way to, interpret all together. Now, in terms of combination therapies, that's the next thing I'd like to talk about a little bit. For 2 NCEs, because obviously for NASH there's nothing that's approved so far. So if you're going to do a combination, it's going to be pretty much with 2 NCEs. And we looked at the FDA guidance. There has to be a strong rationale with data to support it. But I think the key parts would be that either you need to show additional efficacy for both of them and show it's better than that one of them isn't viable, or in some cases perhaps to mitigate something that's happening with another agent. So to give one example of that is potentially using a DGAT2 inhibitor, which is also in our pipeline at this point in time, versus ACC inhibitor. So a DGAT2 inhibitor, also is thought to lower liver fat, but it has an opposite effect on SREBP. So it could offset the effect of SREBP that is seen with the ACC inhibitor and potentially mitigate the triglyceride effect that is seen. So what we have done is a lot of preclinical data to support this theory and also run a clinical DDI study. Right now, a study looking at essentially high doses of both of these in a clinical study is ongoing to see if, what the liver fat reduction would be with these in combination versus the entities alone, but also effects on lipids and other endpoints that we looked at. So there's a lot of challenges for dose selection for the combination therapy. So if you wanted to do a definitive study, looking at a factorial study, it would really be a lot of arms, because if you need each component alone, and then you dose range 3 doses for each, you're looking at a 16-arm study. That's really not possible to do for the most part. So I think we have to really use PK/PD principles to pick those doses. Where on those dose curves do we have to select doses in order to have the most meaningful data, the most useful data to determine doses moving forward into future studies? So we could use conventional PK/PD, but I'd also have to say that QSP gives you some idea of a more mechanistic approach to selecting doses, because, like for example, in this model, ACC and DGAT could be used together. You could look at the doses and the effects of both of those to see what would happen with various endpoints. I think this is an area that needs, I think, more work within our area to understand mechanistically what's happening for NASH, but an area of promise that could be useful, especially for combination products. So in summary, I think we've shown that clinical pharmacology toolbox, a lot of tools that are already in our toolbox can be used for NASH. One of the things is different responses in different populations. So you have healthy subjects, you have patients NAFLD, NASH, especially for these metabolic disease, you may find different responses that need to be understood. Right now, there's no clear way to predict the registration endpoints based on 2A, and I know there's been a lot of discussion on that, but that's really one of the issues right now is there's nothing I can get out of my phase 2 data set that gives me a lot of confidence of what's going to happen with biopsy. And there's also a lot of challenges with combination dose selection. Perhaps using QSP or PK/PD analysis would be of help. Thank you.
All right, thanks Art, and thanks all three of you for your presentations. We're going to turn to our respondents, but I actually have one, I think, clarifying question on the last presentation from one of our online participants, and that is, since the responder rate improvement is low, treatment versus PBO effects less than 10 to 15%, and the requirement of longer duration of treatment to show histologic endpoint, it's very challenging to obtain differentiable effects of histology endpoint during the phase 2 studies in response to the dose range. When the endpoint histology is so challenging, what other options are available to consider in designing phase 2 studies in order to shorten the duration of the trial and test multiple dose levels? If, Art, did you follow that? And then while we're responding, maybe the panelists could come on up.
I'm not sure I followed that exactly,
Yeah.
but I think it really for phase 2B and 3, I think the idea is you need the biopsy studies, and I guess there's questions about how long those need to be, but I think you're looking at least like 9 months to a year. So I'm not sure there's any way with the current strategies to be able to make those shorter. I wish there was. If that's part of the question,
I think that is the point. Yeah, thank you. Thanks. So I'd like to turn now to our reactants. So we're going to hear from each of them, starting with Ajit Das, who's Associate Medical Director at Genentech, Claudia Filizoff, who's Vice President and Liver Therapeutic Area Head for Covance, John Frank, who's Vice President, External Scientific Affairs and Global Project Lead for Madrigal Pharmaceuticals, and Yaning Wang, who's Director of the Division of Pharmacometrics in the Office of Clinical Pharmacology at the US FDA. And Ajit, if you could go ahead. Do you have slides?
No,
okay.
Good news is I don't have it.
Okay. Please go ahead.
Thank the organizers for having me here, and I'd like to thank the panelists because it was a really great session.
Yeah.
Okay. I'd like to thank the organizers, and I would like to thank the panelists. It was a really good session with a lot of case studies and a lot of background also around biomarkers. What I'd like to sort of try to cover here in my comments is some of the perspectives from the standpoint of someone who's involved with early development, especially, we talked about 2A. I'm really talking about what we call 1B, transitioning to 2A, because I think a lot of companies are kind of trying to make decisions also at that stage. What should they be moving forward? I think one nice slide which I saw this morning which comes to mind was one which was shared by Shirley, where she really showed the PK and PD aspect of it, one being around compound characterization and the other being around target characterization. I feel from the standpoint of early development, when we are really working with a lot of doses and trying to narrow down, and as Arthur said, we are doing this whole dose selection at every stage. It sort of comes down. I think the third component, which also really sort of complements these two, is really around safety and tolerability. And some of these could be because we really want to push the dose range as far as possible to understand even potential for any unintended effects. And I think really the three of them really come together. And from the standpoint of early development, at least some of the perspectives I have are from the standpoint of a large molecule in development, because that really makes a difference between when you're thinking about a small molecule versus a large molecule. Some of the issues we've talked about today might be more valid for small molecules. There might be other issues which are more relevant in large molecules, and this could either relate to the fact whether your compound is metabolized by the drug, because we talked about the importance of hepatic function in terms of how it impacts the disposition. So sometimes with large molecules you could get around some of that. But then there are other aspects which are related to the fact that with large molecules you often have long half-lives, and so your considerations are a little different when you're thinking about what kind of variability you have, and that really sort of factors into this whole decision when you're going through dose selection and kind of narrowing down. Looking at the other aspect of it, the PD aspect of it, I think we've spent a lot of time talking about biomarkers. One message which has really come through very clearly is we are talking about this morning we talked about 132 INDs and talking about 35 targets. And so obviously it's not one size fits all. And this really comes into the fact that the biology is complex here. You're talking about steatosis, you're talking about inflammation, you're talking about fibrosis. And so I think your choice of PD biomarkers really ends up being different depending where you are. In the case of our program, we were focused on the metabolic side, the steatotic side. So, we used a combination of biomarkers which are focused in that bucket, combined with some of the more distal downstream biomarkers like ALT, AST, as well as ProC3, which, it's interesting because even though we think of ProC3 as a fibrotic marker, if you move the metabolism side of things, it does filter down. And so we used a combination of both of those, along with an imaging biomarker, which was PDFF, as early as the phase 1B, because we really wanted to get early proof of concept. But just echoing what some people have already said, I think at the end of the day, the combination is important. But I also think for many people here in the room, it's important to learn from the mistakes or the learnings of people who've been treading before you. Like, I think the stories which you shared from Pfizer, I think that is really helpful from the perspective of anyone else coming down the line. Before I end with the safety part of it, I'd really like to say again, the whole intent early on is to sort of push the dose and understand where we can go further with this. And sometimes it might require creative approaches looking beyond just the clinical data. It might require a lot of QSP, as you said, where you may not be able to design a clinical trial to address some answers, but then, QSP might help you in that aspect. But I think it's important to keep in mind also when we are doing QSP, we need to have the right inputs for that, because it's really the data which goes in informs what comes out of it. And I think that's an important assessment to keep. I did see this time sign go up, so I think I'll end with that, and I'm sure a lot of the other aspects will get covered by the other speakers.
Thanks, Ajit. Great discussion. Next is Claudia.
Can I have the...
Yes.
Thanks for the organizers as well. So I'm planning to share with you today only 3 slides just to facilitate the communication, and the objective is to share the potential advantages, but also the limitations of having these dose finding proof of concept studies as part of an adaptive design with a specific focus in this indication. I'm bringing a couple of examples, one in pre-cirrhotic patients and a second one in cirrhotics. So basically, as we all know, and it has already been said, in these early proof of concept studies, biopsy endpoints are in general not feasible. And a combination of disease-specific and mode of action-specific biomarkers allow to collect early target engagement and exposure response and facilitate decision-making and moving to next steps. In general, in these studies, patients that are called suspected NASH, as Arthur said, or presumed NASH, or at high risk of NASH, or as it has recently been described, non-invasive biomarker-defined phenotype. Whatever we want to call the situation is that they are not defined. The different sponsors use different definitions, and the main limitation is that we do not enroll patients with biopsy-confirmed NASH. So one alternative option, and this is, okay. One alternative option is to have those findings study proof of concept as part of an adaptive design. So in this case, patients with biopsy-confirmed NASH and fibrosis are enrolled, and an interim analysis allows an early look of the data and will result in pre-planned, pre-specified adaptations, including randomizing more patients or stopping one or more active arms, and continuing the study for additional weeks up to 48, 52, or 72 weeks, and get histology endpoints that will inform the phase 3. So in in some cases, a therapeutic index function or utility function. Basically, this is a mathematic model that allows to link different endpoints from the different stages, but also from one stage itself. This is something that it's used in oncology and other indications, but not so much so far in NASH. So basically, just to summarize the potential advantages, we are enrolling in this case patients with biopsy-confirmed NASH earlier in the development program. We have the opportunity to evaluate the data from different stages with a combined analysis, and this mathematical model may increase the optimal dose finding. And also, in some cases, we can reduce the overall sample size, but even if we don't reduce, because it depends on the methodology and the adaptations that we are planning, but even if we don't reduce, the same subject can move from one phase to another, and obviously reducing the need to find additional subjects and a continuous and long-term follow-up. There are obviously several limitations, and mainly related to the longer setup time, the higher initial cost, mainly associated with the operational complexity, and obviously the need to control for statistical and operational bias. And finally, and this is my last slide, I wanted to bring this study that there was a recent press release communicating this high-level study design that was not still aligned with the agency, but this is the belapectin proposed phase 2/3 adaptive design. So for those of you who are not familiar with the study, in the previous phase 2 study, the belapectin failed to demonstrate an improvement in HVPG in the overall population of patients with mild and significant portal hypertension. But they did a sub-analysis in the subgroup of patients without varices at baseline. And in fact, in that subgroup of patients, there was a significant reduction in HVPG. But there was a clinically meaningful and significant reduction in the incidence of new varices, and also a significant reduction in the inflammation and ballooning scores. So in order to get confirmation of those post-hoc data, the sponsor decided to design this phase 2/3 adaptive design that could allow to explore one new dose. They explored 2 and 8 milligrams, and they are planning to go lower with 2 and 4 milligrams. And the interim analysis will allow getting additional confirmation of the data that was observed in the post-hoc analysis of the phase 2. And in case this is confirmed, they're going to have pre-planned adaptations, including randomizing more patients and stopping or continuing with the most promising dose and stopping one of the active arms and changing the randomization rate as well, and potentially the patient population, because this sponsor, they have not completed an hepatic impairment study, so they are planning to complete an hepatic impairment study. So that's why at the beginning they are planning to enroll patients with Child-Pugh 6 or below, and potentially, depending the study, they can enroll patients with 7. So the study is planned to continue for at least 18 or 24 months with a final analysis, including incidence of varices, but also some additional outcomes. And this can lead either to accelerated or final approval, depending the final set, the final combination of biomarkers. And the need of a phase 4 will basically depend on that. So just to finalize, the adaptive design can serve not only as dose finding and in early trials, but also in this case when there is some post-hoc data and there is still need to get additional confirmation, it can serve as a first stage before moving into a longer and larger phase 3 trial.
Okay, thank you very much, Claudia. Covered a lot of ground there. And next is John.
Thanks, Mark. First, I'd like to say thanks to Stephen Lee from the FDA, who used Madrigal 3196 as his first case study. So you did all my early work for me. That summarized our phase 1 lipid data and, in essence, showed how 80 milligrams became our going-in dose for phase 2. I have a few slides that I'm going to present that come from our recent Lancet paper and then from our recent presentation of an extension study that was done in phase 2. I'm going to emphasize biomarker responses according to dose exposure relationships, speak a little bit about a liver biomarker called sex hormone binding globulin, of course talk about hepatic fat and the MRI-PDFF data, and then how that all, in phase 2, we looked at the correlation of that results to NASH resolution. So this is the high-level result graph and image from our phase 2 data. And the data shows in the outcome phase 2 is primarily focused on demonstrating an effect on hepatic fat. That was our primary endpoint at 12 weeks, and we repeated the measure at week 36, and then we had a repeat biopsy as a secondary measure. The phase 2 study was an adaptive exposure-based dosing design where patients had a week 2 PK assessment, and at week 4 either stayed on 80 milligrams or if their exposure was above a predetermined AUC, had their dose dropped to 60 milligrams. And patients stayed on those doses that were determined at that point in the study, pretty much for the remainder of the study. Exposure data were blinded to all study personnel. And first we looked at the effect of resmetirom on our imaging endpoint at 12 and 36 weeks, and then at the MRI PDFF response by final resmetirom dose group, 60 or 80, which is what you see here. So all doses are the middle, and then the split outs of patients at week 36 on 60 and 80 milligrams. And we showed a good effect and a dose-related effect even in this small sample size. Images of one patient up above who actually normalized the liver fat by week 36. Next slide. MRI-PDFF has been shown by multiple groups, including several of our good colleagues at Duke, to correlate with histology-determined steatosis grade in adults with NAFLD. Also, there's a growing consensus that a greater than 30% relative reduction in MRI-PDFF hepatic fat predicts NASH response. Slide 2 shows how resmetirom exposure, when divided into high and low exposure groups, the high exposure group predicted greater MRI-PDFF responders. Additionally, there's a marker, an enzyme in all vertebrate livers except for birds. It's called sex hormone binding globulin. And this is a specific liver target of thyroid hormone. This was assessed as a potential marker of the hepatic exposure to resmetirom. So in slide 2, you can also see how resmetirom treated patients with pre-specified greater increases in sex hormone binding globulin. The high SHBG group predicted greater MRI-PDFF response. Next slide shows that among these three markers, exposure, SHBG, and MRI-PDFF, while exposure and SHBG were predictive of NASH response, MRI-PDFF response was vastly more and most predictive of NAS response. In fact, there were zero patients who were not MRI-PDFF responders who were also NASH responders in our phase 2 study. Even for the few placebo patients who were NASH responders, this was the case. So a key takeaway when we looked at our data this way was that 60 milligrams is an effective dose in some patients who have higher plasma drug concentrations, But on the basis of these results, it's not predicted to be a minimally effective dose, which we would define by at least 50% NASH or lipid response across the population. Help.
You gotta get the...
Mouse. Thank you. Our phase 2 patients were eligible for an open-label 36-week non-biopsy extension study if their liver enzymes had not completely normalized. Treatment and dose were blinded at the time of entry into the extension study, with an unblinded reviewer assigning dose until the main study was unblinded. We had 14 former placebo and 16 main study resmetirom-treated patients who entered this study. PDFF at the time of the initial treatment with resmetirom was considered the baseline in this assessment. You can see the primary efficacy population included those former placebo patients and resmetirom-treated patients that had a dose increase to 80 milligrams, all on at least 80 milligrams. 7 of these patients actually had a dose increase, and it remained as a fixed dose to 100 milligram. And although these are small patient numbers, as we know, it was comforting to see a dose response across those 2 doses in liver fat reduction. In addition, and on the left side I'll point you to, this is all the patients obviously included in here from the extension study. We saw decreases in liver enzyme over time that coincided with continued increase in sex hormone binding globulin, which I mentioned was a rough marker of liver concentration of resmetirom. And that's my final slide.
Great. Thank you very much, John, for the presentation. And next is Yaning.
Okay, first, I would like to thank the meeting organizer for inviting me for this interesting meeting. Actually, I think you have heard so far all the challenges in this area. Maybe I can add more. Our division from the FDA, Division of Pharmacometrics, is mainly responsible for the quantitative aspect of dose, exposure, biomarker, clinical endpoint relationship, for the ultimate purpose of optimizing dose for the general population or subgroups or even individual patients. So one of our main responsibility, during the years was to quantify the relationship between the biomarkers and the clinical endpoints across all the disease areas. In the early years, we did this for example, lung cancer. We tried to link early tumor response with the overall survival. Then we did this with a lupus, that is, for example, the double-strand DNA antibody with clinical endpoint like renal flare or bone mineral density versus fracture. We did this across multiple disease areas, but we haven't done anything for NASH, mainly because we're still learning. So during this process, what we learned was, to design a successful or to pick a successful dose for the late phase trial, a key or very important relationship is this: how much biomarker is needed to, change the clinical endpoint in a meaningful way so that you can use a limited sample size in the phase 3 or late phase trial to statistically demonstrate that or prove that. And I still remember, almost 15 years ago, I was reviewing this, one of the early lupus drugs. Again, lupus is another area. You don't have many drugs even today. I remember, again, that was a new area. People don't know the relationship between some biomarkers, even though that is widely used in the clinic to judge, whether steroids or all those off-label use drugs are working. But when you come to demonstrate a new drug is improving the clinical endpoint, just improving the biomarker by, for example, 20% or 30% may not be enough. That actually was the major reason for the early sponsor to eventually fail actually 3 phase 3 trials. Earlier the dose was too low, but the endpoint, the biomarker endpoint, was consistently reduced by about 30% across all the 3 phase trials. And later we learned by analyzing the biomarker reduction and the clinical endpoint relationship, we realized you need a much higher, more sustainable biomarker response in order to change or improve the clinical endpoint within, for example, a limited sample size, so that you can convincingly demonstrate that. So that lesson, and plus other biomarkers and clinical endpoint relationship from other disease areas, taught us that whenever we enter a new area, for example, like NASH, you can demonstrate, let's say, fat content is reduced, other biomarker is improved by a certain percentage. You even demonstrate a beautiful dose response. In fact, in the lupus, they also demonstrate a very beautiful dose response. But it turned out that the maximum response the drug can achieve was still not enough to change the clinical endpoint in a meaningful way, so that they can demonstrate that with, let's say, 100 per arm phase 3 trial, unless you can do a huge phase 3 trial. So with that, another point I want to highlight is, when we're dealing with a disease or endpoint that can be influenced by so many factors, you heard in the morning, this is not like hepatitis C, it's the virus. It's almost like a lifestyle or aging disease. So many factors can influence the ultimate clinical endpoint. Therefore, expecting to achieve some clinical endpoint by changing one pathway or even two pathways, it may not be realistic, because the clinical endpoint outside, the ultimate clinical endpoint is influenced by so many factors. Therefore, when you only modify one pathway, all the other factors are serving as noise, in the end, in your clinical trial or in the phase 3 trial ultimately. Therefore, to beat this noise with a signal, you either need a huge sample size if the signal is small, or you need a very large signal by changing probably simultaneously multiple pathways. Therefore, we heard some failed example in the news. I would not be surprised we'll hear even more failed examples, because this is a natural process. Just like when we collected this kind of failed example in the lupus area, before we can collect enough biomarker clinical endpoint relationship data to figure out not only what are the relevant and the correct biomarker or a panel of biomarkers, but also the magnitude and the duration of the biomarker suppression or modification in order to achieve a clinical meaningful change. Thank you.
Great. Thank you, Yaning, and I'd like to thank all of you for your presentations and comments. So we do have time for some comments and questions from those of you here while waiting for people to come up or to email us online. Remember, it's liver.disease@duke.edu. Maybe I could go back to our original speakers or the other panelists and pick up on, I think, the important points that Yaning was making at the end based on these discussions. I mean, look, if the goal is to get to more limited sample size in the late stage trials and not have a very long study, we've talked about a lot of mechanisms to try to get there and to get the doses right, but it does seem like a challenging disease area. So maybe any reactions to where we are in this process, or any suggestions that you all have about some of the most promising ways to get there? Can some more of the adaptive designs or other innovative designs, like Claudia was talking about, help? Are there other approaches that could help in targeting populations more effectively? What's the path forward? Yeah.
So I'll start, Mark. I think I agree with Yaning. It's very sobering when you see things that do not correlate from phase 2 to phase 3, and you hit the nail on the head. Drug action gets harder and harder when you get into the harder disease, and in phase 3 you have more advanced disease. So I would just suggest that we're on the right track when we collect more biomarkers, especially when nothing's been approved, all the way through phase 3. I think that's a smart approach for any company that's in phase 3 for NASH, have a very extensive biomarker program, and not to assume it's one biomarker. Someone mentioned earlier that there are predictive biomarkers that enrich for NASH. You can incorporate several of those, and you actually may find that is most predictive to a NASH response.
Yes. Ajit?
I'll agree with that, and I think I'll just add one more thing, which is, in addition to having a combination of biomarkers, I think we do need to keep in mind baseline stratification, and this has been something which has been talked earlier today also. Depending on where you start, your response is going to be different depending on that. And so this is something which people have already seen with ALT, they've seen it with ProC3, so that's just something to keep in mind as we understand this data and try to interpret it.
Other thoughts? Yeah, Ruby?
Just in general, FDA has tried to enrich the population by proposing that we are going to enroll patients who have fibrosis stage 2 and 3. So that's one strategy of enriching. And then we are also encouraging a lot of adaptive trial design. And also, if the mechanism of action of drug is such that it requires enrolling certain cohort of patients, we do that. But we're very encouraging of different trial designs, innovative trial designs to move forward.
Thank you. Please go ahead.
Manal Abdul-Malik at Duke University. I think we, as a field, need to step back a little bit and reflect on these lessons learned that we've talked about. And we almost have a little bit of a circular argument going on because one has to question whether we've even designed our studies correctly from the onset, and whether we should start reflecting on especially the advanced cohort of patients with liver disease, as stability being an adequate endpoint, such that we don't see these downstream effects. But yet at the same time, when we talk with the agency about drugs that, for example, are being repurposed in the space of NASH, and we're struggling with phase 2 study designs where sample size is small, we get the guidance of a low dose escalation, whereas it would sometimes make sense to do highest dose, best tolerated in patients with repurposed drug to see if you can get the therapeutic effect at a smaller sample size. The heterogeneity of this disease is creating such challenges for us, even in designing the right trials, that defining the phenotype before we even get into the clinical study in a little bit more targeted fashion is going to be highly important for us to even be successful. We've seen now 3, 4, maybe going on 5 targets where the margin even of efficacy in the late 2-phase studies is maybe only about 10%. And that's already a fairly highly phenotyped cohort who's had biopsies as they enter these trial, and it met several inclusion-exclusion criteria. So it's plausible that once these drugs are rolled out into a very broader, more heterogeneous cohort of patients in clinical use, that the small margin of efficacy that we're seeing in clinical trials could diminish. So I think we really need to be reflective of defining the phenotype and maybe reflecting on our clinical trial designs. 1 year, even maybe 2 years, is ineffective to assess efficacy in an advanced cohort if stability is a great endpoint. So I'm concerned about the margin that we're seeing once we start really creating standard of care use.
Yeah, and just I'm following, I get the concerns about the margin, but in terms of what you're suggesting as the path forward, do you have a...
and there may be no good answer at this point for my comment until we develop the biomarkers to put the patients in different buckets phenotypically.
In those phenotypic buckets, got it. Okay. Thoughts?
I just have one comment that Dr. Kim had one example of a drug which was repurposed for, which is being repurposed for NASH trial. And one of the challenges is that sometimes we don't have adequate information on the hepatic impairment component of the drug. And in that case, we don't want to push too hard going to the maximum dose right away. So you want to start slow and then see what happens, or you want to collect the data on hepatic impairment before you go into the patient population which has already some underlying hepatic impairment. That's one thing that I do want to add.
But if in the repurposed drugs, if there is prior evidence on related hepatic impairment, hepatic impact, that
right.
is considered.
Right,
yeah.
That's what I was saying.
Yeah. Okay. Any other thoughts on that? Okay, please.
Hi, Scott Harris, Altimmune. Your comment about biomarkers and the multiplicity of pathways is quite valid. it clearly applies to distal disease where there's redundancy of pathways. I would hypothesize that the more proximal you get in the disease, for example, the best biomarker being weight loss, the better the biomarker will be. So my hypothesis would be that you get earlier into the disease, perhaps with the GLP-1s or drugs that induce weight loss, you're going to be able to see that kind of change. Could you comment on that?
I've been thinking a lot about that. If you're familiar with the paper Look Ahead, it looked at intensive lifestyle intervention, and it looked like a population that looks a lot like our NASH trials. 14% with a medical history of cardiovascular, average duration of diabetes about 7 years. They couldn't prove, they were stopped because of futility, because the ultimate outcome there was cardiovascular outcomes. It may have been too high of a hurdle. Maybe they didn't have as many patients as they needed. I think it was a 6,000 or 7,000 patient study. Don't quote me on that, but it took them 8 years to reach futility. And that was with intensive lifestyle intervention. So I do believe in weight loss. I think, you know, if there was more attention to weight, this wouldn't be an epidemic. And I also believe it's a very sensitive probe into what goes on in the liver. But in terms of a quick and easy answer to the question that you raised about its contribution to a solution, or I don't know yet. I think we have to at least factor into all of our analyses, understand it, continue to do standard of care, diet and counseling. But I don't know if it's necessarily the answer.
I think lifestyle modification is proven to fail in those cases, so I think that's off the table. But we do have classes of drugs that are emerging that could offer higher degrees of weight loss. I think the Cuban study suggested 7 to 10%. We're going to see the readout on the GLP-1 study in the spring, where they're using very high doses of semaglutide, 0.4 milligrams a day, which is about 3 times higher than the weekly dose. When you multiply it by 7, even more, maybe even 4 times. Now, there's a tolerability issue, but those patients are probably going to lose weight in that study as they have with the lower doses and weekly doses of semaglutide. I think that since the disease is, for the most part, about 80-90% of patients induced by obesity, that reversing that would have that more predictable effect, and you're treating right at the root cause of the disease, so the issue of redundancy of pathways and the multiplicity of pathways is no longer an issue.
Yeah, it's a good, interesting hypothesis.
Sounds like more evidence coming on that hypothesis too. Claudia, you had a comment too?
Yes. Yes, what I was going to say, weight loss can be a biomarker, but at the same time a confounding factor. I remember in your specific study, for instance, patients that lost more weight had a higher, almost twice, placebo response than the ones who didn't lose weight. And the problem with, yes, in the placebo arm, that's why I'm saying that it's also a confounding factor. And the problem with weight loss, and mainly in the short-term trials, is that we do not know how sustainable it is, even the drug-induced weight loss, right? So and in general,
we're going to have to. I mean, after this comment, we're going to have to move on to one more question. That's all we've got time for, unfortunately. Great
and in
topic.
general, there
Please
are
go
multiple factors. Yeah, we can continue the discussion forever, but yes, I agree with you that drugs that induce weight loss might be associated with an effect, but there are additional risk factors, and having weight loss as a biomarker, we should be careful to interpret the data correctly.
And hopefully more evidence coming. Sina, we have time for one more question if you want to go ahead.
This gets back to Naga's comment and slide where, the liver-related morbidity and mortality is primarily in the later stages of fibrosis patients. So when we talk about biomarkers, where we really have an impact clinically on patients at early stages of disease is likely on the cardiovascular and other factors. So it seems like biomarkers as endpoints really need to take into account the spectrum of the clinical impact of the disease. So I know we're focused on liver biomarkers and fibrosis and that type of thing, but it seems to me that the more important biomarkers that should be kind of non-biopsy related, and I'm coming back to non-biopsy endpoints here, really should also be targeting primarily in those early stages of fibrosis, even these cardiovascular biomarkers, if you will. Personally, I do think too that as we select these patients with higher stages of fibrosis, that we should really think about functional readouts as well, even in the early stages of drug development, because they can be helpful for early signals and dose responses and things like that. So.
Any final comments? I saw a little bit of nodding, but I think that's maybe a good comment to end this session on. Okay, so we will end it there, but we are, I think, going to continue this topic as the afternoon continues. But for right now, I'd like to thank our panelists and reactants for a really good discussion. Thank you. And we are going right into our next session, session 4, on clinical trial design and endpoint selection. So if I could have our two opening presenting speakers and our case study presentation come up for that while I do this introduction. This session is going to focus on patient and endpoint selection in clinical trials for NASH and cholestatic liver disease. So again, picking up on some of the themes we were just discussing, we're going to have two opening presentations. First is from Carol Addy, who's Chief Medical Officer at GenFit, and then next is Michael Badman, who's Senior Translational Medicine Expert at Novartis. After the two presentations, we'll have a case study presentation from Vartan Agarwal, who's Scientific Director for Digital and Precision Medicine at the Critical Path Institute. The Critical Path Institute's been a very helpful partner in developing today's event. And then we're going to have some reactant comments and open up to a broader discussion. Again, I'll be back in a little while to introduce the reactants, but right now, looking forward to hearing from Carol, so please go ahead.
Thank you, Mark. And good afternoon. I'm Carol Addy from GenFit. I want to thank the meeting organizers to be able to participate in this workshop, and I'm really benefiting a lot being relatively new to this space. I've been with GenFit for 3 months. As I pulled together these slides, it was not only good for me just to better understand elafibranor, which is GenFit's lead asset currently in phase 3 development, but I think in the context of this workshop has helped me to really think about how we're in such a rapidly evolving space. And so when I share with you the elafibranor story going back to preclinical data and bridging that data to the early clinical space, thinking that this was probably 10 or more years ago, and the decisions that GenFit made at the time during that development, and what perhaps we may have done differently in the current state, and if we were 10 years from now, what maybe we would do differently, taking together our discussions that we're having today and going forward. So elafibranor is a dual agonist of the PPAR alpha and delta receptors. This is pluripotent in terms of mechanisms of action. And so when we think about the ultimate treatment of patients with NASH, certainly some beneficial effects when we think about the hepatic specific effects, potential improvement in fibrotic indices, inflammation, antioxidant effects, but as well, and in keeping with some of the comments from our last session, thinking about the cardiovascular profile of these patients and the potential improvement in lipid parameters, glucose homeostasis parameters, and ultimately the potential for reduction in cardiovascular risk. So when GenFit sought to better understand mechanism of action in the early preclinical space, similar to now, there was no ideal preclinical model. And so GenFit sought to understand the mechanism of elafibranor in multiple preclinical models, rat and murine models that, at least to the best of our ability, predicted what we might expect to see in patients with NASH. And although the intent here is not to do a deep dive in preclinical studies, I think it is helpful to understand the story, so to speak, as we compiled and aggregated data to increase our probability of success as we went into the clinic. So this is one of the murine models that we explored, the FOSFOS model, and this, with a high-fat diet, delivers at least a histologic profile very similar to what we see in patients, and as well associated lipid abnormalities. And so after 12 weeks of high-fat diet, you can see histologically, although the size may not be great to really see the noticeable differences, what you can see at the bottom is that demonstrated improvement in NAFLD activity score, including improvement in steatosis, ballooning, inflammation, all of the histologic indices as we think about evaluating our patients in clinical trials. Of course, we also wanted to understand potential improvement in fibrosis. We thought that elafibranor, with its mechanism of action, would be primarily geared towards the leftward end of the disease spectrum, thinking about treatment of NASH and the inflammation and some of the metabolic abnormalities. But we also wanted to understand the potential for improvement in fibrosis. So here again, looking at the intervention with elafibranor and seeing reduction in collagen and TIMP1 indicative of fibrosis. So certainly encouraging in terms of the potential to impact fibrosis changes, thinking ahead into the clinic in patients with later stage disease. As I mentioned, this FOSFOS model also had an associated metabolic syndrome. So these animals were obese and had associated insulin resistance. Of course, this is important to understand because our patients with NASH primarily have an insulin resistant state. And so here we saw improvements in blood glucose and as well reductions in blood insulin, indicative of improvement in insulin sensitivity. So all lending confidence, this being one model of 4, but lending confidence that we had achieved, at least preclinically, proof of concept. Furthermore, looking at a dyslipidemic model, looking at improvements in lipid parameters, triglyceride reduction, as well as reductions in cholesterol parameters, increase in HDL, and corresponding improvement in atherosclerotic lesions. So all of this set the stage for entry into the clinic, and we embarked upon single and multiple rising dose studies, both in healthy, lean, normal body weight volunteers, and as well looking at overweight and obese individuals. Rising doses, single dose up to 300 and multiple dose up to 240 milligrams. Fortunately, based upon the mechanism of action, we had some good biomarkers to help guide us in terms of dose selection, and we were looking specifically at changes in some of the metabolic parameters, specifically triglycerides, where we saw kind of a plateau in effect right around the 80 to 100 milligram dose level. And hence that really served as the basis for our dose selection as we embarked upon our phase 2A studies, looking at a variety of individuals, whether with atherogenic dyslipidemia, abdominal obesity, or frank type 2 diabetes. Collectively, across the board, we saw improvement in plasma lipids, very much in keeping with what we had observed preclinically, as well as inflammatory marker improvement, along with improvement in liver chemistries. So all really encouraging and furthermore, we went on to explore elafibranor in a clamp study. This was a study conducted in 22 individuals with insulin resistance as defined by HOMA-IR of greater than 3 and central obesity. Looking on the left, you see reduction in endogenous glucose production indicative of improved hepatic insulin sensitivity, and on the right, improvement in glucose infusion rate indicative of improvement in peripheral insulin sensitivity. So all taken together, very encouraging in terms of engaging the target and setting the stage for the conduct of a phase 2b study in patients with NASH. Now, before initiating that study, we wanted to better understand dose selection, given that we had only evaluated 80 milligrams in our phase 2a studies. So we looked at PK-PD relationships, taking into consideration not only lipid biomarkers, but as well some of the liver biomarkers, ALT, GGT, and alkaline phosphatase, in order to understand what could we reasonably predict in terms of maximum dose response. That ended up being predicted at 118 milligrams, and that ultimately ended up being our top dose that was evaluated in our phase 2b study, that top dose being 120 milligrams. Our phase 2b study was a 1-year study in patients with NASH without cirrhosis. We evaluated 80 milligrams, 120 milligrams relative to placebo. And looking specifically, again, thinking that we would stand the greatest probability in the earlier spectrum of disease, we sought to evaluate elafibranor in resolving NASH without worsening of fibrosis. These are data that were published in Gastroenterology, just to share some of the top-line results, where we looked at intention to treat, looking at patients with more severe disease as evidenced by NAS score of 4 or greater, or with a NAS score of 4 or greater and accompanying fibrosis. And so the significance of these histologic analyses in combination with looking at, although we didn't see significant changes with regard to fibrosis, we did see a strong association such that those patients who manifested the greatest response in resolution of NASH by virtue of reduced ballooning or reduced inflammation manifested the greatest improvement in fibrosis. Our hypothesis being that perhaps the 1-year duration of this study was perhaps not sufficient for us to be able to detect meaningful changes in fibrosis. Also reassuring was what we had observed in terms of the changes in the cardiometabolic profile, again, very much in keeping with what we had observed previously in phase 2A studies and with what we had seen preclinically, with improvement in lipid profile, reduction in triglyceride, increase in HDL, and corresponding improvement in glucose parameters. This study enrolled about 40% of patients who had type 2 diabetes, so we also looked specifically at changes in hemoglobin A1C, and we saw about a half-point reduction in A1C. Again, all of these data taken together were very encouraging and served as the basis for our going forward with our ongoing phase 3 study that we are looking at 72-week data in 2020 with our histologic surrogate efficacy endpoint analysis. So I want to thank you for your attention, and I am super looking forward to the discussion that will take place for the rest of the workshop. I think that we have a lot to learn from one another, not only successes but failures, and what we can do to work together to optimize our development, particularly in the early development space. Thank you.
advance. Okay. Hello, thank you. And I'd like to thank the organizers for the opportunity to share with you some of the early clinical development data from our lead FXR agonist, tropifexor. So FXR is an attractive target for many liver diseases, thank you. It's abundantly expressed in the liver and the gut, and FXR agonism has pleiotropic effects that are important in the postprandial state. So given that we're after lunches right now. FXR agonism addresses many modes of NASH and cholestatic pathophysiology, and we're lucky that we have FGF19 or FGF15 in rodents as a biomarker of FXR activity, but it's also a metabolic regulator that feeds forward into the effect on bile acid metabolism within the liver. We're also fortunate that both NASH and PBC as indications have biomarkers linked to efficacy that we can use in proof of concept studies. So tropifexor is the most potent FXR agonist currently in the clinic. Its unique non-bile acid structure includes some unique structural elements that were designed to optimize the fit within the ligand-bind domain of FXR as shown on the right. In cell-based assays, tropifexor has subnanomolar potency. It has over 30,000-fold selectivity over other nuclear receptors, and it does not agonize the cell surface bile acid receptor, TGR5. In vivo, we very quickly saw that tropifexor potently and transiently induced a number of FXR target genes. And even from 10 years ago, we worked on developing an FGF15 assay that would allow us to do some preclinical PK/PD modeling from the get-go. We also profiled tropifexor efficacy in a number of different rodent models of disease, both NASH and cholestasis. The model that we used to choose our first in-human dose was from a rodent model involving the toxin alpha-naphtha isothiocyanate, the ANIT model. As you can see from this slide on the right, this shows picrose cirrus red staining. Tropifexor had a marked improvement in the fibrosis that occurs in this model. On the left, you can also see the effect of tropifexor on circulating markers of disease. On the top left, you can see decreases in gamma-GT. Below it, total decreases in total bile acids. And in the bottom panels, decreases in ALT and AST. What I would draw your attention to, however, is in the top middle of that panel, you see that there's a biphasic response as regards alkaline phosphatase. There is an initial decrease due to an improvement in disease activity in this model. However, at higher doses of tropifexor, FXR agonism on the alkaline phosphatase gene actually increases the production of alkaline phosphatase, and this can increase the levels that we're seeing in the circulation, thus confounding the efficacy in this model. So together with our preclinical toxicology, we used pharmacokinetics and modeling from those data to inform our first in-human dose. We used PK from multiple preclinical species together with our efficacy models, and used this together with a mechanistically based PK modeling program, Gastro Plus. And this actually predicted that our human dose would not surprisingly be very low, in fact between 40 and 130 micrograms of tropifexor daily. So when we went into our first in human, we had our starting dose set at 10 micrograms daily. We performed single ascending dose studies that went up to 3 milligrams from that 10 milligram starting dose, and we interwove both a pilot food effect study and multiple ascending doses up to 100 micrograms of tropifexor, and then subsequently we also included a cohort of volunteers with class 2 obesity plus one other factor of the metabolic syndrome, because we were cognizant that many of the indications that we were looking to address involved patients that had some degree of metabolic compromise. We wanted to make sure that PK was predictable in that obese population, and we also wanted to make sure that we weren't going to have some drastic effects on LDL cholesterol, for instance. So within the first in human, 95 subjects received at least one dose of tropifexa or matched placebo. We saw one SAE, which related to an elevation in ALT, which matched a similar AE. Pharmacokinetically, tropifexa was very well behaved. It had a predictable Tmax of about 4 hours, a half-life between 13 and 22 hours. There was approximately dose-proportional exposure in doses between 10 and 3 milligrams, and not surprisingly, given the BCS category 2 compound, nature of the compound, we saw a 60% increase in exposure with a high-fat meal, shown here on the panel on the right. Multiple dose PK also was very predictable. We saw a steady state achieved by day 4, and we had a very manageable accumulation ratio of less than 2, varying between 1.2 and 1.9 across all the subjects tested. Possibly the most important part of our first-in-human data, however, was the marker of target engagement, FGF19. We saw dose transient and dose-dependent increases in FGF19 observed between 10 micrograms and 1 milligram of tropifexa. And this actually allowed us to model, with our preclinical data and published data from OCA, the doses that we wanted to take forward into our patient studies. This being 30 micrograms for PBC and a range between 10 and 90 micrograms in NASH patients. And it also gave us confidence that we would have efficacy, and therefore we scheduled our ADME and hepatic impairment studies to run concurrently with our phase 2 campaign. So a little bit about our ADME study. We dosed a single dose of 1 milligram of 13C labeled tropifexa, so a multiple of the clinical dose, 4 male healthy volunteers, and tropifexa was well absorbed with a minimum absorption of 68%. Radioactivity from labeled tropifexa was excreted both by the fecal route, but also, importantly, through the urine. The study drug was safe and well tolerated at this dose in all 4 patients. We also saw that tropifexa was the predominant plasma component, and unchanged tropifexa comprised about 92% of total radioactivity, with 2 well understood metabolites being the other 2 peaks there on the right-hand side. As regards our hepatic impairment study, which is ongoing, we are executing an open label, single dose, parallel group study, 6 to 8 patients each of mild, moderate, and severe hepatic impairment, together with matched healthy volunteers with each cohort. We are using a single dose of 200 micrograms of tropifexa given in the fasted state, and we have allowed severe patients to be dosed after half of the mild and moderate subjects have completed the study, and we had adequate safety data. Overall, in this study, tropifexa has been well tolerated, and our initial interim analysis is showing us some very useful data as regards lack of difference in the hepatically impaired population compared to healthy volunteers. Now moving on to our proof of concept studies. Our first proof of concept study was in the indication of primary biliary cholangitis, and this was designed as an ascending dose cohort-based study, each cohort having an interim analysis and safety review at the end of each cohort. We dosed for 28 days, so 4 weeks of dosing, and then followed up for a period of a subsequent 2 months. I'll show you data here from the part 1 of the study, which includes data from 30, 60, and 90 micrograms of tropifexa. We have completed as a final cohort at 150, but that data is yet to be published. And as you can see on the panels here, we saw a dose-dependent decrease in gamma GT with tropifexa up to 90 micrograms. We view this as being a good marker of oxidative stress in this cholestatic population. Interestingly, we saw that there was a decrease in alkaline phosphatase at 30 and 60 micrograms of tropifexor. However, the response at 90 micrograms was less marked than that at 60. So our human study does very much resemble what we were seeing in our early cholestasis models in rodents. Reassuringly, however, we did see a dose-dependent decrease in ALT. This was still going down at day 28 when we stopped dosing the study drug. And you can see, I think, that the effect continues to manifest even when the study drug was withdrawn, suggesting that even with 4 weeks of treatment, there was some change in disease activity. Tropifexor overall had an acceptable safety and tolerability profile with no discontinuations due to itch or severe itch in cohorts 1 to 3, and there were no drug-related AEs related to ALT in this study. We did see some transient changes in cholesterol. In the case of PBC, actually, the cholesterol levels are somewhat different from the NASH population. In this study, we saw a decrease in total cholesterol, decrease in LDL cholesterol and HDL cholesterol, as one expects. So moving on to our study in NASH. This is our FLIGHT-FXOR study. It's an innovative, adaptively designed 3-part series. In parts A and B, tropifexor has been dosed up to 90 micrograms, and the population used was a phenotypic or biopsy-proven population. I will show you data today from our study, an interim analysis of part C. This population differs in that it is biopsy-proven NASH, and the doses used are 140 and 200 micrograms of tropifexor. The final the dosing period will be 48 weeks. However, this data that will be shown today, comes from an interim analysis taken at 12 weeks and was presented recently by Dr. Sanyal at the AASLD in Boston. So clearly with dosing of tropifexor at 140 micrograms and 200, we see a rapid and sustained decrease in ALT levels. We also see a significant decrease in gamma GT in under these conditions. Moreover, we see an important reduction in hepatic fat at week 12 by MRI. As regards safety and tolerability, up to week 12, there were more dose reduction and discontinuation events in the 200 microgram tropifexor group, and the most common AE was that of pruritus. There was some mild increase in LDL cholesterol and an expected decrease in LDL cholesterol in this study. But importantly, there was no evidence of tropifexor-induced liver injury to any of the patients dosed in NASH. So to conclude, the use of mechanistically based PK modeling benefited our early clinical development for tropifexor. Biomarker modeling from our tropifexor first in human gave us confidence of likely efficacy. The timing of the ADME and hepatic impairment studies will provide data for end of phase 2. And tropifexor shows dose-dependent biomarker efficacy, both in PBC and in NASH. And at higher doses, the FXR class effects of itch and cholesterol do become evident in patients with NASH. However, there's no evidence of tropifexor-mediated liver damage in treated NASH patients. Thank you for your attention.
Okay, I guess. Hello, everyone. My name is Varun Agarwal, and I would first of all like to thank the organizers for having me here. Today I'm going to talk about quantitative tools to inform clinical trial design. So I work for Critical Path Institute, and what Critical Path Institute is, we are a non-profit, and we form pre-competitive consortia, and we work with regulatory agencies, academia, industry, and other nonprofits to develop drug development tools. And we have, among our competencies, we have a competency in regulatory science, data acquisition, and quantitative modeling and simulation tools. And based on our experience in developing these tools, we see that there are 3 specific challenges to clinical trial design in NASH. So specifically disease diagnosis, staging, identification and validation of less invasive biomarkers, and dose finding and dose optimization for patients with varying degrees of liver diseases. And these challenges could be addressed by specific models. For example, disease progression models could help answer questions around disease staging and identification and validation of biomarkers, and PBPK models could help in dose optimization and dose finding. So in the subsequent slides, I would specifically talk about these models, their applications, some examples from literatures, and how we can leverage them for addressing questions around NASH. So specifically, using PBPK models, there is a specific need, and we have heard people talk about them, that in NASH, NAFLD, as the disease progresses, the functional mass of liver is reduced, and it can have a number of consequences on the drug. Specifically, the metabolism of the drug could be reduced. And the other thing which adds to the complication is that the translational models of NASH are not that reliable. So what it boils down to is that it's very hard to predict liver concentration of the drug just based on the systemic concentration. So what can we do? Can we use PBPK models? So first, let's understand what PBPK models are. PBPK models are these models which use the anatomic information with the physiochemical properties of the drug to basically predict the PK in specific organs. So these models are really flexible because they use drug-specific parameters and system parameters. And as you can imagine, you can change drug-specific parameters for different drugs and system-specific parameters to address different diseases. So if you have a disease, specifically, for example, NASH, in which your system parameters are messed up, you can plug in those parameters to get simulations corresponding to NASH. And one really interesting thing from PBPK models is that we can predict the concentrations which are not really measurable in clinic. So as I said, these models are flexible. We can change enzyme levels. And these PBPK models could be modified to include patient-specific characteristics, and you can get personal medicine out of that. So there are a few examples in literature demonstrating the application of PBPK models, and these are NASH-specific examples. So in this paper, these authors actually looked at the biopsies of livers, and they showed that the CYP3A levels are reduced. I think I can't really get to that. Anyway, so the rightmost bar shows that the NASH CYP levels are really reduced. So what these people did, they used a SimCYP PBPK model to predict the systemic concentration. So what they did was they changed the concentration of the enzyme levels in SimCYP and got these PK predictions for different populations. And as you can see, the red curve shows that the PK for midazolam is higher in the NASH population, which is something which you would expect. Here is another example from specifically for liver cirrhosis. And in liver cirrhosis, the different properties of the physiology is altered, the hepatic rate flow, the functional mass of liver is changed. And this is another example, and in these people developed a mathematical model to predict the concentration, the systemic concentration of the drug. So here's a simulation showing for healthy population the oral and the IV concentration, IV PK of the drug, and then they incorporated the pathophysiology of the liver cirrhosis population to predict the PK in healthy and cirrhosis population, and their predictions matched well with the experimentally observed concentrations. Using PBPK models, you can also generate population PK, and I don't really need to talk about why population PK is important, but in this paper they are showing how to use a reference drug in conjunction with the phase 1 trials in healthy population for the candidate drug to do predictions, population predictions for phase 2 and phase 3 trials. So what these people are talking about is in step 1, you use the reference drug in healthy population to get the physiochemical properties of the drug. In step 3, in step 2, you use the candidate drug in your healthy volunteers to get the physiochemical properties of the candidate drug. And then in step 3, you basically get the pathophysiological properties of the population. So this is your learning step. And then you combine all of that, the knowledge, the physiochemical property of the candidate drug and the pathophysiology to generate a virtual population, and you can do prediction of population. So in summary, PBPK models are kind of becoming quite popular, and there have been an increased number of regulatory submissions both in EMA and PBPK and in FDA. However, there are certain challenges, and the biggest of these challenges is that these models are not entirely physiological. A lot of the parameter estimates are based on empirical relationship, and applying them to a population like NASH would imply having reliable measurement of pathophysiological properties, which are difficult. Some of the other tactical problems are around the PBPK software. They're proprietary. They don't really offer that level of flexibility, and it's really hard to explore under the hood. The independent implementation of these models, devoid of any specific software, would be difficult because these models are quite large, involve several differential equations, and it would require extensive validation and verification. So changing gears a little bit, talking a little bit more about the disease progression models and how these disease progression models could address some of the questions around clinical trial design. So the first question you may naturally ask is, what is a disease progression model? So disease progression model is simply something which tracks the progression of a disease. So in the plot here, you see some clinical outcome for NASH with respect to time, and all you can do is you can just go and fit a best fit line, and then that's it, right? We are done. Well, not really, because all these patients are different from each other, and there is an unexplained variability. So this average effect would not explain what is going on with different stratified patient population. So what you do next is you start mining this unexplained variability for patient features. For example, patient feature 1, which could be age, gender, weight, or just some other genetic factor. And once you account for that, then you get this better prediction for that specific population. And you do this over and over again till you have explained all the relevant variability associated with your population. The disease progression models that so developed are really powerful, and they can be used for addressing, for stratification, population selection, and they can be combined with dropout models and drug effect models to generate clinical trial simulators. And I'll show an example of what we have done at Critical Path Institute. So far so good. How are these disease progression models helpful? So to answer that question, I'll talk about some of the things that we have done for neurodegenerative diseases. And neurodegenerative diseases are like Parkinson's and Alzheimer's. They have similar issues as we see in NASH in terms of selection of the right population, having the correct biomarker, and they suffer from the same problems, same issues with clinical trial design, as we have heard people talk about in the morning sessions. So the question is, can we optimize these trials? And that was the question that we faced, and what we did at Critical Path was we integrated data from several clinical trials to develop clinical trial simulators. And what these tools, this is a schematic of what this CTS or a clinical trial tool is. It has 3 components: a disease progression model, a trial model, and a drug effect model. So we made these CTSs for different diseases, and here is just a brief overview of the tools that we had developed. We had developed a mild to moderate Alzheimer's disease clinical trial simulator tool, and this was used by sponsors to optimize their registration trial. An early motor Parkinson's disease identification clinical trial simulator uses a TAT imaging biomarker to stratify population. And a pre-dementia model which incorporates left hippocampal volume, and it received letter of support from the EMA. And all of these tools have received some kind of regulatory approval from both the EMA and the FDA. So the thing is, now how was the tool developed? So the first thing we did before developing the tool was we looked at what are the relevant clinical outcome measures. So for example, for Alzheimer's disease, or it could be the ADAS-Cog score, or for Parkinson's disease, it could be MDS-UPDRS score. The next thing to do is then develop a mathematical model which tracks the progression of the disease in the relevant way. And to do this, you have to talk to the subject matter experts in the disease area. And the next thing is looking for different covariates. So at this step, you would need expertise from clinical pharmacology people, pharmacometricians, and so on and so forth. And then once you have all this done, you approach the industry and you curate and you acquire the data. And all of this is done in reverse. So you acquire the data, then you identify the covariates. So that's your execution. Here is an example of a CTS. I'm not sure if you can see that on the screen or not, but it has 3 components. The first is the population. So what are the different characteristics? What are the biomarkers, demographics? Then is the trial design. So is it a parallel design? Is it a delayed start? And then how many numbers of simulation you want to do? What is the desired power? And what this CTS spits out is the graphical and tabular output of results, which includes power estimate and confidence interval of power. So the question then is, what would we need to make a CTS for NASH? And I can't emphasize this more. We would need data, and significant amount of data. So we would need to inform the disease progression part, we would need longitudinal and observational and clinical trial data. And to incorporate the drug effect and the trial effect, we would need clinical trial data. And we would need at least 2 clinical trials, one to design the model, and the other to validate the model. And the reason that we have been able to do this so successfully at CPATH is because we have this huge database ranging up to 90,000 patients for a variety of diseases, and this curation has been supported or has been made instrumental by this legal document called Data Contribution Agreement, which lets the sponsor share the data with us, and the companies and sponsors are in full control of how this data would be accessed. So in summary, the clinical trial simulators and disease progression model can help optimize trial design, and to do that, and using these trial simulators, the relevant biomarkers can enter the model either as a covariate or endpoints if they're linked to a clinically relevant outcome measure. And to do this, again, reiterating, we would need extensive patient-level data. Now the question for NASH and NAFLD drug development would be, is there industry support for pre-competitive engagement? What are the existing data sets that could support quantitative solution for this? So the conclusion of my talk is that we need different tools for different contexts. PBPK models could help with dose determination. Clinical trial simulator tools could help with optimizing clinical trial design. Data sharing is really important. It could help development of tools to address clinical design questions, and the emphasis should be on promoting open science because it's easier and faster to develop tools if you work in a collaborative fashion. Thank you.
Thanks very much to all of you and Varun for that presentation. I'd like to go to our discussion with reactants now. So if you all could join us up here on stage. I'd like to introduce Dilara Japar, who's a clinical pharmacology reviewer at the Office of Clinical Pharmacology at the FDA. Lara Dimick-Santos, who's a medical officer in hepatology and nutrition team for the Division of Gastroenterology and Inborn Errors products at FDA. And then last but not least, Scott Seiler, Chief Scientific Officer at Lysum Services Incorporated. So we're going to have comments from each of them, and then for those of you here in the room and joining us online, look forward to hearing your perspectives as well. So Dilara, please go ahead. And do you need...
Hello. So I'd like to take this opportunity to really discuss the timing and design of hepatic impairment studies for drug development for NASH indication, which is one of the most common questions that we encounter as a clinical pharmacologist in FDA when we interact with industry who are developing drugs for NASH indication.
I think if you could use the remote right there.
Generally, for most of the drug development programs, ADME studies are conducted during the phase 1 trial, phase 1 development program to delineate the elimination pathway and to assess the need for hepatic or renal impairment studies, and also to inform the phase 2 trial inclusion-exclusion criteria. Once the proof of concept is established and optimal doses identified and during the phase 2 trial, then the hepatic or renal impairment studies are conducted prior to phase 3 trial to inform the inclusion criteria for phase 3 trial and broaden the population inclusion criteria. Sometimes, if the target population do not really have hepatic or renal impairment as a comorbidity, and by restricting the patients with hepatic or renal impairments during the phase 3 trial doesn't really change your target population's characteristic, those hepatic or renal impairment studies can also be conducted after the phase 3 trials once you establish your safety and efficacy with more confidence. However, this drug development paradigm for NASH indication is slightly different since our target populations do have inherent hepatic impairments and may potentially have concurrent renal impairments in the target population. Therefore, it's important to conduct these hepatic impairment studies early in the drug development program. If our target population is NASH population with cirrhosis, then it's obvious that you should conduct hepatic impairment studies before you administer your drug in patient population. If your target population is actually NASH patients without cirrhosis, because these phase 2 trials runs between 12 to 18 months, during which even the patients without any NASH patients without cirrhosis could potentially asymptomatically progress into compensated cirrhotic patient stage, it's still important to understand the PK changes in hepatic impaired patients. Therefore, it's highly recommended that you conduct your hepatic impairment studies early in the trials, hopefully before your phase 2 studies where you'll be dosing your patients in the long term, at least from 12 to 18 months in dose ranging studies. And additionally, as earlier speakers have alluded, that drug metabolism enzymes and transporters will also be may also change in the NASH population. It's important to collect some PK information in the pre-cirrhotic NASH population in phase 3 trial to see if there's any effect of different NASH stages on PK of your evaluating drug. Design of hepatic impairment studies are already covered earlier. I just wanted to touch upon two aspects that we encounter quite often. One is population. Generally, hepatic impairment studies are conducted in cirrhotic patients based on Child-Pugh scores without really specifying the etiology of the patients, without specifying how they arrived at the cirrhosis stage. But there's potentially etiology-dependent impact on the PK of the drug, especially for drugs that are excreted in the bile duct. Therefore, PK changes due to cholestatic cirrhosis may be underestimated in cirrhosis due to other etiologies, making it a little challenging to relating the result of your typical hepatic impairment study to inform the inclusion criteria for NASH population or other cholestatic diseases. And this is an unanswered question, and probably we need more data to show that etiology does affect the impact on the PK. So this is something we really should consider when we conduct hepatic impairment study for NASH or other cholestatic diseases. One more thing is when we conduct hepatic impairment study, generally the current guideline does say single dose hepatic impairment studies are adequate if the multiple dose PK can be accurately predicted for both the parent drug and the active metabolite. But if you know the evaluating drug, do you have nonlinear PK or time-dependent PK, then it's highly recommended that those hepatic impairment studies be conducted with multiple dose. And additionally, because to assess the safety profile in the target population, multiple dose PK hepatic impairment studies are highly desirable. With that, I'll conclude my talk.
Great. Thank you very much, Delora. Next is Laura.
Yeah, Delora. And then
Laura. Delora, Laura.
Laura.
There you
go. All right, so I didn't make any slides. I didn't even call into the conference call before. I apologize about that. I meant to send you an email. I was on vacation and I couldn't get my computer
That's
to work.
important too.
Well, I was trying to sign in so I could get the number, but I couldn't get it to work. But what I wanted to do just was emphasize a few points that other people have made and kind of tag on to Delora's discussion about the hepatic impairment studies. I really think we need to go beyond the requirements that are in the current guidelines for hepatic impairment studies in patients with underlying liver disease. That guidance wasn't written for patients with sick livers. That guidance was written for the rest of the world. So that it's inadequate and it's struggling to get rewritten. But in the meantime, it is really important to, as Delora pointed out, to do PK in patients without cirrhosis, with whatever underlying disease, be it NASH or PBC or PSC, to get an idea whether there is significant PK changes in the pre-cirrhotic state. And then, as Naga pointed out this morning, the Child-Pugh class is really inadequate, and it does not delineate in between patients with early Child-Pugh A and late Child-Pugh A with portal hypertension and decreased platelets and stuff. And those are totally different patients. Those need to be studied separately. And the PK says you need to get adequate number of patients in each of those subgroups. And I would recommend that you also collect MELD scores and try to have adequate number of patients in each range of MELD score, in addition to the Child-Pugh is okay as far as it goes, but it doesn't adequately describe the patients and where they are on the spectrum. So I would encourage everybody to really rethink a better way to do hepatic impairment studies in patients with underlying liver disease. And then I have one other kind of side comment that's not totally related to this conference, but it has come to my attention lately that the PK studies in patients for diabetic drugs have been including patients with abnormal liver functions up to 2 times upper limits of normal. I have no idea what upper limit of normal was being used, whether that was really, normal or one of the lab values. Probably it's a lab value. So therefore they're including a lot of patients in their baseline PK studies that have underlying liver disease, though it's probably relatively mild. It seems to me a big mistake that really the PK studies need to be done both in patients with normal livers and diabetic patients with different ranges of elevations of, and if they're done very early, then the sponsor can know and easily include more patients with NASH in their clinical trial if their PK is not affected, or if their PK is affected, they can then make adjustments for that, and so that the patients are getting dosed appropriately. That's it.
Okay, thank you. And next is Scott.
Thank you to the organizers for inviting us to participate. So I work with a group that specializes in what's known as quantitative systems pharmacology or toxicology modeling. Really, it's a mechanistic mathematical modeling, and if you've been here all day like I have, you've heard it come up a bit, and I thought this would be a great opportunity for me to give everyone a bit of a overview, ever so brief, on some of the ways in which QSP and QST modeling can help with these challenges we have in developing drugs to treat these NASH patients. So kind of at its core, really quantitative systems pharmacology, again, it's a mechanistic mathematical model or models of different disease systems, in this case, obviously, nonalcoholic steatohepatitis. And really, in NASH in particular, I think poses a really good disease state for the application of this QSP modeling due to kind of the multifactorial nature and some of the kind of myriad challenges that we've heard described throughout the day. Some of which are kind of that interconnected pathophysiology. We talked about proximal versus distal and the interaction of multiple systems in the presentation of the clinical pathways. And when you are forced to apply engineering principles and describe it mathematically, you really get down to the core of mechanistically how the components are interacting. And so how can these be applied? There are a few ways. In particular, I think one of the things that's come up over and over today is it seems that as a community, we are somewhat information limited as we're designing our clinical trials. And these QSP models provide an additional layer of information, albeit virtual. It is still useful information to support the decision making, these challenging decisions we have to make. So some of the ways that can, in particular, work is in concert with measurements. So identifying knowledge gaps with the simulations, hence identifying experiments or measurements to be made to fill those gaps, to complete our understanding, to give more confidence to those decisions. Certainly, to some extent, the models are predictive based on a wealth of clinical data typically, so that there is certainly a predictive nature that increases with each iteration of development. As more information is gathered, more is incorporated back into these models. Another important case application point here, particularly for NASH, is the interpatient variability. The heterogeneity in this particular disease population is vast, and the ability to capture some of those mechanistic and clinical differences allows you to potentially discern a responder from a non-responder, a patient who will be safe from a patient who will not be safe for a given treatment. Another important point that Dr. Agarwal just brought up is disease progression. And if you understand some of the mechanistic drivers of disease progression, you can represent that in your simulations as well. These QSP models are being, the validation is following a process similar to what has been applied for PBPK models as well. So there's something of a standard applied to them across the board, including those for NAFLD and NASH. Now, another aspect that probably useful clarification is the complexity of these QSP models. So Dr. Bergman earlier described kind of a nice, simple, mechanistic PK/PD model. Megar and Jesko have also done the same in their publications. And that you can move from something so simple, perhaps, to something fit for purpose. Dr. Bergman also described kind of a nice, smaller QSP model coming out of Pfizer. With Dr. Rieger and Musanti as the authors. You can also take it to another layer of complexity, even greater, where you're invoking the vast entirety of the pathophysiology. So not only the steatosis pathways, but the inflammation pathways, the fibrosis pathways. Realistically, what layer of complexity you use depends on the nature of your question. Sometimes you want a very complex model, sometimes you want something simple. You have to ask yourself that question. In this case, I would argue if you're trying to apply a treatment in a proximal location, be it weight loss, be it steatosis, and understand the impact on fibrosis, then you may need one of these more complex models. One example of that, again coming from our group, is what we describe as a NAFLD-SIM. So that's on a quantitative systems pharmacology. We also have another kind of companion model that focuses more on the toxicology, and that's DILI-SIM. Again, for this QSP type of modeling, at its foundation is that mechanistic mathematical model that is, all the mechanistic components are based on the existing literature, clinical data by and large, occasionally some preclinical data. And so we develop a vast array of simulated patients or simulated populations, and then we have kind of all the pathophysiology accurately represented in mathematical terms. The real important next steps are then to, of course, apply the drug and see how they might respond to treatment. So we just heard a couple descriptions about PBPK modeling. Dr. Brower described earlier how there are some unique differences in NASH patients in particular that invoke the customization / development of unique PBPK models that allow us to predict the exposure of the target, exposure of the compound at the site of the target. That could be hepatocytes, it could be stellate cells, it could be macrophages, depending on the treatment. And then, of course, we need to know the PD, right, the target engagement, and then bring that circle back around, how that target affects the underlying mechanisms and the pathways, so that ultimately we can predict the potential for injury, the potential for efficacy, and develop that information we need to make those decisions about the trial design. Just as a quick note, the classic QSP model applies variability in their development, in the development of the simulated population, looking at mechanistically variability as it's been described in the key kind of mechanistic components in the literature, pulling them together in an array of combinatorics, ultimately kind of settling on different clinical presentations, and then validating against as much clinical data as possible, both in kind of the untreated state as well as the treated state. I'll conclude with this thought, which is if you understand some of the mechanistic drivers of progression, you can as well model those. I think for NASH, there are a number of possibilities here, one of which that's emerged repeatedly is weight gain, and how the increase in adiposity substrate for de novo lipogenesis might hence contribute to steatosis and worsening of the disease. And in fact, we've been able to recapitulate such behavior. Recently presented poster showed kind of over 20 years with weight gain rates consistent with what's been reported in the literature. And you can see that with simulations, we're able to as well consistently predict changes in steatosis, NAS score, fibrosis stage. Not only does it work in kind of that forward worsening direction, but also in the opposite. So with weight loss, it was brought up earlier, kind of the confounding nature potentially of weight gain and weight loss. You can potentially use the simulations to simulate that weight loss and dissect it, if you will, from the actual pharmacologic actions of the drug. And so whilst you may have had an eager placebo group doing exactly what they should do to advance their health cause, it may be a confounding variable for us, and we can use the modeling perhaps to tease apart those two factors, so the patients benefit and we benefit. So with that, I'll conclude. Thank you.
Great, thank you. Some great comments related to the challenges of clinical trial design in this space. And we do have a few minutes for comments from those of you in the room and on joining us online. So please go to the microphones if you do have any comments. A lot was brought up. I mean, for example, Laura's comment about the need, about the existing guidance not applying to patients with different types of underlying liver disease, and the need for PK analyses in those subgroups, and wanted to connect that to some of the discussion we've had around clinical design issues supported by modeling disease progression, supported by some of the techniques that Scott just described using QSP. I'd like to hear any comments from the other speakers or panelists about the extent to which these approaches do seem like a path forward for addressing some of the costs and uncertainties with clinical trial design in this space.
I think one of the things that has really impressed me as I have gotten re-involved in the NASH space is the heterogeneity in treatment response, variability in treatment response, which in part may be due to the dynamic nature of the disease. So although we think about disease progression, we also know that there is spontaneous regression, which may in part be due to changes in body weight, but may also be due to factors that we don't totally understand. And so that was one of the things that I wanted to try to better understand in some of the modeling work. Can we better understand what those factors are that do contribute to disease regression, so that we can help better understand trial design as it may pertain to placebo response, for example?
So it's a great question. And so in theoretical terms, certainly it could be addressed. Again, at least with the type of modeling that we were describing earlier, this QSP sort of approach, if you understand mechanistically some of the hypotheses about how the interconnection may be, the microbiome, for instance, right? Something like that, the gut microbiome, and how it may be involved, you can absolutely explore those. Simulations are great for what if, asking what if and answering. I say answering, but really by developing hypotheses that then could subsequently be addressed in the experimentations with measurements. Yeah.
So it was what you said about disease regression, that patients spontaneously get better. I'm not sure that I really believe that patients spontaneously get better. I think patients get better if they lose weight, they diet, they exercise, if they're on a drug that changes their metabolism. I think what we are frequently calling spontaneous improvement is actually variability in the interpretation. It's because the kappa score for staging, kappa scores for just saying, do you have steatohepatitis or do you don't, yes or no, are good. They're 95% plus. But the kappa scores for staging fibrosis from one stage to the other are 0.6 at best. And they're lower, the lower it is. So if you're trying to stage between 1 and 2, especially if you got a 1C, your every time, even the same person restaging will stage differently 40% of the time. So I'm not sure that we really see a lot of major spontaneous improvement without some kind of intervention. And a lot of the modeling is going to be very difficult because at this point we're still basing everything on histology, and when we read the histology we're so bad at it that it causes so much confusion in the interpretation of any biomarker that we're trying to study against changes in histology. I'm not sure how to solve the problem.
Varun, does the detailed disease modeling based off a larger set of empirical data help with that? It seems like some of the same issues have come up in some of the other disease areas where you've worked.
Yeah, so it can, but again, the question is, do we have the data available? What does the data set tell us? Do we have that information in the data set? If we don't, then I'm not sure how we'll be able to build that in. So all the disease progression model that we build have to be informed by the data, and if the industry out there is willing to share that data with us, we can certainly try to do that.
I have a question for you. So when you said we need data sets, what kind of outcomes do you need? Because we have one data set now we just got on NASH to a surrogate endpoint, and we'll have another couple coming in the next couple of years. But we won't have clinical benefit outcome data for many more years, probably 4 to 5.
So the normal disease progression model, you don't really need you just need a longitudinal observational study, and we can build the disease progression model just based on that. But to really imposing a drug effect or some kind of a therapy is not really needed. So
okay, so the NASH CRN data sets might be adequate
Might be,
to be
yeah.
able for you to do that with. Does anybody here from the NIH?
Good point. So we have a couple of questions, right?
Rogelio Mosqueda, Madrigal Pharma. I have a question for the nice presentation of Dr. Addy. As you may know, there was a myriad of dual PPARs on development in the early 2000s for the treatment of diabetes, type 2 diabetes. And many of those development programs were abandoned because many of these dual PPARs had significant increases in body weight, fluid retention, congestive heart failure, the hint of potential deleterious cardiovascular profile in spite of the good metabolic effect, and also pre-tumorigenic effects. So my question is, in your program, your company has considered this potential risk-benefit assessment, and whether it's still worthwhile to explore this in a condition like NASH?
No, I think it's a terrific question, and certainly something that GenFit has considered very carefully in the development of elafibranor, because we know of the potential safety-related effects specific to the PPAR gammas, and so that was very much baked into our early development space, both preclinically as well as the early clinical studies, in order to rule out the potential for any specific PPAR gamma related activity.
And next question.
So this question is for people, for both of you, Warren and Scott Seiler. So this question is for the people who are experts in modeling, I think Varun Agarwal and Scott Schuyler. So your model is as good as the variables you put in for the construct of the model, right? So have you ever gone back in time, say for example you're in 2019 right now, and have you ever gone back in 2020 and said, 2010 and said, oh, this was a drug we studied in 2010 with this particular model. Now if we run this drug for safety or for efficacy, the results are going to be different, or are they going to be same? Do you see that evolution in your model? Does that change the results based on the construct when it has changed?
I'll go first. So this sounds a lot like repurposing of drugs. And coincidentally, yeah, there might have been some type 2 diabetes drugs that have been evaluated previously. No, but the reality is, there are a couple of ways to do it. So when you develop a model such as this, I think it's best prudent to version it. So in fact, you can do exactly that. You can kind of benchmark it against each version, because as the understanding and the not just of a given area, but the integration of all them evolve, theoretically the model should evolve as well, right? So the state of the current state of the model should reflect as best as possible what is known. And so if we knew less then, perhaps it's less predictive. But maybe in being less predictive, maybe it illuminated a knowledge gap that got us to a better understanding. So there's a bit of give and take there.
Okay, and we'd like to go to the microphone again in a minute, but let me take one from online. And Laura, this is directed to you. What MELD score range do you or FDA recommend in hepatic impairment studies among patients with cirrhosis? 6 to 12, 13, 19, 20, 24?
Well, I don't think that we've recommended one, and I'm not sure that I've seen any major amount of literature, though I've had some sponsors come in feeling that a change in MELD score of 4 or 5 would be very clinically significant. So maybe grouping them and about, for, 20, 25, 25, 30, something like that to look at. But I would encourage you to look at literature and give us a proposal if you think that's not right.
Okay, great. Thank you. Please.
Thank you. Regarding tropic factor development, in early stage you added an obese group in your first in-human study, What was the purpose of such a group, and will you recommend this group in first-in-human studies?
Yes, so we knew that we were going to develop Tropifexa in indications beyond PBC. NASH was an up-and-coming indication at that time. And so we wanted to look at a NASH-like population, including patients with class 2 obesity, plus or minus another part of the metabolic syndrome, with relatively normal ALT. Seemed like a relatively good way of introducing a NASH-like population into the first-in-human study after we had safety and biomarker data from our MAD cohorts.
Did you do imaging in it, or did you draw a conclusion from this arm, or?
No, because it was simply a 2-week dosing period, so we
too short.
Too short. We just had standard laboratory measures, biomarkers, but no imaging.
One wrap-up question, just to make sure that we haven't left any stone unturned around the endpoint selection part of this panel. Any final thoughts about endpoint selection? We have talked earlier today about the importance of linkage to clinically meaningful outcomes that matter to patients. Is that something where there are opportunities for further progress from ClinPharm tools or other methods like you've talked about today? Any other thoughts about endpoint selection in these studies?
Well, I'm very concerned with the endpoints that we've selected and that we're using now, and multiple clinical trials. So I don't want to give everybody a heart attack. We're not going to go back on, say, you can't use them, but I'm not sure that a 1-point change in fibrosis is really good. And it's a high bar to say in your surrogate that you've got to reverse fibrosis, because really the bar for the clinical outcome is just slowing progression of disease. So if we make this surrogate bar A difficult and impossible to measure, because we really can't accurately measure 1-point change, I'm not sure that we really have given the best advice for surrogate endpoints. I don't have better advice to give at this time, but I think that we all need to think together that perhaps we should be looking at bigger changes in histology that are easier to replicate and reproduce in the interim until we can validate biomarkers and get rid of histology, which would be my dream.
Thanks for the comment. I think we're going to have to leave it there for now for this session, but the next session is all about synthesis and next steps, and there will be an opportunity for comments then on these same kinds of topics. For now, I'd like to thank all of our panelists and reactants and all of you who contributed to the discussion as well. Great panel. Thank you very much. And I also want to thank you on my behalf. We're going to take a short break right now. We'll be starting up again at 4:10 with a different moderator, but I've enjoyed my time with you all today, and I too would like to thank all of those from FDA, Duke, and Critical Path who helped put together today's session. Thank you all very much, and we'll be back for the next session at 4:10.
Where what we hope to do is to go ahead and pull together all the great science that we talked about today and see what type of takeaways we can make from that. I mean, as those who have participated through the morning and early afternoon, clearly we covered quite a bit of ground. So I'd like to invite the panelists up, and what we're going to do is we're going to have the panelists go ahead and give us a couple takeaways from today. But before we actually do that, I'm going to go ahead and summarize what we heard, well, at least what I heard today, spend about 3 or 4 minutes on that, and then I'll turn it over to the panelists. I'll also introduce the panelists. You know many of these folks from earlier sessions. Clearly NASH is a public health concern affecting about 30% of the world's population. It's a pretty significant effect, right? So clearly that's the reason why we're working on this disease. There's currently no approved therapies, right? We covered that earlier in the morning. The risk of mortality increases actually with the progression of fibrosis. And so therefore, the early intervention with therapies is very important around this disease. I think if we look across challenges within drug development, it was clearly laid out that one of the primary challenges for clinical pharmacology was the fact that disease actually can alter the metabolism, pharmacokinetics, and disposition of therapies being used to treat the disease. I can imagine a larger hurdle for a clinical pharmacologist to go ahead and deal with. Likewise, it appears that there's multiple phenotypes that are associated with disease of this disease, and so therefore identifying those phenotypes and understanding how that affects therapeutic response as well as disease progression is extremely important. So there's clearly a need also for early diagnosis of patients with NASH and NAFL. There is also a need for accepted non-invasive biomarkers, which we spent a lot of time on today, and we'll dig a little bit more into that. Also, there's a need for better non-clinical models, as well as additional research in the translation of this disease. Clearly we need a better understanding of the basic pathophysiology of the disease. And this is not unusual. I mean, many therapeutic areas suffer from these needs. And so this could be a liver disease meeting, or it could be a kidney disease meeting. We'd be talking about very similar things. But there's some really nice opportunities here too. I heard very clearly from the FDA, they articulated, the fact that they wanted to work closely with the community to solve many of these problems. And I think that's really important, right? If FDA is going to help to convene some of these sessions like this and add their insight into how to move forward, I think that's a major step in moving forward in developing drugs for this disease. I also heard outlined today is really a framework on how to approach the disease from a clinical pharmacology standpoint. Looking at dose selection, drug-drug interactions, the ramifications of altered hepatic function as well as renal function. And I think that's a really good roadmap, right? I think it was said earlier that the same clinical pharmacology tools can be used, but it sounds like the staging might have to be a little bit different here with this indication. And then finally, what I'd like to do is like the audience to think about the opportunities around biomarkers. Clearly, across many of the talks, laid out the opportunity for liver injury biomarkers, fibrosis biomarkers, FXR activation, bile salt biomarkers, functional assessment of the liver, as well as imaging biomarkers for fibrosis and other approaches. So I think there's lots of opportunities out there. The real question is, how do we pull that down into a plan, a roadmap that we can go ahead then and act on? The good part is there's lots of consortia out there, right? Well, at least two, right? We talked about Litmus and we talked about Nimble. In one case using registry data, in the other case using clinical trial data to go ahead and derive fluid-based biomarkers and other outcomes for NAFL and NASH. We also know, if you go ahead and look on FDA's website for drug development tool qualification, you can see that there are some programs that are being qualified for this space, specifically some imaging biomarkers. I think what came out of the latter sessions was the fact that data sharing needs to happen. And we need to figure out mechanisms to best share data. I saw a lot of presentations today on biomarkers that were being used in drug development programs. I hope that data at some point will be shared. I know it's hard to share data from an industry standpoint, but we have to figure out mechanisms or we're never going to be able to push this space further and have the tools that we really need to cure these patients. And again, we also heard in the later sections around quantitative science tools or quantitative medicine tools. Clearly that's a way, an approach that we can go ahead and integrate all this data that we're talking about, not only the clinical data that we have, but then also new biomarker data and understanding how those biomarkers can actually be used in clinical trials. So that's my quick summary.
So clearly we've covered a lot of ground today. I said that before. I was just really amazed with how much we were able to cover in such a short time. And what I'd like to do is now turn it over to the panel here to go ahead and provide their input and their thoughts for today's session and really drive the conversation hopefully to next steps and what we can do as a stakeholder group to go ahead and figure out solutions for this disease. So let me introduce the panel. You know Dr. Abdelmalik, she was in the first session. Dr. Bergman, he was in one of the latter sessions as well. A new contestant is Frank Aninki. Can you say your last name for me? Yes, Ananil. He is the acting clinical team lead for hepatology products in the Division of Gastroenterology and Inborn Error Disease at the US FDA. We also have Mark Avigan joining us, and he's the Associate Director for the Critical Path Initiatives in the Office of Pharmacovigilance and Epidemiology at the US FDA, and Dr. Kim is rejoining us as well. So with that, I'd like to turn it over to the first panelist.
You have provided an outstanding summary so far of a very exciting and engaging day. I think as a field we should be quite proud of the interface, engagement, and collaboration between academic industry and FDA. As you've seen, I mean, we've have a highly endemic disease, but the exponential rate at which we are seeing new targets and the extensive growth with the applications to FDA and the applications to IND really lend us a very promising and future for drug development in this space. We've heard about a lot of challenges on multiple different fronts. And I think where the field is stagnating behind while we do have targets is the outstanding issues that were raised with regards to our understanding of these target engagements and the individualized nature of whether receptor proteins in the liver for any one unique target can functionally translate into variances in efficacy outcomes. And while we have a very large armamentarium, potentially of future therapeutics, the challenge from a clinical standpoint is to bridge that gap between the therapeutic armamentarium that we have in translation to the probably vast phenotypic variances in NAFLD-NASH and ultimately selecting the right targets for the right cohorts of patients, not only to optimize efficacy, but to minimize risk. We've heard about the difficulties in translating very promising targets, which for all conceptual purposes had therapeutic evidence of a therapeutic effect in animal models, and went so far to translate into phase 1 and phase 2, but ultimately fail in achieving a therapeutic efficacy endpoint in phase 3 or late phase 2, which speaks to the challenges. And it speaks to the challenges in how we choose patients for clinical trials, the phenotypes we enroll, and the heterogeneity we are putting into the treatment trials. It speaks to reflecting on the endpoints and the duration of trials, and controlling for better for confounders that can occur in the context of therapeutic trials, whether it be standard of life recommendations that are made with variances across sites, diet and exercise that varies across sites, and maybe even truncating promising drugs a little too short because we were shooting for too high a therapeutic endpoint, such as fibrosis resolution in too short an interim of time. and also reflecting on the endpoints we're using, understanding the insensitivity, not only of histology, but also of some of the biomarkers. I look forward to seeing the very rapid and evolving field of the biomarker development, because I'm convinced once we have the hopefully wet-based biomarkers, but certainly coupled with the imaging biomarkers, the ability to ascertain disease severity. But I'm also looking forward to seeing these biomarkers translate into prognostication and therapeutic responsiveness. I think once we get over that hurdle, we will move very readily into defining the appropriate therapeutic landscape for unique cohorts.
Thanks, Manel. Art?
So I guess I came up with a few different highlights, at least from my perspective as an industry clinical pharmacology person on this panel. One is the changes in PK observed with disease state. I mean, that was a clear theme throughout the day, and the need for potentially doing hepatic impairment studies early in development. So one thing that may be useful there, I'm not sure how close we would be to having a PBPK model that could really predict what would happen in this cohort of population if there's enough data to build that, but I think that would be something really helpful for us to determine the risk of hepatic impairment, not only hepatic impairment, also NASH, because it's now becoming less clear to me if hepatic impairment and NASH are going to give you the two answers, although they're intertwined. Do you need to do both to really understand? But having models that would kind of be able to quantify what's happening with transporters, what's happening with metabolic enzymes, and so you could have a prediction of what's going to happen with your compound, so you understand what kind of studies you would need to do to support it. It's perhaps that in some cases it may be sufficient to rely on a population PK approach where you go into a clinical study, you have sparse sampling, and then sometimes you can determine the effect of disease state in that manner if appropriate. So I think that's a big challenge, I think, that maybe is addressable in some amount of time. I think there's a lot of biomarker talk obviously, and obviously at some point in time we'd rather get away from doing biopsy studies and just do biomarkers, but really in the short term that's probably not feasible. But there's questions in the short term, like for example patient selection for our biopsy studies. People are going to be doing these things. How do we best leverage the information we have to best select our patient population? We need to do that as soon as possible. You don't need a validated thing, at least in my view here, because you're just trying to decrease screen fail rates and not have people do biopsies that are not necessary, for example. Then, of course, that there's the longer-term solutions of trying to, change the development paradigm. We're using more of the biomarkers than the biopsy. Also, we spend a lot of time talking about biopsy, but eventually there's going to be outcome studies. So, how do these biomarkers also relate to biopsy? Part of that will be cardiovascular as well. There's going to be all-cause mortality in here, and how do these things relate to that as well? So that's something, another challenge I think we have. In terms of modeling, we talked about QSP modeling for dose selection, for example, understanding of biology, and identifying targets, and using modeling MIDD approaches so we don't have to do studies that we don't need, and especially combination therapy. I mean, one target may not be enough to really move the needle on the disease. If you add a second target together, it may be useful, but again, it's harder to dose select when you have two NCEs together. How do we use modeling and simulation to deal with that? I think those are the main things that I'm thinking about, as we wrap up today's meeting.
Great. Thanks, Art. Frank?
Well, admittedly, I wasn't here this morning, but I looked at a lot of the documents, and I want to first congratulate INSO because she spent a lot of time putting this together. I want to present just 3 patients that I thought about in the last couple of days in preparing my remarks for the end of this conference. Sponsor Y has a drug in phase 2B that has promise in their proof of concept. And it's a 24-week study. And 3 of the patients at the end have a biopsy. The drug is dosed at 40 milligrams daily. At the end of the study, 3 patients have the following results. 1 patient improves, the second patient does not, and a third patient actually has worsening histology, but not the histology associated with NASH. The disease, in fact, is not described at all. It probably is related to some drug-mediated effect that's yet unknown. The 3 people are all 50 years of age in the same city. They are all females. They have the same medical problems. They have NASH and diabetes with hypercholesterolemia, obesity, and hypertension. The only difference among each of these women is one is an Inuit from Alaska, the other is a Hispanic woman of El Salvadorian, not of Mexican descent, and the other one is Caucasian of Scotch-Irish descent. So this discussion today that you all have, I think, and my background, although I've been with the agency for almost 2 years, some of you may know, is that I was a physician scientist for many years, and so my prism of regulatory science is a little bit different than many of my colleagues, which is unfortunate for them, I think, but and for some of you that listen to me when I talk to you in face-to-face meetings. But nonetheless, I do think that we, as people working together, need to start thinking a little bit more about the science, the hard science, and one of the things that the industry needs to be looking at is pharmacogenomics, precision medicine. Because I wonder why those 3 identical women, and there are trials that have these data, don't respond in the same way. So you can predict this in a population, but of course at the end, that phase 2B doesn't have great results. Because as you move through the hula hoops, as I like to call them, of these trials, you don't see what you see in phase 1 or phase 2. So I'm not really sure that the conventional wisdom of pharmacology is going to work for a disease like this one. Why? Because unlike diabetes, where you have hemoglobin A1C, or hypertension, where you can use a sphygmomanometer, we don't really have the best understanding, as someone who studied the liver for many years, of the liver. In fact, in many ways, I think it's like the brain. You know, there are many people in this country who are suffering from dementia and Lou Gehrig's disease and terrible new types of cerebellar degeneration. And the neurodegenerative disease space is quite unknown. It's a box. It's a black box. And I often think about the liver. It's a big organ, but we don't really have a good understanding of that. It's a kind of complex organ. So when you take a sledgehammer to try to treat a disease, of course it's going to be tough and we're going to fail. And so, you know, we can help. But I do think one of the things I would encourage you to think about is to work with really fundamental scientists. We're not fundamental scientists, we're regulatory scientists, and we have to wear hats with regulations. And there are attorneys over us, I think. But, you know, there are basic scientists that are working in this country. And the other thing I would say is that in modeling, I'm not so sure. I would agree, of course, that the models that are available to us, you know, models from animals and primates, they may not work as well, and they're certainly costly. Some of you, I think, were in Europe at a meeting with me in London, and I think that the Europeans are far ahead of us in using human tissue and human organoids and precision slices, and those kinds of things may be more effective in doing high throughput screening in looking at dose selection, even before you take it into humans, because I think that's really where we may be headed, because we have no idea, I think, some idea, but the idea of looking at a steatotic liver to handle drugs is probably something that we as scientists, physicians, pharmacologists have not been used to dealing with, because the fact is that humanity, not just in the West, but in India and China, have never been this food satisfied. And there's got to be a place to put all this energy. And one wonders whether or not these steatotic hepatocytes I often think about when I see all of your data is just, this is the natural way they're handling these new xenobiotics, because they're utilizing them. Even so, you know, whether or not these PK and hepatic impairment studies that were designed a generation ago are actually not applicable any longer simply because the biology of a normally functioning fatty liver has changed. The other thing I would point out to all of you, and I mentioned this in London, is that this is a more urgent problem in a sense of a public health issue. I'm not suggesting we treat everyone with a fatty liver by any means, but we really can't be so cavalier about thinking that we can transplant every NASH-related cirrhotic, because we simply don't have enough transplanted organs available to do that. And there are many other diseases. We were touching, I think, briefly on cholestatic diseases, but NASH is so encompassing, it's hard to get to that sometimes. But those are equally devastating diseases. Not to mention pediatric diseases, acute liver failure from accidental overdoses and the like. We just simply don't have the organs and the resources to do that. So those are some of my thoughts as I end the day, but I think that one of the things about the 3 women I was thinking about is PNPLA3 as a biomarker. I'm not suggesting that it's a great biomarker, it may be horrible, but certainly there's been a lot of molecular research by a good Howard Hughes investigator. I'm wondering whether or not that would be predictive of whether one of those 3 women had a better response than the other, and whether or not the presence of that, SNP, the SNP, made one or the other more susceptible to injury. And I'll stop.
Thanks, Frank. Mark?
Well, I'm totally intimidated by all the excellent presentations on something that I'm just trying to catch up on. But what I've heard so far is that, I guess I'm going to use the analogy of GPS. So what we really want to know is if we're in a car driving to New York, where are we in the car and how fast are we driving? So that has to do with, what about the NASH patient? Where are they in their progression and how fast are they going to a course where they need to, if they don't get an intervention, they're going to have a bad outcome. And what we're hearing is that there's people all over the highway, and from the very beginning of at the start of the drive to on a lane that goes very slowly, and other people are going very quickly. And the determinants of where you are on the GPS locator is to some extent driven by many different factors, not just one thing. One of these, of course, is primary mechanism susceptibility, which is very important. So I agree with Frank that actually is an important determinant to determine and to study and to put into the model. But there are other determinants as well. Once you're well along the way, there seems to be progression of disease and liver destruction or damage because there's already in progress a process of inflammation and fibrogenesis which seems to be self-perpetuating. So there's also, separate from the primary mechanism, as the disease progresses, there also seems to have its own tempo and ramp up. So the question then is, looking into the future, can we develop a composite of measures, which we can call them biomarkers, give them any term you want, that will determine for that patient where they are and when do they need an intervention that makes sense from the point of view of the mechanism and the strategy of treatment. It's likely that we'll either have step therapy or we'll have composite therapies. We'll have combination therapies because, as we heard, the complexity of the disease is not necessarily one nidus or one single pathway for the intervention to actually have an impact. So it's a little bit, maybe in that sense, you might use the blood pressure analogy. But we don't know yet. The second point I want to make, and this is a really important FDA lesson learned, is that biomarker responses to treatment measured by biomarker outcomes sometimes are misleading. So, and there's some great examples that are worthy of being cited. One is the CETP inhibitors, the cholesterol ester transferase, the transfer protein inhibitors, where there was a great excitement around the middle of the 2000s that these would be companion drugs to the statins to really knock down cholesterol. And the finding was very high HDLs and a lowering of LDLs. Well, that makes a lot of sense. Well, the drugs were tried in large clinical trials, and guess what? In some cases, they had terrible outcomes, including increased death, which was a surprise for the phase 3 investigators, or an increased cardiovascular event. So that didn't make sense, but it impugns that when you're perturbating a system, which is complicated, and you're attacking one thing, there's a lot of compensations going on around that you can't account for, which might be bad. So there is, no matter which way you slice the cake, there's going to be a requirement to do some kind of a bridge to outcome. So to some extent, that's part of the rationale for doing these biopsies. It would be obviously from an epidemiologist point of view, you really want to know what's the long-term result. Did people live longer? Did they live happier? And so on. So that's an important point to remember. The last point I want to make is on the domain of dosing, where we really, as a hepatologist, putting on a hepatologist hat, as liver disease progresses, different patients have different reasons why dosing requirements change. It's not always the same thing. It depends on the drug. Is it a hydrophilic drug? Is there early ascites? Is there early portal pressure change, which leads to differences in blood supply at the micro level to different lobules? For example, if there's sort of mini shunting going on in the liver because of changes in pressure, that could be very problematic for dosing, because you might get in some lobules too much drug, and then in the sister lobules next door, too little drug. So how do you manage that? Is that solvable? Is dose reduction always the name of the game? And then there are other things to be concerned about too. Patients with liver disease have low albumins. Well, is the drug protein bound? How much of it is in the free form? And you can just go down this list. There are wonderful reviews about this, written by academic pharmacists a number of years ago that are worthy of reading. So the idea of using Child-Pugh-Turcotte, or Child-Turcotte-Pugh score, whatever it's called, is a little bit like borrowing a scale that was used for clinicians at the bedside to tell the patient that, that this was their prognosis, or this is how they might do in surgery, as a tool for pharmacology, is a little bit of putting a peg in a round hole. And so I think that we do need better markers for dosing, and that's the challenge, as well as for monitoring over time as the disease progresses and knowing when to either cut out that drug or change the dose.
Thanks, Mark. And so,
okay. So I was hoping that I can be a little more optimistic after all this workshop, and then now we are optimistic. So, okay, it's a great day, and then a lot of learning. So basically, we've heard a lot about importance of the early characterization of PK, PD, and also disease model, which we still have a long way to go, but at least we have some handle on PK, PD. At least that's we can do pretty fairly, pretty thoroughly. So I think that needs to be done while the community as a whole, or as a investigator, collect more data, basic data, to really come up with the best QSP model or mechanistic understanding. I can agree more with Mark about this compensatory mechanism. Liver is pretty smart, so when you hit certain thing, it will do its best to protect itself. So there are a lot of things going on, so we have to understand that. So how do we get there? More research, I guess. So I heard today, there's good way, even with this limitation, we've heard pretty good compelling stories about rational drug development using clinical pharmacology approaches, starting from preclinical translation of the preclinical study to phase 1, and phase 1 to phase 2 and phase 3. The juries are still out there. We need to see what's coming down the road, but still, we do our best at this stage, even with some limitation. And also, just because of the very high competition and interest, we do sometimes see just too rush. The programs just jumping into phase 2B with very minimum information. I like to caution all the sponsors about it. It's basically until the drug is proven to be efficacious, it's not really efficacious, and then risk-benefit is pretty biased toward risk. So we really need to be responsible for the very safe drug development program, I was also hoping whether PBPK or other modeling approaches can help, to predict PK change in hepatic impairment patient. As I alluded early this morning, we still need some better characterization of the system. Basically, we've been pretty conveniently using the Child-Pugh score because that's what's available. But then maybe hearing from all these hepatologists, maybe we need to think a little harder, what's really needed in clinic down the road, not only for the drug development program, but also the post-marketing to make sure we do very responsible drug development program. So that's something we need to work together, throughout the whole program. Each program can contribute the data, system data, then ultimately, collectively, we may be in a better position later on. And I like to also emphasize, I hear a couple of presenters say importance of having some plan for quality data collection. We are really working on soluble biomarkers. Although it's limited, we still have to investigate, and then maybe it has some promise to improve our sensitivity, specificity of certain biomarkers. Then that will all reside on what's the quality of data. Are we not seeing the response because somehow bioanalytical assay method is so variable, or my own is good, but mine is so different from someone else's bioanalytical assay. So then I just cannot compare, and then really cannot come to the conclusion. So I think community should really think about how to resolve that issue, and also within your program, you should have some kind of plan. In terms of quality data collection, having some plan for bioanalytical assay method used in a consistent manner throughout the program. So when you compare PD or biomarker data from phase 1, phase 2, phase 3, you have some translatability and the reliability, the interpretable data comparison, based on the well-validated biomarker, bioanalytical assay method. That's one thing. And last but least, I'd like to my main takeaway from today's workshop is really collaborative learning, actually. So although I thought I may have really better answer, but still, really thought-provoking discussion, a lot of interest, this is great, to me. And it's really great to see all the interest and investment despite this complexity and difficulty in this field. So I'd like to see more of this. I did say that it's not the end of the story. Probably this is the beginning of the story. So we should really come together more often and then share the learning from our current experience. Because I do really want to thank all the presenters, industry presenters, to share their experience, even some of the failure story. That was great, and then we should do that more. And also I like to learn we like to learn more from the failed trial as well, because it's very disappointing, probably very heart aching to the sponsor who has to go through it. It hurts us too. However, there's a great lesson we can learn from the failed trial. So I'd like to see we can come together one more time, maybe many more times, to learn from the failed trial and failed program, what can be done better so we can move this field forward. Thank you.
Thank you, Ms. Zook. I'd like to thank the panel, but I'd also like to open up the microphones to the audience for any final comments or questions. And then likewise, if the panel would like to respond to any of the more insightful or controversial topics that were brought up, I think that would be great as well. I can lead off with a quick question. So where should we start? I think we have a whole list of opportunities. Where's really the low-hanging fruit where we can have some initial impact and then go ahead and move from there? Well, don't tell me I stumped the smartest panel of the day.
I think Dr. Anania's point is very provocative. As clinicians, we have seen this, and If feasible, I think a low-hanging fruit would be target-directed pharmacogenomic analyses, because that would really address many things that we are struggling with, not only as it pertains to the appropriate cohort selections for unique targets, but defining potential balance of safety, efficacy, and risk. There is no doubt that a steatotic liver is vulnerable. It's vulnerable with ischemia reperfusion. It's vulnerable with drug-induced liver injury. It's vulnerable with the increased and heightened risk of liver failure when exposed to, viral illness. And so as we work towards drug development, the enrichment of effort in pharmacogenomic programs, I think, will attenuate and optimize what we really want is the most optimal and favorable efficacy signals with the least risk potentially, and not exposing patients who wouldn't otherwise gain any benefit from being in clinical trials because they have zero opportunity for a treatment outcome to consider alternative approaches.
I just want to follow up. I hope that I didn't depress Insuk, and I didn't mean to do that. I think that this is a really very exciting time. People have to remember that you as sponsors are looking at one of the more primordial aspects of our living. I mean, you are looking at taking energy and basically happily redistributing it. And this is not a light undertaking. Of course, we don't know a lot of things. So I think this is part of doing science. I realize you work in industry, but this is how science works. So you would expect a lot of things to fail, unfortunately. I know it's painful, and financially it's painful, but this is how it works. I actually think you've made a tremendous amount of stride, and we're making a lot of stride in biomedical science, but it's going to take a lot of time. So I hope you're not depressed about it. I just say I think it's moving along, and I think there are a lot of I think the animal modeling, we didn't get to talk about that much, but I don't know that animal modeling is going to be the wave of the future for you, but I'll leave that to another discussion.
Mark.
So, thanks, wrong button. So I think that there are some things to think about just from the point of view of having been at the FDA for a while and watching drugs get approved and then labeled. And from the epidemiologist point of view, and then I'll do a molecular biologist point of view, but from the epidemiologist point of view, it's useful to develop tools and stratification schemes that are easy to then translate into practice. Because what ordinarily happens is a drug gets approved for a particular patient population defined by a protocol of enrollment, and then that just gets cut and pasted into a label. So the tools that are used to identify the target population can't be too complicated. The problem that we have is we don't really understand the real susceptibility effects that would actually totally make a difference. But it is something to bear in mind. Now the molecular biology question. So genomic polymorphisms and target effects on certain genes are clearly important. Could that be broadened to also ask about gene expression profiling in general? Because there are other determinants, such as epigenetic mechanisms, that are not hardwired as genomic, but in this space may turn out, if you come back in 100 years, to be really important. And they have to do with dietary behavior, not only of the individual who gets NASH, but also potentially their home environment and actually during in utero exposure. So I would be just cautious not to necessarily say only genomics, but it's a very important question, and I only pose it as how to actually attack it from a scientific point of view and share data that you all have.
Any other comments? Otherwise, I'll go ahead and close the session.
I'm sorry. I just wanted to raise this, at looking at metabolic disease from a broader perspective, and to build up on Frank's comment on, predictors, perhaps genomic predictors. I think we don't know of the population of people who have metabolic disease, who go on to develop cirrhosis, the question of competing risk, who dies from a cardiovascular endpoint before they develop cirrhosis. And if we had access to broad population-based information, that might help us determine, who do we need to treat early? What is treatment versus prevention? And how do we target therapy to those who are more likely to benefit? I was just thinking, because fibrosis may not be the same, but it could be the same at least for cardiac, renal, and liver. And I think from the diabetes therapies, we have seen differences, at least in terms of preventing renal failure. Do we know that we can prevent liver fibrosis? Thanks.
Great, thank you for the comments. So I'd like to go ahead and close the session. I'd like to thank the panelists as well as the experts around the room. Really appreciate your input today. And before I turn things over to Dr. Shirley Sau, I'm going to offer a few closing remarks. I need to go ahead and thank everybody, and this is from Mark. Of course, thanks to the Duke-Margolis team for pulling this all together, the CPATH team as well, and then, of course, anybody that we left off. And then, most importantly, thanks to the FDA team. I mean, without the FDA's participation with the organization of this session, I don't think it would have been as powerful as it was. So, again, I'd like to go ahead and turn the closing comments over to Shirley, and thank you.
So you took some of my comments, John Michael. So I just wanted to comment on a couple of things, and this won't take long because if you've hung on for this long, thank you, and I won't keep you much longer. But it has been a remarkable day. There are a myriad of other NASH and cholestatic liver disease workshop meetings, conferences out there. But what made today unique was our embracing of clinical pharmacology tools specifically to help drive drug development in this area. And I just want to thank everyone, including all the audience members as well, not just the speakers, the wonderful speakers and panelists who did an excellent job with the engagement and provocative discussions today, but as well engaging the audience. So you've heard from some really distinguished leaders in the field today. There's a lot of evidence-driven, thoughtful evaluations and considerations that are taking place right now every day by academicians out there and industry leaders and such. And we've identified a lot of lessons learned, some successes, and areas for improvement. And we at FDA want to continue this dialogue. We want to continue to engage and help advance this area of science to the best extent possible. I'm optimistic. Given everything we've heard today, I think we have some of the brightest minds out there working on this problem. And so I think that this won't be the last we'll hear of this. We could probably dedicate an entire workshop to modeling and QSP and all the other clinical pharmacology tools that were alluded to today. So I'm looking forward to the future. And at its very closing final remark, I really want to thank the, not just the FDA team and speakers and panelists, but the Duke-Margolis team, in particular Sarah Sheehan, and also Nicholas Harrison, and then John Michael Sawyer as well on the planning calls. You guys have been fabulous. Thank you so much for pulling this together for us. And that will be it. Enjoy your lovely rainy evening. Thank you.